Hi guys, today we are gonna be starting the revision program for internal medicine. So let's get started with cardiology, as I think this would be one topic that will make or break the rank. The very first thing that I'm gonna teach you here is a quick revision of the aspects related to the pulse. As you can see in the recording, the very first one, you can see a normal tracing, and then you can see a dichrotic notch, which happens primarily because the blood would be bouncing off against a closed aortic valve. This is what I'm saying. Like if this is the representation of the aortic valve, this is the aorta. What's going to happen is that the moment the blood goes out of the heart during systole, then some blood will obviously try to come back into the heart. It will never be given permission to come back into the heart, but the blood striking this could be responsible for this small notch, that is the dichrotic notch, and then obviously the pulse pressure will fall, which is based on the peripheral resistance. But if you see the first recording, you can see that the pulse, which are shown here, is exhibiting a relatively slow rise. The initial part is obviously due to the contraction of the left ventricle, but then you can see a relatively slow rise here. The amplitude is also lesser, and also the dichrotic notch. If you compare the two, you can see that the dichrotic notch is relatively much more smaller. So in this condition, either I can say the dichrotic notch is small, or I can say that the dichrotic notch is almost absent. Such a kind of a pulse which exhibits a very slow rise will be encountered in patients of valvular aortic stenosis. This would be technically called as anacrotic pulse. Anacrotic because the dichrotic notch is missing. An alternative term that is used to describe this pulse would be pulsus parvus et tardus. That means that the pulse would be slow rising and would be having a relatively lesser amplitude. The words are obviously interchangeable. Sometimes they can write tardus before and parvus later, but the basic point is amplitude is lesser and the rate of rise is relatively slower in the patient. But if you look at the current recording where I'm putting my pointer, you can notice that there are two peaks in the pulse during the phase of systole. And if you compare this with the pulse in which you can see two peaks, in fact, the dichrotic notch relatively looks bigger. So I can say that point number C and point number E, they both represent a twice beating pulse. The difference between the two is that in the twice beating pulse in point number C, the representation, you can notice the fact that the two peaks are found in the phase of systole, whereas in point number E, one peak is in systole, the second one is obviously in diastole, that is the dichrotic notch looks relatively bigger. So the pulse that is represented here, where the dichrotic notch looks bigger, diametrically opposite of what I said earlier, dichrotic notch is absent. The dichrotic notch looks bigger, the pulse is felt both in the phase of systole and diastole, is called as dichrotic pulse, and this would be encountered in patients of dilated cardiomyopathy. Just remember the D alphabet here, D pulse, that is dichrotic pulse, is found in dilated cardiomyopathy. It is called as a twice beating pulse and is felt by you in both the phase of systole as well as diastole. If you contrast this with the image given in point number C, you can see the fact that there would be it's a twice beating pulse. There are two peaks obviously, and both are going to be present in the phase of systole. So the pulse that is represented at point number C is the one which is technically called as pulsus bispheriens. This pulse would be characterized by sudden rise and then a fall also. This fall is because of a dynamic left ventricular outflow tract obstruction. This dynamic left outflow tract obstruction occurs in hypertrophic obstructive cardiomyopathy. So you need to remember the ABCD of pulse, that is A is anacrotic pulse, B is pulsus bispheriens, HOCM. I'll repeat the fact for this one again. I said in this condition, the pulse first exhibits a rapid rise, and then there is also a rapid fall in the phase of systole. You can see the sudden fall of the first peak. This is due to dynamic left ventricular outflow tract obstruction, which is due to asymmetrical septal hypertrophy present in HOCM in a patient. So that narrows the outlet from where the blood can exit into the aorta. The blood will anyway go out, forcibly, because hypertrophy is there in that. So the second peak is representing the residual power of the ventricle, which is ejecting blood out of the aorta. But initially you saw a dip, and the dip is of concern because suddenly the pressure is falling. That is due to obstruction. Then point number D to be remembered is collapsing pulse. Collapsing pulse also will exhibit a rapid rise and a rapid fall initially. But this collapsing pulse is the one which you usually feel in the radial artery. That is, you will raise the arm of the patient above the level of the head, and you will notice that the pulse will simply disappear. So collapsing pulse is a feature that is also called as Corrigan's pulse. And this pulse is encountered in patients who are having valvular aortic regurgitation. So I have described ABCD of pulse to you. A is anacrotic, B is Bispherian, C is collapsing, and D is dicrotic pulse. That would be found in dilated cardiomyopathy. And then I can request you to add one more A to the discussion, where I can say that the pulse will be alternatively weak and strong. Alternatively weak and strong. Such kind of a situation where you get a strong, I'm not saying normal, I'm saying strong pulse, then a weak pulse, then you can see again a strong pulse and a weak pulse. I mean, this is going to be repeated again and again. So the term that they use to describe this one is technically called as pulsus alterans. This is a feature that is encountered in patients having left ventricular failure, where the less ejection fraction of the heart would ensure the fact that the amount left behind in the ventricles would be more. So Frank Starling law will operate, and therefore the next time the pulse will be more powerful. But obviously it cannot sustain that effort because it is failing. So alphabet A is for anacrotic pulse and pulsus alterans, and alterans is for left ventricular failure. Then you also need to remember regarding irregular pulse. This is a very characteristic feature that is encountered in atrial fibrillation, which happens to be one of the leading sustained tachyarrhythmia. Then after this, you need to remember regarding a pulse which tends to disappear in the phase of inspiration, that is pulsus paradoxus. The next pulse to be remembered by you is pulsus paradoxus, which is characterized by inspiratory disappearance of the pulse. They've asked in the exam that during evaluation of pulsus paradoxus, would you advise deep inspiration or deep expiration, or would you advise the patient to go for normal breathing while you are checking the blood pressure? So it's a normal breathing to be done by the patient while you check the blood pressure, and you will notice that in the inspiration, the blood pressure of this person will fall more than 10 millimeter of mercury. In a normal person also blood pressure falls, but here it would be an exaggeration of physiology. The best example for this is obviously cardiac tamponade, where the intrapericardial pressure will over or exceed the left ventricular end diastolic pressure, and therefore the pulse tends to disappear. Then apart from cardiac tamponade, even constrictive pericarditis can be having pulsus paradoxus, though it is relatively rare written in the book. Then he can write inferior wall MI, where there is a hypotension anyway, and on inspiration the blood pressure will fall more than 10 millimeter of mercury. He can also incorporate respiratory conditions like severe COPD exacerbation or severe acute asthma in a patient. So when you are gonna read these terminologies, you have to understand that he is talking about pulsus paradoxus. Do not be under impression that pulsus paradoxus is only specific to the heart. Any condition causing hypotension, even any etiology of shock can contribute to pulsus paradoxus in a patient. Even in pregnancy, the gravid uterus can press on the IVC, and therefore the venous return will become lesser. BP would be lower, and on inspiration that part could be exaggerated, causing a pulsus paradoxus. So these are some of the pulse aspects that I want you to remember for the rhythm, irregular pulse, and pulsus paradoxus obviously having these parameters. And then the ABCD of the pulse is alterance. Then is going to be anacrotic pulse of valvular aortic stenosis. B pulse is Bispherians of hypertrophic cardiomyopathy. Collapsing pulse or Corrigan's pulse is aortic regurgitation. And D, dilated cardiomyopathy causes a dicrotic pulse, where you will notice that the pulse would be felt both in systole as well as diastole. The reflected part of the pulse component tends to become relatively bigger. The next thing that you need to revise is that they can give you with or without any history, any ECG. And whenever they're giving your ECG to you, you are supposed to basically look at the heart rate with respect to lead number 2. Always count the heart rate at least twice or more than twice. Like in this particular case, when you will start counting between the R and the R waves, I can count like at least 4 and a little more. So I can say that initially I can count about 4.5 large squares. So the heart rate of the patient will be 300 divided by the number of the large squares. And mathematically speaking, this would be something in the range of about 70 per minute, 70. But if you look at the subsequent recording, you will notice the number of the large squares between the R and R have suddenly changed, and now the heart rate of the patient will change to 100. So there's a change in the heart rate of this particular individual that is happening, and that is a fairly of concern to me, because if I practice it once again, you can see 3 large squares. and then you can count more than that. You can count about 4 and a little more than 4, that is 4.5. So the heart rate of the patient is not constant. Whenever you get an irregular RR interval, then two rhythms which are always being asked in the exam for irregular RR interval are, one is atrial fibrillation and second is multifocal atrial tachycardia. One of the hint in the question can be, if he begins the question by saying alcoholic, you obviously need to think in terms of atrial fibrillation. If he says a COPD patient, then you need to think in terms of multifocal atrial tachycardia. The differentiating feature between the two would be that in atrial fibrillation, the P wave in the patient would be missing, whereas in multifocal tachycardia, P wave of varying morphology will be noticed by you. So now let us try to scan for the P wave in the various leads. Let's start from the routine leads which are available. That is, if you start from lead 1 and go down to lead 2, it is a little difficult to appreciate the P wave of the patient. You can see some fibrillatory activity which is occurring here, and the P wave of the patient definitely looks to be absent in most of the leads. If you scan through even the inferior V5, you will notice that there is no P wave that is noticed. It's almost a flat line right before every QRS complex in the patient. So because the P wave is not appreciated, plus some fibrillatory activity is noticed here, therefore this particular ECG, the diagnosis goes in favor of atrial fibrillation. And then you need to know the protocol for management of atrial fibrillation, that is called as RACE, where R would stand for rate control. So you are going to be giving esmolol to the patient. If esmolol is not in the choices for rate control, you can even use verapamil for the patient. This is very standard. Because atrial fibrillation can trigger clot formation and cause embolic stroke, anticoagulation obviously has to be done. You need to scan the heart using a transesophageal echo as well as a transthoracic echo, and then you have to start the patient on molecule like dabigatran so that the chances of embolic stroke can be minimized. C would stand for chemical cardioversion, where you will have to give a molecule by the name of ibutylite to the patient. This is a class 3 antiarrhythmic molecule that will shut down the multiple ectopic foci in the left atria. If ibutylite is not in choices, then amiodarone. Remember, amiodarone is a broad spectrum antiarrhythmic molecule. It is used both in management of atrial fibrillation as well as in ventricular tachycardia. The last approach would be that if chemical cardioversion will fail, then the last approach would be to go ahead with electrical cardioversion for the patient. So it is RACE, which is the management for the patient. And that's a standard question that is being repeated. Either it's going to be a atrial fibrillation with irregular RR interval with absent P wave or multifocal atrial tachycardia. So let us scan another image so that we can remember this better. Well, you need to remember how to count the heart rate in the patient. The formula would be 300 divided by the number of the large squares. That would be separating the R interval of the patient. As you can see here, that the number of the large squares would be almost around 6, whereas in the inferior one you can count only 1 or maybe 2. So if you divide this, it's a piece of cake. I mean, calculating heart rate is very straightforward in the ECG. Now, if you scan through this particular ECG, make that a habit. Whenever you are giving an ECG in the exam, you always have to look at lead 2 right at the bottom for calculating the heart rate of the patient. So let's do some basic evaluation of the heart rate of the patient. Here you can count something in the range of at least 2 large squares can at least be counted, and a little, like I would say 2.5. So this would be 300 divided by 2.5, which will make it something in the range of at least, I would say, 100 to 125 per minute. So heart rate of this patient at the moment while I have counted it would be mathematically something in the range of about 125 per minute. Now let's scan a little laterally. When you move a little laterally, you will notice that the RR interval of the patient is slightly changing, because if you look here, you will notice only 2 large squares which are present, and then subsequently you can count a little more than 2, a little more than 2. So the heart rate is once again not constant. In this person, the heart rate is oscillating between 150 per minute to 125 per minute. So again, one of the highlights is that there is a irregular RR interval in the patient. If you are in doubt for regular RR interval, just minimize and just casually look from left to right and just try to subconsciously count the number of large squares present between the R and the R, and you will notice a definitive variation. Let's do this once again so that you can be sure about what I'm talking. Like in this particular case, you will notice that I can count 1, 2, a little more than 2, so a little more than 2. But if you go a little laterally, you can count only 2 large squares in the patient. So therefore, I am very sure that this is an irregular RR interval in the patient. Now, scan for the P wave. You will notice a P wave present here. Then you will notice the amplitude of this particular P wave. And if you compare it with the one that is shown previous to this one and the one that is shown even much more earlier than this one, the P wave amplitudes are definitely a little offbeat, I would say. So because the patient is having different morphologies of the P wave, therefore the diagnosis of this particular patient where P wave is anyway present, irregular RR interval with a positive P wave, but of varying morphology, should always be answered by you as multifocal atrial tachycardia. This has recently become the hot favorite of AIMS paper, as well as I can recall at least 3 consecutive papers they just asked about multifocal atrial tachycardia. This is one of the common arrhythmias that is encountered in patients of COPD. Cigarette smoking on long-term basis would contribute to damage to the heart because it will cause pulmonary arterial hypertension, damage to the ventricles also, so MAT can be triggered. For treatment of multifocal atrial tachycardia, DC shock is contraindicated. It is treating the cause. And for rhythm control in this patient, though in my case, patient's heart rate is, I would not say contributing direct threat to life, but still it is a handicap because when the heart beats faster, the person gets a constant pounding sensation in the chest. So the drug that you're going to start in this particular patient would be verapamil. So the next thing to be remembered is that multifocal atrial tachycardia will be having a presence of 3 distinct P wave morphologies with a heart rate between 100 to 125 as I showed to you. And I have shown you one more strip where actually you can notice a variation in the heart rate of the patient. And you can also notice the varying morphology of the P wave. In fact, the P wave in this case can be erroneously thought as that of P pulmonale also. Because COPD patients can be having P pulmonale. So the amplitude of the P wave in this particular case can be going more than 2.5 millimeter. So one of the errors of judgment can be that we might straight away just read COPD and thought that this he showing us a P pulmonale, like this one I would say, the P wave of the patient. Then again the morphology, the P wave is changing. So we might get the impression as if we are dealing with P pulmonale in a patient. But the change in the heart rate of the patient is the one which is of definitive interest to us. For this particular recording, you can notice the change in the heart rate of the patient. So this is still a MAT, and as I told you, in this case, the drug that we will use will be verapamil to control the rates and don't answer DC shock for the patient. Also remember the fact that for all the supraventricular tachycardias, re-entry phenomenon will play an important role. In the exam, what he has done is he is also asked about whether anticoagulation needs to be done or not need to be done in all patients who are having supraventricular tachycardias. So there's a CHAD S2 score, VSC score that I've described, where C would stand for congestive heart failure, H would stand for hypertension, A would be age of the patient, then diabetes, stroke. Stroke is given 2 points, remember. Anyway, I've said atrial fibrillation results in embolic stroke. Then is vascular disease, age and sex category being female. Alone gender female will not classify the patient as being a candidate for requirement of anticoagulation. And most of the time, the drugs that would be used would be rivaroxaban or would be dabigatran. And the right side of the table also mentions the risk of development of embolic stroke in the patient. I usually get a query lots of time regarding which type of stroke is common, embolic stroke or thrombotic stroke. Well, Harrison doesn't give a clear situation behind it, but I'll put it like this. Suppose you get a question where patient has never had any history of any kind of heart disease and suddenly stroke occurred today morning. I would think it is mainly atrial fibrillation, because atrial fibrillation can be clinically silent. There may be no symptoms in atrial fibrillation due to the high discharge of the vagus nerve, and then suddenly stroke will happen. But if he describes a patient to you who's having, let me say, known case of atherosclerosis of the internal carotid artery, or he describes regarding a person who has suffered from stroke earlier and is a big time smoker, then I can think of thrombosis in the patient as well. So embolic should be given more priority over thrombotic stroke, but then you also have to look at the data in the retrospective perspective. That is, atrial fibrillation usually does not cause any symptoms, and then boom, suddenly induces a stroke. And embolic stroke is equally devastating as a thrombotic stroke. Rather, multiple emboli can channelize into the brain circulation and can cause extensive damage as compared to thrombotic that might be limited to only one part of the brain circulation. Then remember that if atrial fibrillation is occurring with WPW syndrome, then a patient will straight away go into ventricular fibrillation. You see, why am I saying is normally in atrial fibrillation you have a AV nodal block in the patient, so the impulses would not go down and the AV node will try to protect the heart. But in a patient with WPW, you have a bundle of Kent that does not exhibit any decremental property. So all the impulses of the atrial fibrillation will straight away go into the ventricles without the decremental property of the AV node. This is going to result in atrial fibrillation to degenerate into ventricular fibrillation. The only situation where atrial fibrillation can degenerate into ventricular fibrillation is if WPW is present in a patient. Otherwise, without WPW, this kind of a situation is not possible. And this also explains the fact that why don't we nowadays use digoxin for atrial fibrillation? Because when you will give digoxin, it will inhibit the AV node. And if you inhibit the AV node, the current will preferentially go by the bundle of Kent directly into the ventricles of the patient. The function of digoxin is to block the AV node, and the current is anyway preferring to go by the bundle of Kent. So preferential conduction will cause further degeneration. So nowadays, digoxin is absolutely contraindicated in patients of atrial fibrillation, because if a person is having a bypass tract and you are not aware of it, he will degenerate very, very fast. So that's why I just kept that in the discussion primarily. And the learning at the moment is, if you ever get a question in the paper of a irregular heart rate or irregular RR interval, there are two possibilities: P wave present, P wave absent. If P wave is absent, atrial fibrillation. If it is present, it is multifocal atrial tachycardia. And for multifocal atrial tachycardia, don't answer the RACE protocol. For multifocal atrial tachycardia, don't give a DC shock also as an answer. For multifocal atrial tachycardia, it is obviously treating COPD of the patient and then using verapamil or diltiazem for rate control in the patient. Moving ahead. The next ECG that I'm going to show you is again going to be, we are going to check the heart rate at lead 2. And you will notice the fact that this time the number of the squares which are present between the R and the R interval, they look pretty decent. At least I have counted 3 times, and every time I counted, I am counting a little more than 3, something like 3.5. So I can say that the heart rate of this particular patient would be 300 divided by 3.5. That would be less than 100. So there is no tachyarrhythmia apparently present in the patient. The heart rate is stable, so it gives the impression as if there's no tachyarrhythmia. But now, if you look at these waves, these undulating waves that are present in this particular chart, these undulating waves are present before every QRS complex in a patient. These are the flutter waves, or these are the sawtooth waves. So the moment you see flutter waves present in a patient, it tells you the fact that we are talking about atrial flutter now. Atrial flutter, why it occurs is because of a macro reentrant circuit. This macro reentrant circuit is primarily focused around the cavo-tricuspid isthmus, that is the right side of the heart of the patient. And in these patients, the deterioration can be pretty quick, in a sense that the ventricular rate can be fairly fast. And therefore, though at the moment, luckily, thankfully, to vagus nerve, the heart rate is under control. So all I need to do for this particular individual of atrial flutter is I don't need to go for rate control. Here, yes, I need to go for an echo because there could be clots in the patient. But I will definitely like to go in for chemical cardioversion in this individual. In this patient, I repeat again, do not answer rate control because the heart rate is pretty stable, as it is chemical cardioversion to suppress this macro reentrant circuit in the patient, for which you will be giving ibutylate to the patient. And if it fails, then you would be giving a low intensity DC shock to the patient. The intensity of DC shock in atrial flutter is one of the lowest that you have to remember, that is 25 to 50 joules. So flutter waves are obviously going to be encountered in other leads also, and most of the time they're going to be encountered in lead number 2, 3 and AVF. Why 2, 3 AVF is because The focus here is right-sided. It is mostly located in the right atria of the patient. So 2-3 AVF are going to scan it very nicely. Though luckily in this patient, we are noticing flutter waves present even in the chest leads of the patient. If I zoom in, you can see the flutter waves in the chest leads of the patient as well. And the characteristic feature of this arrhythmia would be these abnormal looking waves, which are not to be confused with that of PSVT. Now, how to differentiate that from PSVT? Let's look at the actual ECG of PSVT that was given in the exam. This is going to be the QRS complex, which is relatively narrow. Then you can notice a ST depression. This is present almost all the time. ST depression is present in this patient. This is the QRS complex. And then there is an abnormal looking wave here. This wave is formed due to merging of the P and the T wave. This wave is not actually the P, it is formed by merging of the P because RR is becoming pretty close. If you scan the heart rate of this particular patient, it would be approximately 1.5 R squares, about 1.5 R squares, about 1.5 R squares. So heart rate in this particular ECG is 300 divided by 1.5. That would be astoundingly fast value 200 per minute. Along with this, I can notice relatively narrow QRS. Normal QRS is about 2.5 large square, that is about at least 100 milliseconds. But in this particular case, it is a notch narrower than what it should be. And then I can also notice ST segment depression in the patient. There is a definitive hidden P waves in the patient. There's a global ST segment depression. Now, if I scan through almost all the leads, you will notice ST depression in AVF, lead 3, lead 2. So ST depression is present almost everywhere in this patient, except maybe chest leads, it may not be so pronounced. But this ST depression is present because fast beating of the heart is there. There is going to be a increased in oxygen consumption. So if you get a feature of ST depression, hidden P waves, narrow QRS, and heart rate of 200, then all these basically point to PSVT, that is a paroxysmal supraventricular tachycardia, which is also called as AV nodal re-entrant tachycardia. This is an arrhythmia that occurs mainly because of the re-entry phenomenon in the heart of the patient. So for supraventricular tachycardias, there are three, basically atrial fibrillation, atrial flutter, multifocal atrial tachycardia, and a PSVT. And though I would say that PSVT is the easiest one of them to actually comprehend, but you need to keep a watch for the remaining ones also. So AV and RT, how would you manage this? For AV and RT or PSVT, if the question says how do you prevent the recurrent episodes of I would say syncopal episodes in the patient, so the best way for prevention in this particular MCQ should be answered as catheter ablation. But if that is not in the choices, then for prevention of such episodes, you will have to put the patient on a medication that is oral verapamil. Earlier, I was using verapamil for ventricular rate control in multifocal atrial tachycardia. Now I'm using the same molecule in PSVT for preventive aspects. But if he says patient is having an acute episode of PSVT, then I think everybody knows that this would be carotid sinus massage in the patient. Then would be, if carotid massage is anyway a time buying procedure, you will have to go for chemical cardioversion. And if chemical cardioversion will fail, then you will anyway have to go for electrical cardioversion in the patient. So that is the sequence. Carotid sinus massage is given with a thumb perpendicular to the angle of the jaw. It activates the glossopharyngeal nerve, which in turn will be activating the vagus nerve, and vagus nerve would then be innervating the heart, and it will control the ventricular rate of the patient. If he says which nerve innervates the carotid sinus, it is the glossopharyngeal nerve, not the vagus. Adenosine is the preferred drug for management of these patients. This has a side effect of bronchospasm, short-limited bronchospasm that can definitely freak out the patient for a while, but it is short-limited, so no worries. And DC shock would be given if adenosine will fail. So that would be 200 joules biphasic that would be used for management of this particular patient. But if in the question he says that it's a crashing patient, like he describes a unrecordable blood pressure situation. He says patient was brought in a syncopal episode, BP at the moment is 70 by 50, 80 by 60. then it is straight away cardioversion DC shock. Don't waste your time using drugs on a patient in whom the BP is unrecordable. So then you will have to go in for a cardioversion in the patient. So at the moment, I have discussed with you aspects related to couple of supraventricular tachycardias, and you can also see the movement you give adenosine. We can practice once more. The heart rate of this patient would be something in the range of 150, 2 large squares. There is a relatively narrow QRS that can be visualized once again. You can notice the ST segment depression. I'll just draw that before you. This is the S wave. Now I'm going to highlight before you the ST segment depression of the patient, and then you can see a wave which is formed by the merging of the other normal waves, that is the P and the T waves. So a very clear cut, I can show that again to you. I think you would relate to this better if I use proper colors to just incorporate harmony in the diagram. You can see the ST segment depression coming up, then this wave that is formed by the merging of the P and the T, and obviously prior to this you can see the narrow QRS of the patient, and the movement patient was given adenosine. You can see that the heart rate of the patient is stabilizing, and now you can see a P wave coming up, then you can see a QRS complex. So as normal sinus rhythm is coming up in the patient, NSR is being established, so at least some sense of normalcy in the ACG is coming when you're giving a shot of adenosine for the patient, and this would definitely be the dramatic response to adenosine, and even for DC shock again the same normalcy would be obtained in the ACG of the patient. The aspects to be remembered by you are for supraventricular tachycardias. The parameters to be remembered are like this. For atrial fibrillation, the highlight will be absence of the P wave, and the RR of the patient will be variable. For multifocal atrial tachycardia, P wave will be there. It would be of varying size, and RR of the patient will be variable. RR can be variable even in atrial flutter. That is not that in atrial flutter you cannot have a variable RR interval. Most of the time we usually get a fixed pattern, a fixed AV block in the patient with a sawtooth. And for PSVT, where you will notice that the patient will be having hidden P wave, and along with hidden P wave there would be ST segment depression and a narrow QRS in the patient. Narrow QRS is a feature in all of them, but especially in PSVT it becomes very pronounced. So there are 4 SVTs that I want you to remember, and they're simple and straightforward to work up. Treatment for atrial fibrillation and atrial flutter is the same. Both of them are treated by the RACE protocol. For PSVT, I've already explained on the previous slide. For MAT also I've explained we don't give DC shock and we treat with verapamil. That is to control the ventricular rate perspective only. Otherwise, we have to treat the COPD component of the patient. Now, this ECG can definitely be given to you without any history. So let's go through the ECG slowly. The first thing that you do anywhere is look at the heart rate of the patient. So this time the long lead 2 is not given, so no problems. I will use the one of the inferior leads for it. First try to count the large squares which you can read comfortably. Like in this case you can see a little more than 6 large squares can be read by you. So I would say that the heart rate of this patient would be 600 divided by 6.5, which would make it something in the range of less than 50 beats per minute. So heart rate is not very encouraging, rather it is bradycardia coming in. So first impression of mine is they could be heart blocks in the patient. Then what you will do is you will calculate the axis. To calculate the axis, this is what you will do. You will on the x-axis plot lead 1, and on the y-axis you will plot the data for lead number AVF. This is the plus and the minuses that I have highlighted. You will notice that in this particular person's ECG, the QRS complex of the patient is really big and S is really very small. So I will say that the vector of R minus S here is positive. Why? Because R is taller than S. But if you look at the AVF data of this person, you will notice the fact that in the AVF, this S wave is relatively more deeper than the R, which is almost very small. So if I subtract R minus S, this time the vector is negative. So let us plot the positive vector of lead 1 and the negative vector of lead number AVF And if I just join them together, you will notice the vector is pointing in the superiormost quadrant. That would be left axis deviation. So this particular patient's ECG is having a bradycardia with left axis deviation. Now I will have to see whether there's a normal sinus rhythm or not. So you can again use lead 1, 2 or 3 for establishing normal sinus rhythm. Like you can definitely see a very beautiful P wave scene with a normal PR interval and then a QRS complex in the patient. Though the T wave in this case shows a little bit of inversion, which I am wondering could be due to various reasons. Even lead 3 is showing a T wave inversion present here in this particular patient, and that's definitely could be due to myocardial ischemia that could be present in the patient. One of the important causes of T wave inversion that you have to keep in mind if you encounter any question on that would be unstable angina, non-ST elevation MI, and hypokalemia. So I'm keeping my options open at the moment. This person is having bradycardia, left axis deviation, T wave visualized inversion in lead number 2 and 3. Now, as I scan through the augmented leads of the patient, you will notice that a very peculiar thing is occurring here, that when the R wave is going up, it is showing a slight change in slope. When I looked at it for the first time, I thought that maybe I was not seeing very clearly, but now I think when I zoom in, you can see there is a change in the slope of the upswing of the R wave. That is definitely not normal. That's definitely not normal. So what I'm thinking is, could this be delta wave? And yes, precisely, this looks like a delta wave, but let's scan a little more so that we are a little more confident for the delta. When I go through the chest leads of the patient, you will notice that the R to S progression is occurring. Like you see that in lead number V1, R is relatively small, S is deeper. Then you will notice that R is becoming bigger as compared to S, and then the R height has definitely increased more than that of the S. In this particular case, you are definitely noticing abnormality in the upswing of the R wave almost all the time. So this change in the slope is the one that is bringing me closer to the diagnosis of this patient, that is delta wave present. Now we know that delta wave is a very characteristic feature of WPW syndrome. So even if history is not given the question of sudden cardiac death and palpitations, syncopal attacks, you should be in a position to pick it up on the basis of the change in the upswing of the R wave of the patient, which is very particularly highlighted in some of the leads. If WPW is present in a patient, we all know that the treatment of choice would be RFA, that is radiofrequency ablation. If the question says, how do you handle an acute episode of WPW, like he is presented right now with palpitations and dizziness, then for acute episode, the drug of choice is procainamide. But if the question says, how would you prevent the episode from occurring, then for prevention, the drug of choice for the patient would be remembered by you as flecainide. I repeat my situation again. If he says DOC for acute management, it is procainamide for WPW. But if he says prevention of episode, it is flecainide. Ideally, we can burn the bundle of Kent and the problem of the patient can be circumvented. And WPW is also written in multiple choice questions as accessory pathway mediated tachycardia. The conduction in WPW by the accessory pathway can be antegrade forward or can be retrograde also. AP mediated tachycardia. In some questions, he might use the word orthodromic and antidromic. So orthodromic, if you just go by the word ortho in Hindi would be ulta. So here there's a retrograde conduction via the bundle of Kent of the patient, whereas antegrade conduction would be antidromic conduction. So orthodromic is reverse conduction via the bundle of Kent. Why I am worried about this is because normally in our heart all the pathways are antegrade conducting, and if there is a reverse conduction via Kent, that would mean that there would be a re-entry phenomenon in the patient, and the re-entry phenomenon can trigger an arrhythmia in the patient. Normally, the current of our ventricles will not go up into the atria. See what I'm saying here? Current of ventricles will go up into the atria. That's re-entry phenomenon for you, and therefore supraventricular tachycardia can be triggered in WPW syndrome patients. The highlight is anyway delta, and then orthodromic is reverse, antidromic is antegrade A, antidromic A, antegrade conduction can occur. The importance of knowing that would only be that this conduction can contribute to the variation in the duration of QRS interval, and most probably, I would say importantly, trigger tachyarrhythmias in the patient. Coming to the next slide, I have once again highlighted before you the delta wave that is very characteristic for WPW. Related MCQ to be remembered is delta wave on EEG is definitely normal, that is found on NREM stage 3. And delta wave in ECG is obviously abnormal. And if you look at the second figure, you can see the Osborne wave, which would be found in patients of hypothermia. This was asked in the January NEET 2019 MCQs. And another cause for Osborne wave is hypercalcemia. So abnormalities of the QRS complex can be revised here. I have spoken about narrow QRS. Then I have shown an abnormality in the upswing of the QRS complex, that is especially the R wave, that is delta. Then I have highlighted regarding abnormality at the end of the QRS complex, that is Osborne wave. And lastly, I can mention regarding a wide complex QRS. And I can also mention a M pattern in the peak of the QRS complex. So narrow QRS is a feature that would be encountered with supraventricular tachycardias. Delta waves are WPW. Osborne is hypothermia. Wide complex QRS could be premature ventricular contractions or ventricular tachycardia or torsades de pointes, which I'll explain in the subsequent slides to you. And if you get a peak like this of a M peak, M pattern in the peak of the R wave, then this could be a feature that could be encountered due to intermyocyte conduction in bundle branch block. If this is highlighted most of the time in V5, V6, if this is present mainly in V5, V6, it indicates person is having left bundle branch block. And if the same pattern may be elicited in as a deep S wave or a broad dominant S wave, in lead number V1, V2, then it could indicate a right bundle branch block in a patient. So intramyocyte conduction can definitely represent or could be related to M wave in the peak of the R wave. The M wave I'm saying is because of the M pattern that would be seen in these patients due to intramyocyte conduction. Now, if you look at the next ECG, you will notice that the patient is having a heart rate of only about a little more than 1.5 Lard squares. So 300 divided by 1.5 Lard squares, this would make up a heart rate of something in the range of 200 per minute. And the patient is having a broad complex tachycardia, really broad complex tachycardia. As you can see, it's all spread out. So considering the broad complex tachycardia occurring in the patient, this goes in favor of a monomorphic ventricular tachycardia. The final diagnosis of this ECG would be given as monomorphic VT in a patient. For management of this monomorphic VT, because most of the time the BP would be unrecordable in the patient, so we will have to give a DC shock. Also notice a very characteristic finding in this person where you can see in the downswing of the R, you can see this slight shelf pattern, and then obviously the ECG would continue down. You can see this slight shelf pattern occurring here, and then obviously the ECG is continuing down as a S. So this that I've tried to show here before you is referred as Josephson sign, which is encountered in patients of ventricular tachycardia. And one of my students who sat for NEET 2019, he told me categorically that he could appreciate the Josephson sign very well. So monomorphic ventricular tachycardia, Josephson sign are rather features which are going to make the diagnosis very easy for you. Broad complex QRS. When I'm describing this, I have had a lot of queries from students saying, why are you not calling it ventricular flutter? You see, ventricular flutter will have a very more I would say characteristic sinusoidal pattern like this. Now, I would not traditionally call what I'm showing right now to you as a sinusoidal pattern, because this is definitely having some abnormalities when the current is moving in the ventricles of the patient. So it's not a very characteristic sinusoidal pattern that you normally expect to see. But if I was getting a characteristic sinusoidal pattern, then we will use the word ventricular flutter. The only difference is that very fast monomorphic ventricular tachycardia is called as ventricular flutter, where the Josephson sign and the other intermyocyte conduction aberrations that show up in the ECG are usually missing. For management of this particular patient, because the BP would be unrecordable, so it is obviously a non-synchronized DC shock. In fact, only two MCQs where answer is non-synchronized DC shock is ventricular tachycardia, pulseless, and ventricular fibrillation. However, I will say if the person is having a stable VT, then the drug that we use for stable ventricular tachycardia would be amiodarone. And if he specifies the word post-myocardial infarction ventricular tachycardia, then the drug of choice for the patient should be remembered as lignocaine. So drug treatments are anywhere to be remembered. Plus, since they have asked about these aspects, both there was a question on both PSVT and VT in 2019 NEET. So I think it's a good idea to remember this information. Moving on to the next ECG. In this one, you will again notice that the heart rate of the patient is about 1.5 L square. The heart rate of this particular patient, and then you are noticing he is also going into ventricular fibrillation in between. So heart rate of this patient in the leads that are highlighted would be something in the range of again 200 per minute. The rhythm is degenerating very soon into ventricular fibrillation, and it's I would say disaster situation for this guy, because he's gonna deteriorate very fast. But why I have shown this ECG to you is to highlight that the size of the broad QRS complex of the patient is not the same. All the broad QRS complexes which are highlighted here may not be of the same size or the caliber in the patient. Because of this variation that I have shown before you, of the height of the QRS complex varying, I would say that this would go in favor of a diagnosis of TDP, that is Torsades de Pointes. He is gonna deteriorate into ventricular fibrillation very soon, but polymorphic VT is the diagnosis in this case. Again, because if the BP is unrecordable, it is a non-synchronized DC shock. And if the BP is recordable in the patient, then it is magnesium sulfate, which is to be given for management of this particular patient. The image is showing a polymorphic VT, which could be related to electrolyte imbalance or a cardiac event that might have occurred in the patient. So maybe from the Holter, this strip was obtained in the patient. The next image is showing a classical ventricular fibrillation. You can see that there is a uniform twitching all over. When ventricular fibrillation is occurring in the patient, the first thing to be given to any patient would be chest compressions, and then you need to give DC shock to the patient. They have given a situation of a ventricular fibrillation or pulseless ventricular tachycardia, and they've asked what is the first step to be done. Then chest compressions have to be given at a rate of 100 to 120 per minute. I mean, every 1 second doctor has to give 2 chest compressions, and 1 cycle would be for 2 minutes. If there is no return of spontaneous circulation, you will again have to give 2 minutes of chest compression and then give DC shock in the patient. So the basic point is defibrillation has to be done in the patient. If he says what is the treatment of choice, it is obviously a defibrillation. But one DC shock may not cause improvement, so you will have to repeat the shock in the patient. And if there is no return of spontaneous circulation, it means that he could have straight away now gone into cardiac arrest also. So if there is a cardiac arrest in the patient, then you obviously need to give epinephrine to the patient. And this is a broad protocol because it could be ventricular fibrillation, it could be VT, it could be cardiac arrest in the patient. So remember that in this protocol, he is not talking only about possibility of ventricular fibrillation, but he's saying that you straight away have to anyway ensure the fact that at least 3 shocks are given to the patient. If it is a ventricular tachycardia or a ventricular fibrillation, adrenaline used in case of the fact that the patient is having asystole. Amiodarone is definitely included in the resuscitation protocol, and he has asked that what is the best drug used in the emergency tray for post-resuscitation arrhythmia. Then amiodarone is used for post-resuscitation arrhythmia. And by this time, you would have stratified him into whether he's having a ventricular tachycardia, whether he's having asystole or a pulseless electrical activity. Pulseless electrical activity is like even tension pneumothorax. No patient will be having a presence of beating heart. The electrical activity is there, but there is no pulse in a patient. So usually in the exam, the pulseless electrical activity that they have asked is related to respiratory system. One of them to be definitely remembered is tension pneumothorax, where the positive pressure in the chest will crush the superior vena cava, inferior vena cava, resulting in crushing of the blood pressure of the patient. So obstructive shock will occur in the patient. So pulse will not be there, but the heart electrical activity is very much there in the patient. Then specific treatments like lignocaine, procainamide for ventricular tachycardia, and if it is sinusoidal VT, that is ventricular flutter I was talking about, then it could be hyperkalemia, and that has to be managed by giving insulin drip to the patient. So these are obviously specific treatments in the flow chart, but the minimum I want you to remember is that in any patient of ventricular fibrillation, you have to give overall a patient total of 3 shocks given in the protocol, and if it is asystole, then obviously you need to give adrenaline to the patient to restart the heart of the patient. And if there is no return of spontaneous circulation, in spite of all the things that I mentioned here, then the drug to be answered is amiodarone, and this is mainly VT, which will present in this fashion. And if it is not controlled by 3 DC shocks in the patient, then survival of the patient will definitely be relatively lesser. I repeat my statement, ideally if the BP is recordable, straight away give amiodarone, but here it is the resuscitation protocol that is being talked about here, that unrecordable BP was elicited by you, and then you are managing the patient, and there is no improvement in the condition of the patient, so you have to follow the steps and give amiodarone as a last resort, and then you will obviously call it quits and explain to the relatives that sorry, we could not do much for the patient. So for patients who are having bradycardia, I'll discuss separately. There's a separate algorithm for it. ROSC means return of spontaneous circulation, but this is one flowchart that I want you to keep in your mind. That is chest compressions, defibrillation, again chest compression, a repeat shock in a patient, total 3 DC shocks in ventricular fibrillation or ventricular tachycardia. Coming to the next ECG, which is being shown to you, you will notice that the heart rate of the patient is constant. It is about 2 large squares. It is still 2 large squares, and it is still 2 large squares. So the heart rate is pretty constant. There is a tachycardia, no doubt about it. That is 150 per minute, but the heart rate of the patient is stable. One thing very characteristic about this ECG is that the amplitude of the height of the QRS complex is changing. The QRS complex is very small versus what looks like normal, again a relatively smaller one versus one that looks relatively normal. So this time what is happening is that right away in the exam, I mean, you don't even have to go to step 3 or step 4. No, most of the time when you're looking at lead 2 or V6, wherever, you will notice that findings will be given there only. You don't need to scan the whole ECG. That can obviously has to be done. What I'm saying is most of the time in the exam, it's a spot diagnosis. So in this case, it is the amplitude of the QRS complex that is variable this time. Remember, earlier I was teaching you P wave is having a variable amplitude, but now it is an amplitude of QRS that is variable in the patient. So for this variable QRS complex amplitude, for the diagnosis of the patient, we will call it electrical alternance. This is a feature that is seen in pericardial effusion and is encountered in cardiac tamponade in the patient. We can scan through the remaining ECG also, and you will notice that if you look at the depth of the S and then the subsequent one, depth of S here and the depth of the S, the subsequent one, they're definitely not equal in size. So the amplitude is definitely varying for the QRS complex of the patient. Even the depth of the S wave serially, like if you look at the first S wave, the next S wave, it's definitely not equal. We can scan once again, Here you can notice. So because of this variation in the amplitude, the diagnosis is electrical alternance, pericardial effusion, and if it is associated with pulsus paradoxus, we might have to go in for a pericardiocentesis for management of this particular patient. The X-ray of this patient is also showing an increased cardiothoracic ratio. Then it is also showing what is referred classically as a water bottle heart, or is also referred to as a money bag appearance. So pericardial effusion, a water bottle, a money bag appearance is very, very classical. If money bag, water bottle, electrical alternance, if these kind of discrepancies are given to you in the question, your answer is always pericardial effusion. But if any of these facts that I have just discussed with you or the previous ECG is given in the question, any mentions regarding pulsus paradoxus also, then obviously the dimension of the MCQ changes and the answer should be given as cardiac tamponade. So don't straight away answer money bag as cardiac tamponade. It is pericardial effusion. you must have pulsus paradoxus written in the question for diagnosis as cardiac tamponade in the patient. Patient or pulsus paradoxus would be having an unrecordable blood pressure. One of the very easy ways to diagnose pulsus paradoxus, even if not given in the question, is cardiac tamponade can be very easily diagnosed by these three words: muffled heart sounds, elevated JVP, and hypotension. What they wanted to see was that are you able to pick up cardiac tamponade in the question 1, and are you able to differentiate it from a condition called as tension pneumothorax, where you can see that once the air will go into the chest due to the breach of the chest wall, the whole lung will collapse and the pressure in the chest cavity will turn positive, and this pressure will crush the filling of blood in the great veins of the heart. So the patient will develop obstructive shock, the BP will crash. In tension pneumothorax, you can see in the diagram, both patients will be pulseless. Cardiac tamponade patient is pulseless. Tension pneumothorax patient is pulseless. He has asked in the exam, how do you differentiate between the two? So the main differentiation is based on the basis of breath sounds. Breath sounds will always be heard in patients who are having cardiac tamponade, but breath sounds will not be heard in patients who are having tension pneumothorax. Over this particular area, there will be no breath sound because there is no lung. The lung has been crushed by the air at the positive pressure. So the question said, which of the following is best to differentiate tamponade from tension pneumothorax? That would be breath sounds in the patient. For tension pneumothorax as described here, we will obviously go for a needle decompression. You will have to deploy a wide bore needle in the second intercostal space of the patient, that would be in the midclavicular line, so that you can decompress the system and the air compression of the heart will become lesser. But if it is cardiac tamponade worked out by you in the question, then you will have to go for a Zephyr-Sternal approach, and you will have to perform a pericardiocentesis in the patient. This pericardiocentesis will ease off the pressure on the ventricular cavity, and the blood pressure and the filling of blood in the heart will definitely pick up. Once you've revised the diseases of the outside of the heart, then we need to scan another ECG. Okay guys, next we shall be revising regarding the ECG patterns which could be given to you with respect to electrolyte abnormalities. Like if you look at this current pattern, you will realize the fact that the heart rate of the patient is to the tune of a little less than 100 per minute. So there is no tachycardia in the patient. Then if you look at the QRS complex is really broad. I mean, that's a very striking feature that you can encounter in the ECG. And there is also a M pattern that can be noticed in most of the leads, including from the chest leads. I can make out the fact that there is a presence of a bundle branch block pattern. That would be a M pattern deciphered. That tells you that there must be some conduction defect in the patient, or there could be an electrolyte imbalance. Then I'm looking for the P wave. So let's start. There is no P wave noticed in lead 1. There is no P wave in lead 2. There is no P wave in lead 3. Neither in the augmented leads, neither in the chest leads. P wave is not present. Now this is a very surprising ECG. There is no tachyarrhythmia. There is not even a bradycardia, but the P wave is missing in the patient. QRS is broad. So all this is telling you that there is a problem with the electrolyte in the patient. And then when you look at the chest leads of the patient, you will notice these tall tented T waves present in the patient. The vertical height of the T wave can be approximately always less than 10 millimeter, but in this case you are getting very big T waves in the patient with a slight ST segment elevation as well. So because of the fact I'm saying this ST elevation, because you can see this ST elevation coming up, which is merging with the T wave in fact. So I am noticing a ST elevation, I'm noticing a tall T wave in the patient, which is breaching the height of almost 10 millimeter. All of these point to the fact that the patient is having an electrolyte abnormality by the name of hyperkalemia. Hyperkalemia, the characteristic feature is always a tall T wave. There is a ST elevation also present, and the highlight of hyperkalemia is that the P wave will become shorter and shorter and will tend to disappear, and there would be a broad QRS. And later on, if we don't treat this person, the patient's QRS complex will become relatively broader, and then there would be a presence of what is called as a sine wave pattern in the patient. And finally, the heart of the patient will stop in diastole. Acute hyperkalemia can be managed in the following fashion. We can just quickly revise the management of acute hyperkalemia and chronic hyperkalemia. In fact, chronic is also not to be neglected. Like they can give you a case of CKD and they can mention regarding long-standing hyperkalemia in the patient. The drug that is recommended nowadays for chronic hyperkalemia is patiromer. Another new drug that is given is sodium zirconate. And the third drug that we will use is obviously the potassium binding resin, that is K-bind. This resin can be given in the form of enema or tablet form to the patient. This will take care of the dangerous hyperkalemia. The resin would be polystyrene sulfonate, that is a sodium or a calcium polystyrene sulfonate in the patient. This would help in chelating to the potassium and helping in control of the values of potassium in especially CKD patients. For acute hyperkalemia, the first line management is calcium gluconate. I'm deliberately writing calcium chloride because he might write calcium chloride also. Yes, we give calcium chloride. Yes, we give calcium gluconate. In fact, calcium chloride is more efficacious in neutralizing the dangerous effect of hyperkalemia as compared to calcium gluconate, but we never give calcium carbonate. Calcium carbonate is the oral form that we have in tablet of shell cal, so that is not used. Then insulin will be causing the fastest entry of potassium into the cells, about 0.5 to 1 milliequivalents per hour. After insulin drip, we can also give to the patient salbutamol that will potentiate the effect of insulin drip, and the fall would be, as I said, 0.5 to 1 milliequivalent per hour. The fourth thing that we will do is give Lasix to the patient of furosemide. This would cause caliuria and a loss of potassium in the urine of the patient. So I'm kicking out the calcium which is more in the blood. If these strategies are not working, I will be using hemodialysis in the patient. And then they have asked what is not effective for management of the patient. Then they have asked what is not routinely used in medical management of patients who are having a dangerous hyperkalemia. The answer should be given as soda bicarbonate. There is no metabolic acidosis currently described, so therefore there is no role of soda bicarbonate for management of these patients. So these are the drugs for hyperkalemia, and the ECG findings very characteristic to be remembered. Tall titer T wave everybody will remember. You just need to remember the amount, that is magnitude more than 10 millimeter in vertical size in the chest leads of the patient, and in the limb leads the T wave height should be more than 5 millimeter of the patient. Coming to the next ECG, which is again related to electrolytes, they can ask you regarding hypokalemia, and they have also both in the theory part as well as in the image based part. For the hypokalemia component 1, remember it can trigger of arrhythmia, which is by the name of torsades de pointes, which is also called as polymorphic ventricular tachycardia. If you go look at the ECG of this particular patient on the extreme right hand side in the chest leads, it has suddenly deteriorated. The ECG is showing presence of a broad complex tachycardia. And at the same time, the amplitude of all of these is not the same. The amplitude of each one of them is changing. As a result of it, I'm going to call it polymorphic ventricular tachycardia, which is triggered by hypokalemia. Now let's scan for the ECG findings of hypokalemia in this particular ECG. You can definitely appreciate the QRS complex of the patient, which is followed by a slight upsloping ST segment depression, I would say. This is the upsloping ST segment depression, and a normal duration QRS, a normal duration P wave. So P wave and the PR interval looks okay to me, but there is some ST segment depression. Then I can notice a U wave. The U wave is like this. The yellow that I highlighted is the T wave inversion of the patient, and the one that I'm highlighting now is the U wave of the patient. You will notice this once again. If I just zoom out slightly, you will notice the U wave once again. This is the U wave, and just prior to that is the inverted T wave of the patient. So what I can see in this particular patient's ECG is a ST segment depression. I can notice is a T wave inversion that is in color yellow. And then I've also highlighted a prominent U wave in the ECG patient. In fact, it will give you a biphasic pattern of the T wave. It will look like a biphasic pattern of the T wave, like T wave is going down then going up. But that's not a T wave that's going up. It's actually a U wave. So prominent U wave is being noticed in the ECG of the patient, especially in lead number 2. If we can practice this once more, the prominent U wave thing, even in lead number AVF, this you can appreciate is the P wave before the QRS complex. Here the QRS complex is showing a bundle branch block pattern also. That's a feature that can be seen with any electrolyte imbalance or bundle branch block pattern can be seen. And prior to this that I have shown before you is the U wave of the patient. This is the U wave. And prior to this would be the T wave inversion of the patient. So I think you can relate to the hypokalemia component relatively better. Hypokalemia can also contribute to death like hyperkalemia can. The cause of death in hypokalemia would be diaphragmatic paralysis in the patient. We need to give a potassium drip to the patient. The rise of potassium in the blood that you need to achieve on a priority basis by today evening. If you admit the patient, let me say yesterday evening, by today evening, within 24 hours, the target is about 3 milliequivalent per liter is to be achieved in a 24-hour period. This is the target value that you need to achieve. Now, how will you achieve this target value in the blood is by giving 200 milliequivalent. You have to give potassium chloride to the patient. Every 200 milliequivalents of potassium chloride will cause a rise in the blood potassium of approximately 1 milliequivalents per liter. I said for every 200 milliequivalents KCl that is given to the patient, the blood potassium will rise by approximately 1 milliequivalents per liter. Based on this, I can say the fact that suppose if in the exam he says that the actual potassium value of the patient is 2.3 milliequivalents, then I need to upgrade him to at least 3 so that the chances of diaphragmatic paralysis are minimized. The blood value has to be upgraded by at least 0.7 milliequivalents. If I go by mathematics, 200 milliequivalents of potassium chloride given to the patient will cause blood values to rise by 1. So for 0.7 milliequivalent rise, I need to give approximately 140 milliequivalents of KCl. Pure mathematics here. I repeat the mathematics once again. First, remember, we don't increase straight away to 3.5. 3 to 3.5 is via oral. But raising up to 3 is definitely the one that is our objective on a priority basis. So suppose this was 2.1, I would have upgraded by 0.9. If it is 2.3, 0.7 milliequivalent upgrade in the blood. And to do that, you have to give KCl to the patient, that is via a peripheral line or a center line. So mathematically speaking, this would be 140 milliequivalents of KCl to be given to the patient. The highlights of this slide are, you need to remember the one of the arrhythmias that can be triggered. You have to remember how to give potassium correction. And one of the highlights of the ECG finding of this patient would be a presence of a prominent U wave and a T wave inversion in the patient. That is totally opposite of the ECG findings that were discussed with respect to hyperkalemia. So both hypo and hyperkalemia have to be remembered. Once again, I have shown a slide to you where you can see a definitive increase in the height of the T wave. That would be a tall tented T wave developing in this particular individual. The QRS complex would definitely also broaden out and will merge with this tall T wave of the patient. The P waves will become subsequently small or indiscernible P waves. So remember, in hyperkalemia, the T goes up and the P becomes relatively smaller. The opposite is for hypokalemia. In hypokalemia, what happens is that the height of the T wave keeps on reducing, and then the T wave inversion would come in. This T wave inversion will be associated with ST depression and a prominent U wave. So U waves are found in ECG of normal also, normal person also. So I've written the word prominent U waves in the patient, or I'll just put a plus sign to highlight the prominent U wave of the patient. And then another very characteristic finding of hypokalemia and has been asked is that the height of the P wave will increase. This increase in the height of the P wave is called as pseudo P pulmonal. Meaning of the word pseudo P pulmonal will be that the P wave vertical height will be more than 2.5 millimeter in the absence of pulmonary artery hypertension in the patient. Pseudo P pulmonal is a characteristic finding of hypokalemia, whereas P pulmonal is a finding that is encountered in patients who are having pulmonary artery hypertension. So the vertical height of the P will become absent in hyperkalemia and the vertical height of the P wave will increase in hypokalemia. You can try to remember one of them, like in hyperkalemia, T is bigger, P is smaller. Here it is opposite. The T will be smaller and the P will increase in size. Treatment of choice for hyperkalemia I've explained to you is MCQ wise the first line drug or the DOC is calcium gluconate, otherwise insulin causes maximum fall, calcium does not cause a fall, and for hyperkalemia KCL would be given achieving a target of 3 in the next 24 hours. So these are the aspects with respect to the ECGs and the rhythms that I have spoken before you. And then subsequently, just to take the pressure off before we talk about bradyarrhythmias, I'll incorporate the concepts of cardiomyopathy before you. And the current diagram shows a banana-shaped cavity of the left ventricle. It highlights HOCM, hypertrophic obstructive cardiomyopathy, which will be having a presence of asymmetrical septal hypertrophy. Another feature that you encounter in hypertrophic obstructive cardiomyopathy is left ventricular outflow tract obstruction. Why I'm saying that? Have a look at the diagram. If you look at this outlet of the left ventricle, that is the blood when it has to go towards the aortic valve. You can see the red is the aortic valve and the blood has to go towards the aortic valve. This outlet is the one which will decide the ejection of blood into the aorta. If the volume of blood in the ventricular cavity is lesser in this particular patient, then this gap will be lesser. That will increase the gradient and the murmur will become relatively louder in the patient. What I want to highlight is that traditionally speaking, all murmurs will decrease on Valsalva, or all murmurs will decrease with standing. Why they decrease with standing is because on standing the venous return to the heart will reduce. The exception is HOCM. Why? Because in hypertrophic obstructive cardiomyopathy, if less blood will come in the left ventricle, then the gap between this free wall of the aorta and the septum will reduce. The LVOT will reduce due to less volume of blood, and therefore if the gap will reduce, the gradient will tend to increase, and due to the increase of the gradient, the murmur intensity will also tend to rise. So I want you to remember that all murmurs will become softer with Valsalva, standing and amyl nitrate. Why? Because less blood will come in the heart, so softer murmurs. Exception is always HOCM. Why HOCM is the exception is what I've tried to highlight in this diagram, that if the volume of blood in the ventricular cavity is lesser, then this outflow tract obstruction is increased and the gradient also increases. Whereas if there is more volume of blood in the left ventricle, then this LVOTO will become lesser and the blood will be easily able to flow out. Remember, the murmur of HOCM will always behave opposite of the murmur of standard cardiology conditions. In fact, if you can remember these two statements, you would be able to solve the common sense questions. The logic is that all murmurs decrease with Valsalva, with standing, and with amyl nitrate inhalation, because they all cause a decrease in the venous return of the heart. The exception is to hypertrophic obstructive cardiomyopathy murmur, that will become relatively louder, and mitral valve prolapse murmur, that will become relatively longer. In contrast, opposite of this can be remembered. All murmurs will increase with squatting and hand grip, except HOCM, which will behave opposite. The HOCM murmur of the patient will become relatively softer, and the mitral valve prolapse murmur will become relatively shorter. The English words are the ones which can be introducing error. Louder versus longer, or softer versus shorter, so errors of judgment can be there. And the previous diagram that I had shown before you highlights the fact that why this is going to behave opposite, because the main determinant of HOCM gradient is not going to be the narrowing of the aortic valve. Everything is present below the aortic valve of the patient, so we call it subvalvular aortic stenosis, and the volume of blood decides this gradient, or the volume of blood decides how much blood can inject into the aorta of the patient. So these maneuvers will affect a cardiomyopathy patient, obviously. Then if he gives you slides with the dilated heart or with the stiff heart, you should be able to pick up, because what you can see here is a very erratic arrangement of the myocytes. One is an erratic arrangement. Then this erratic arrangement is also called as Wold pattern. There is a relative increase in the thickness of the myocytes, which are arranged in a abnormal fashion, erratic fashion of arrangement. This is a feature that is seen with hypertrophic obstructive cardiomyopathy. On the other hand, in the middle slide, you can see multinucleated myocytes. These multinucleated myocytes, cardiac myocytes, are also having damage. Like some of these are having less eosinophilic staining because they're damaged myocytes as compared to the other ones. And then you can notice a myeloid deposition between the myocytes. This is gonna be RCM, restrictive cardiomyopathy, multinucleated myocytes for dilated cardiomyopathy, and the road pattern is for hypertrophic obstructive cardiomyopathy. Mainly HOCM is an example of diastolic malfunction. There can be sudden cardiac death in hypertrophic obstructive cardiomyopathy. It is one of the most common cardiomyopathies that is seen overall. The commonest cardiomyopathy is not DCM, it is hypertrophic obstructive cardiomyopathy. And for management of these patients, drug-wise we give propranolol, and treatment choices implantable cardioverter defibrillator. The pulse that we encounter in HOCM is called as pulsus bispherians. Whereas in dilated cardiomyopathy, the pulse that would be present would be dicrotic pulse. And patients who are having DCM, because the ventricles are dilated, these patients would be always having a functional MR and a functional TR, which will obviously contribute to the pulmonary edema and enlarged liver in the patient. But this functional MR will also result in a pansystolic murmur to develop in a patient. So the murmur that is seen in hypertrophic obstructive cardiomyopathy is called as a ejection systolic murmur, that is due to left ventricular outflow tract obstruction. But mitral regurgitation will result in a pansystolic murmur occurring in a patient. Restrictive cardiomyopathy will always be having a stiff heart. The special features of restrictive cardiomyopathy would be presence of a Kussmaul sign. There can even be presence of square root wave sign on a cardiac catheterization in patients who are having restrictive cardiomyopathy. This square root wave sign will be same as that observed in constrictive pericarditis. The findings would be same, but in this condition, there will be no mention of any pericardial shudder. Rather, the heart sounds which can be mentioned in this particular condition can be third heart sound and the fourth heart sound. The reason for third heart sound in this condition would be that the ventricles of the patient are relatively stiffer. So in these patients, and the auscultatory finding of this patient will be that there will be no pericardial shudder, but there will definitely be a presence of a fourth heart sound that can be easily appreciated in this patient, because the ventricles will have to generate more force to push blood into the stiff ventricles of the patient. The best way to diagnose this condition would be either a cardiac MRI, or instead of cardiac MRI, we can go in for an endomyocardial biopsy in the patient. So they can mix up the clinical features of these with the slide. So therefore, these differences should definitely be known to you. Arrhythmogenic right ventricular dysplasia is a new type of cardiomyopathy that can be given in the question. I'll just mention the clinical details of ARVD as well. Arrhythmogenic right ventricular dysplasia is a disease of the desmosomes. This is a new cardiomyopathy given in the textbook, so that's why. And is characterized by fatty deposition in the heart. Very surprising, because normally we read about fat deposition in the liver, but fibrofatty deposition in the heart is a feature of arrhythmogenic right ventricular dysplasia. And one of the characteristic ECG findings of ARVD will be epsilon wave, which might look like a Osborn wave to you initially, but it will be having this relatively M kind of a pattern or a notch that is present at the starting of the ST segment. This is very characteristic and is called as epsilon wave. If epsilon wave is encountered by you, even an asymptomatic patient or a person with history of sudden death in the sibling, then this particular patient should also be taken as a candidate for implantable cardioverter defibrillation, because the usual presentation of this would be the patient might be having at the moment no symptoms, but sudden cardiac death in the sibling history can definitely be given in arrhythmogenic right ventricular dysplasia. So epsilon is one of the main reasons I want you to remember. A related MCQ which should be remembered here is a heart favorite of our examiners, Brugada syndrome. This is a sodium channel defect, SCN5A defect. And what happens in this person is also a history of sudden cardiac death in a brother or a sister. You will notice a ST elevation definitely present in this patient. This would be called as a cove pattern, COVE, a cove pattern of ST segment elevation, which would be associated with the T wave inversion in the patient. So I have highlighted ST elevation of MI obviously, but this ST elevation cove pattern is very characteristic for Brugada. And the treatment of choice for Brugada, because sudden cardiac death will also occur, is implantable cardioverter defibrillator. Arrhythmogenic right ventricular dysplasia is classified as a cardiomyopathy, but Brugada is only a channel defect. Heart might be structurally normal in this case, but even in this condition, due to channel defect, the inward current of the heart is defective. Short circuit in the heart can occur, and therefore the possibility of mortality in these patients will definitely be increased. Sudden cardiac death is present in both of them. Okay, coming to the next ECG, which can be given to you especially for bradyarrhythmias, you will always notice that there will be a straight line that will indicate the fact that there is definitely a presence of a heart block in the patient. So whenever you identify any area where there's a heart block, which I'm gonna refer also as missed beat. Why? Because the ventricles really did not contract at this point of time. Whenever you get a question on a missed beat, always look at the PR interval after the missed beat and the PR interval before the missed beat, and you are seeing here that both of them are equal. So whenever the PR interval after and before is equal, the diagnosis of yours will always be Mobert's 2 heart block. Instead of traditionally starting with first degree heart block, I've deliberately shown you a ECG of Mobert's 2 heart block in a patient, because that's the one that is one frequently asked. And secondly, I would say the fact that your diagnostic skill is mainly based on the fact that instead of going like this, that is, you count the PR interval the first time, and then you counted the second time, and then you counted the third time, and then the fourth time. It is a good idea to actually count it only twice, that is once before and after, and then you will be able to identify Mobert's 2 heart block in a patient. Coming to the next one, you can see that you can identify the P wave in the patient, but after that the PR interval of the patient is fairly prolonged. The PR interval of this patient is spanning almost I would say more than 5 small squares, or almost going up to 6 small squares. So because the PR interval of this patient is in excess of 200 milliseconds, the PR interval is again in excess of more than 200 milliseconds in a patient. So therefore, in this particular case, we will say that the patient is having a first degree heart block. Why a first degree heart block and why not a second degree heart block is because there is no area where there's a missed beat in the patient. That is, every P is followed by a QRS complex. So at least the normal sinus rhythm is maintained in this patient. So the diagnosis of this particular ECG is a first degree heart block, which is due to damage to the conduction system between the SA node and the AV node of the patient. In some questions, instead of giving you single strip, they might give you a complete ECG. And I'll just zoom into lead 2 so that how would you pick it up? You will notice that after a couple of QRS complexes, there is one flat area, which is the area of the scheduled missed beat. That is, the QRS complex is missing here. So I'm going to look at the PR interval after, and I'm going to look at the PR interval before. And you will notice the fact that this time the PR interval that is before and after is not equal. It is a huge disparity between the two. So because the PR interval before and after is unequal, it indicates the fact that the patient is having a presence of a Mobert's 1 heart block, which is traditionally called as Wenckebach phenomenon. Instead of going the traditional fashion of counting the PR interval serially, what I have done in this patient is that I have tried to straight away look at the PR interval before and after, though obviously you can go the traditional way also, but there is a significant increase in the duration of the PR interval of this patient, and then there is a missed beat followed by unequal PR interval of the patient. This is the area of the missed beat, and the disparity is in the PR interval before and after. So that is what I mean by the word unequal. Let's now look at all of them in a single sheet. First degree heart block will always be having a presence of a prolonged PR interval, no drop beats. In Mobert's 1 heart block, the PR interval will serially increase. So the PR interval after and the PR interval before is unequal, and this is the area of the missed beat. Again, an area of the missed beat, the PR interval before and after, however, in this case is equal. So Mobert's 2. Then is 2:1 block, which is very commonly misdiagnosed by most people as a third degree heart block. The aspect in the ECG of this one is that for every one non-conducted P wave, this is the non-conducted P wave in the patient, you can see that at least one P wave is getting conducted down, that is a QRS complex is coming. So 2:1 block basically means for every alternative P wave which would be conducted downwards, or one would be bouncing off the AV node of the patient. In comparison with the third degree heart block, you always have to realize that the QRS complex will always be relatively broad when it comes to a third degree heart block in a patient. This is because the heart is operating on bundle of His, and bundle of His fires at a rate of only 40. Then the patient will be having no correlation between the P wave and the QRS complexes. The PR interval will also be very significantly increased, unlike the superior one where you will notice that the PR interval looks normal. The PR interval is increased, there's a broad QRS, and the PP and the RR interval will never match. Normally the PP and the RR interval will always match. So let me count the RR interval for this guy. Huge number of squares. And if you look at the PP interval of this patient, then the PP interval of this patient is not equal. So there is no matching between the PP and the RR interval, a prolonged PR interval, broad QRS. That should make you think in terms of a third degree heart block in the patient, especially if we can give you a scenario of a mother having SLE and a baby being born to her with bradycardia. Then you know that the question is regarding anti-Rho antibody that can be having a transplacental transfer and can result in a third degree heart block in the patient. Mainly, I want you to remember that 2:1 block should not be misdiagnosed as a third degree heart block. That's the usual error that can come. So you obviously need to be wary for it. And one of the best ways, is just look at the QRS complex of the patient duration, and then look at the PR interval also, which would be significantly increased in patients of third degree heart block, whereas that would not be the case in a patient having a 2:1 block, that is a second degree AV block. For management of a bradyarrhythmia, the cutoff is heart rate less than 60. Though some guidelines are mentioning even heart rate less than 50 per minute, but I would like you to in the exam answer as less than 60 per minute for symptomatic bradycardia. That's what is the usual norm. Then, is the bradyarrhythmia causing any symptoms in the patient, like there is a hypotension, there is altered perfusion of the brain, there is a acute heart failure? So under perfusion of tissues is the concept here, that is the person having symptoms? I mean, how do I know symptoms are there? Perfusion of tissues will be less. The first line management for such a patient would be to give atropine to the patient. Other alternative molecules which are available are dopamine and epinephrine. So remember, alternative molecules are atropine, dopamine, epinephrine. Even isoproterenol can be used. If it is ineffective, then we will go in for TCP, that is transcutaneous pacing. And if transcutaneous pacing also will not work, then we will go in for a TVP, that is a transvenous pacemaker. So 3 drugs are to be remembered, that is atropine, dopamine, and most of the time in MCQs, isoproterenol can also be given, or epinephrine can be given. And then TCP and TVP are molecules that can be used for management of this patient. Epinephrine is obviously the one which is given in the protocol, but isoproterenol is also used. In the next slide, we will talk about a question that has come on aortic dissection. I want you to remember that the leading cause of aortic dissection is hypertension. Do not answer as Marfan syndrome. Yes, Marfan syndrome will be one of the contributory factors for aortic dissection. A lot of patients of Marfan syndrome will die due to aortic dissection. But 70% cases of aortic dissection are due to high blood pressure. Other causes can be like cystic medial necrosis, which will again damage the blood vessel. Or he can mention syphilis, that can damage the arch of the aorta and even the ascending aorta. In aortic dissection, there would be a very severe chest pain, which may or may not be described by the patient as the tearing chest pain. But the location of pain will not be in the front of the chest, it would be in the interscapular area. So that's a very characteristic feature, chest pain in interscapular area. Then depending on the progression of the tear, it could either be an antegrade progression of the tear or can be a retrograde progression. The antegrade progression of the tear can involve the internal carotid artery. So there can be neurological features like Horner syndrome or even hemiplegia written in the question. And when it comes to retrograde tear, the retrograde extension of the tear can go towards or into the coronary artery of the patient, and therefore the patient will be having a coronary artery dissection. Coronary artery dissection will result in development of type 1 myocardial infarction in the patient. We do not do thrombolysis in coronary artery dissection in the patient. The investigational choice for aortic dissection is big controversy. I'm quoting Harrison. He mentions transesophageal echocardiography for hemodynamically unstable patients. If patient is hemodynamically stable, CT chest or a MRI of the aorta can definitely be done. And one of the characteristic findings that you can encounter with a CT or a MRI chest can be what is shown in this image, what has been asked in the exam, that is a tennis ball configuration. The reason for this tennis ball configuration or appearance is secondary to the intimal flap that would be developing in this particular condition. And for management of these patients, since current diagram is showing anterior, because this is anterior posterior, this person is having a type A, that is a ascending aorta is involved, so type A aortic dissection. For type A dissection, it is straight away a surgical management. There is no role of medical management for patients having a type A dissection, so we will not answer drugs. But when it comes to type B aortic dissection, which you can see now, you can see this tennis ball appearance in the intimal flap in the descending aorta of the patient. This image basically represents type B aortic dissection. In those circumstances, depending on the stability of the blood pressure of the patient, like if I say blood pressure is unrecordable in the patient versus I would say that the BP of the patient is normal to low, so I can divide it into two parts. If the person is hemodynamically unstable to the level that he may not survive, we'll anyway have to go for surgery. But if it is normal to low, then we can go for conservative management. We can be using short-acting beta blocker to reduce the propagation of the tear, because when you slow down the heart rate of the patient, then the progression of the tear will reduce. Some patients might rather be answered as having a very high blood pressure. This is due to peripheral vasoconstriction, and that will put more stress on the heart, and the tear will again increase. So labetalol will be used because it is alpha plus beta blocker. So there can be three scenarios given for this particular patient, and obviously drugs are to be answered for a low blood pressure and a high blood pressure. But even if it is unrecordable, then surgical management will be done. This is the pulmonary artery bifurcation that is represented here. The pulmonary artery is getting distributed to the lung tissues, and anterior to that would be the ascending aorta of the patient. So two blood vessels should definitely be identified by you in any CT chest that is given. And aortic dissection is anyway an important topic. Coming to the next one, the history may not be given in the question as is the pattern in needs, but you should be able to scan the ECG and identify the problems in the patient. So let's do some calculations here. Let's do a heart rate evaluation. In this particular patient, I can count about approximately 5 large squares, a little more than 5. So the heart rate of the patient will be usually slightly less than 60 per minute. So there's a bradycardia. Then I will look at the axis for lead 1 and lead AVF. Let's look at the vector for lead 1. The vector for lead 1 is R minus S. R is very tall and S is very small or negligent, so R minus S is positive. And in AVF, you can again see the fact, I'm just plotting for lead 1. And then for AVF, I would say that R and S are almost of equal size, or R minus S vector is 0. So therefore, in this particular patient, the vector is falling in the normal quadrant of the patient. So this is normal axis. Then we will look at presence of normal sinus rhythm. So we can start from lead 1. P wave is there, very much there, 3 small squares. Then is the PR interval of the patient, that is about 3 to 5 small squares. So PR interval looks okay. Then the QRS complex duration is also fine. That is about 2 to 2.5 small squares. But there is a definitive ST segment elevation that can be elicited in the patient, which is emerging in fact with the T. ST segment elevation is being noticed in this particular individual in lead 1 as well as in lead 2. A definitive ST segment elevation can be elicited. If that is the case, I will also scan through the augmented leads in which I do not see very significant changes. But yes, when I come to the chest leads of the patient, I can notice a ST depression. I have just highlighted the ST depression before you. That is V1, V2, V3, and V4 are showing ST segment depression in this particular patient. At least V1, V2, V3 are showing a ST depression. So one possibility can be that this patient is having a non-ST elevation MI of the anterior wall. But then in this particular question, he has also given you recordings of V7, V8, V9. That is, that he has in this particular recording itself taken the tracings of V7, V8, V9, and V7, V8, V9 are showing a ST segment elevation. When you get a ECG which is like this, that you are having a ST elevation present in V7, V8, V9, and you are having a ST depression present in V1 to V3, then we call it reciprocal changes. So in this particular patient, the diagnosis will not be non-ST elevation MI of the anterior wall. The diagnosis of the patient would be posterior wall myocardial infarction, because two things are given together in this question. That is a ST depression in the chest leads, V1, V2, V3, and V7, V8, V9 are showing ST elevation. If both things are given together in any multiple choice question or in any image based question, this would be called as reciprocal changes, and this would be posterior wall myocardial infarction. He can give you this ECG and ask you which blood vessels would be involved. So for posterior wall MI, the blood vessel that would be involved would be the posterior descending artery in the patient. Let's quickly revise in this particular case the various types of MI. So first we'll talk about types of MI and then infarct localization. For types of MI, you should be knowing that type 1 myocardial infarction would be occurring in situations where there is a coronary artery thrombosis due to atherosclerotic events. But there can be a coronary artery dissection also, like there is a retrograde extension of the tear. So basically, atherosclerotic events are responsible for type A or type 1 myocardial infarction. When it comes to type 2 myocardial infarction in a patient, this could be due to, let me say, drugs like cocaine abuse in a party, or there could be severe anemia which could be contributing to decrease in oxyhemoglobin deficiency or carbon monoxide poisoning. You can see that in point number 2, or I would say type 2 MI, there is no atherosclerotic based causes. It is mostly non-atherosclerotic based causes which are responsible. In type 3 myocardial infarction, patient came to the hospital, ECG was done, cardiac biomarkers were done, but then you notice that unfortunately the patient expired, usually due to a tachyarrhythmia, ventricular fibrillation, so sudden cardiac death. Type 4A myocardial infarction will occur on the cath lab, in the cath lab during a percutaneous coronary intervention in the patient, whereas type 4B myocardial infarction will occur mainly when the patient is having an older generation stent, that is latent stent thrombosis. You see, stent is made up of after all metal only, and then it would be coated with immunomodulatory drugs, but then the stents can also have thrombosis because it's a foreign material in the blood vessel. Type 5 MI will occur primarily during CABG, that is coronary artery bypass grafting. That's a disaster because there is bleeding, and during the bleeding in the intraoperating field, the CTVS guy got panicked and he clamped the aortic sinus. If you clamp the aortic sinus, then the blood supply of the left main coronary artery is gone and the patient is dying on the table per se. Or I can say when you put sutures in the artery, the suture is a foreign material that can trigger a MI in the patient. Type 5 MI will be having a 10 times elevation of tropi. Whereas when it comes to type 4A myocardial infarction, it is associated with 5 times elevation of the value of cardiac troponin I. 5 times elevation is seen in type 4A MI and 10 times elevation in type 5 myocardial infarction. After remembering the types of MI, we are going to quickly look at which blood vessel blockage will cause which type of MI. If the patient is having left LAD blockage, then the findings will be mainly seen in 1 AVL, V1 to V4. I'll talk about the major important ones only. If the patient is having right coronary artery blockage, then the findings will be found only in lead number 2, lead number 3, and lead number AVF. If you are gonna get posterior descending artery blockage, that is a posterior wall MI, you will be having ST depression in the chest leads of the patient and ST elevation in the special leads, that is V7, V8 and V9. Suppose in the paper he gives you ST depression only in V1 to V4 and there is no findings of ST elevation in V7, V9, then this is a LAD infarct, but the diagnosis in this case would be non-ST elevation MI of the anterior wall of the patient. On the other hand, if the left circumflex artery would be involved, the findings would be seen in 1 AVL, V5, V6. The key is V5, V6 because V5, V6 deal with the lateral surface of the heart. At least two aspects which are must know for you are either inferior wall myocardial infarction, which is gonna be lead 2, 3 AVF, and then I want you to remember non-STEMI of the anterior wall, which can also be given to you. So infarct localization is obviously must, and apart from that, types of MI should be remembered. Coming to the next slide, the next data to be remembered is biomarkers for MI. The best biomarker for myocardial infarction is obviously troponin I. But if he says early biomarker, that is which will rise the earliest, then earliest is heart fatty acid binding protein. This would give you an early diagnosis. If he just says the word best biomarker for diagnosis of cardiac events in myocardial infarction, the best biomarker is troponin I. Even in the scenario of reinfarction, it would always be troponin I. The risotroponin I will be 20% over the baseline admission value. If he specifies the word reinfarction after 72 hours, then trop I will not have this advantage, but rather it would be CPKMB, which will start coming back to normal and then will rise once again. Then remember that LDH1 and LDH2 ratio will also help you in diagnosing myocardial infarction. The basic concept is that LDH1 is present inside the heart and LDH2 is mainly present in the blood, in the serum. So in a normal person, the values of LDH2 is more than values of LDH1. But if there will be necrosis of the heart, then the values of LDH1 will be more than values of LDH2. This was NEET 2018 that they had asked about the flipped effect. What I mean by the flipped effect is that the LDH2 values, which are traditionally more, will now become rather relatively lesser as compared to LDH1, which is in the heart of the patient. So remember the biomarkers aspect that I highlighted before you, and obviously cardiac troponins would be advantageous because we need at least a doubling for diagnosis of MI. Most of the patients who are having coronary artery disease will also be having a development of atherosclerotic process. So we need to give statins to patients. So who are the patients who will require statins? Patients who are requiring statins are the ones who have already had an atherosclerotic cardiovascular event. That is, all patients who already had a MI, already had angina, already had stroke. Those are the patients who should be given statins even if they have normal LDL. Why? Because the normal LDL for you and me, they say what is the normal LDL for ordinary population? It should be kept as less than 100. But if he says what is the target LDL for high risk population, like the one that is mentioned here, then the target LDL for high risk population, like already had a heart attack, is less than 70. So if a person has already had a MI, suppose his LDL value is 95, that is normal, less than 100, but for him the target is less than 50. Then patients who are asymptomatic but are having a LDL of more than 190, what I mean is that the person could be having a lipid profile defect. Like one of the common lipid profile defect that is encountered is type 2A hyperlipidemia. That is also called as familial hypercholesterolemia. So people with type 2A hyperlipidemia, familial hypercholesterolemia, if the LDL values are elevated more than 190, we have to start statins even at a young age. Then diabetes mellitus is accelerated atherosclerosis, renal failure is accelerated atherosclerosis, or even there is a Framingham risk score available. That Framingham risk score will take into consideration parameters like age of the patient, blood pressure of the patient, cholesterol of the patient, smoking history of the patient. So there is a statistical software available that is called as Framingham risk score. Framingham criteria are used for diagnosis of heart failure, but Framingham scoring is used to calculate the future cardiovascular risk of the patient with respect to MI. Framingham criteria are rather used to identify congestive heart failure in a patient, CHF in a patient. So patients who require statins are ones who have already had a MI, who are diabetic, who are having exerted atherosclerosis, even if asymptomatic, but having a deranged lipid profile is a candidate like familial hypercholesterolemia. And then I said even age more than 40, LDL is more than 70, those patients would require statins primarily. If in a question he mentions that triglycerides are highly elevated and triglycerides of the patient are more than 500 milligram percent, then people with hypertriglyceridemia, like in familial combined hyperlipidemia, they also have the risk of development of acute pancreatitis. So not only coronary events can be seen with a deranged lipid profile, but especially triglycerides more than 500 in diabetics can predispose to pancreatitis. So all these patients who are having hypertriglyceridemia, we also have to start fenofibrate in the patient. Indication for starting fenofibrate is mainly isolated hypertriglyceridemia in a patient. Otherwise, the routine guidelines are use high intensity statins, that is atorvastatin or rosuvastatin. No point of giving the 10-20 milligram that we write in the OPD. He says that's like a Ayurvedic medicine, may or may not work. But when it comes to statins, we have to give, and they should be given even on the day before surgery. In fact, aspirin, low dose 75 milligram, that is the anterior coated 75 milligram baby tablet of aspirin. Antihypertensive medication and statins should be given even on the day of surgery. They are yes on the day of surgery because they reduce the risk of intraoperative MI. This is because it will reduce significantly the risk of intraoperative myocardial infarction. The investigation choice, another MCQ, is investigation choice of intraoperative MI, that is transesophageal echocardiography. MI in MCQs is also written as stunned myocardium, that is to describe sudden decrease in contractility of the heart. Whereas chronic stable angina is referred as hibernating because there is a gradual reduction in contractility of the heart. So remember my words, hibernating myocardium for chronic stable angina and stunned myocardium for myocardial infarction. And yes, remember in transesophageal echo has been told to you as the investigational choice in aortic dissection. I repeat again, that is what Harrison says it. So I would recommend you to go by the Harrison data and not by what the radiologist is saying, which will mostly be CT or MRI. At least medical books mention mainly transesophageal echo. Then after aortic dissection, most patients are hemodynamically unstable. That is why I'm saying. Then transesophageal echo is also done for evaluating a tumor in the heart, that is atrial myxoma. And just now I told you that intraoperative myocardial infarction can also be diagnosed by transesophageal echocardiography. Moving to the next aspect, they have talked about especially hibernating myocardium or chronic stable angina. And the question was like, how do you differentiate hibernating myocardium, which is having less contractility, versus a scar in the heart? Then to differentiate between them, the best test would be PET scan. Or instead of asking like this, the question has been asked as, what test is done to evaluate for myocardial viability? That is whether it will respond to revascularization procedure or whether it's gonna not respond to revascularization procedure. Myocardial viability is again PET scan. The revascularization procedures which are available before you are either coronary artery bypass grafting, or you can go in for another scan that would be, thallium scan can also help in evaluating presence of chronic stable angina, but especially for viability, it is a PET scan. In fact, let's just get the data in order here. Chronic stable angina is also called as reversible ischemia, or for that matter of fact, it is also referred to as hibernating myocardium, which means that the contractility is lesser since the fuel supply is significantly reduced. Now, Remember that in this condition, the biomarkers are normal. Trop I is always normal. It is only that the ECG will show a ST segment depression when the patient is symptomatic. If he comes right now, he's not having any chest pain, he says I had chest pain episodes earlier, then ST would be normal. So if he says what is the first test to be written for these patients, it is a treadmill test. Though nowadays we are going ahead from treadmill test and we have started writing CT angiography for the patient. In CT angiography, we take multiple millimeter by millimeter sections of the coronary artery, like we do a 256 slice CT or 320 slice CT, and then we are able to see the Agatston score in the patient, which is going to be calcification in the coronary arteries due to the atherosclerotic process. Though CT angiography has not been validated by FDA, but it is being increasingly used over treadmill test because lots of patients are not very comfortable. However, if there is a contraindication for treadmill test, like if he gives you a situation of severe aortic stenosis, which is a contraindication, then the test you can do in the patient would be a non-physical stress-based test. That is, you are not making him walk on the treadmill, but you would be doing a stress echocardiography, which can evaluate the blockages in the artery of the patient indirectly. Something that is more accurate than stress echo is a thallium scan. So all of these are non-invasive tests to identify the blockages in the heart. That would be treadmill test, stress echo, and a thallium scan. If he says specifically in the exam that what is the gold standard to identify the blockages in the artery of this patient, then the gold standard would be answered by you as coronary angiography. That will give you real-time evidence of where is the blockage and what is the percentage of blockage. PET scan is mainly to be answered for myocardial viability, that whether the tissue in the heart will respond to any intervention in the form of a coronary artery bypass grafting or not. So a PET scan would help you know that from the prognostic perspective. The drug of choice for chronic stable angina is beta blocker. Lifelong aspirin, statins, and beta blockers would be given to the patient hypertension management also. And if he specifies that what is the treatment of choice for this patient, then your answer would be given as revascularization procedure. When I say revascularization procedure, there can be two possibilities. One is CABG, coronary artery bypass grafting, which is recommended for triple vessel disease. Or it would be PCI with medicated stents, that is drug-eluting stents for single vessel disease as well as for double vessel disease. The only thing is you will have to put two stents in two different arteries for double vessel disease in a patient. So revascularization procedures are definitely going to be beneficial for the patient in chronic stable angina, and these patients would be prescribed long-standing on long duration, I would say, beta blockers and statins. If they don't get improvement, then obviously angiography aspect has to be handled in these patients. Okay guys, coming to the next ECG, there was no history given. If we look at the heart rate of this guy, this would be about a little less than 100 per minute, so no tachycardia. And then you can notice a very characteristic ST segment depression which is present in the patient. The P wave appears to be of normal duration, the PR is normal, there is a normal sinus rhythm in the patient. But every time what is happening is that there is a very characteristic ST segment depression that is coming up. Now, because ST segment depression is being noticed in this patient in lead number 2, in fact, even in lead number 1, there is a ST segment depression. So I would say there's a global event occurring in the heart, in a sense that this person is having a myocardial ischemia. Why am I discussing this question is because my students informed me that there was a question in which they could see ST depression everywhere, and myocardial injury word was also given and myocardial ischemia word was also given. Now, when do you say injury? There are two things for injury to be answered in an MCQ. Either there should be a very characteristic ST segment elevation that should be noticed, and the best biomarker or the best test for injury is anyway a biomarker. So troponin I values should be grossly elevated. Because of the fact that in this particular ECG, most of the leads are showing a ST segment depression, there is no information given for cardiac biomarkers. It is ischemia that would be primarily answered. I could have, even if I got deep Q waves in any of the leads, even the chest leads are not showing any deep Q waves, I could have still thought in terms of an injury resulting in cell death of the patient, because following the injury there is cell death, and cell death is characterized by development of deep Q waves. So the basic message from this particular recording is that ST depression per se is to be answered for myocardial ischemia. For injury, there is obviously biomarkers in ST elevation, and there is no evidence of any T wave inversion in any of the leads in this particular patient. So still, even if there is no T wave inversion, we would still call it presence of myocardial ischemia due to ST segment depression. Though traditionally speaking, there are two findings which indicate a myocardial ischemia, that is a T wave inversion as well as a ST depression. Coming to the next slide, there is a evidence of bat-wing pulmonary edema in this particular patient. For management of bat-wing pulmonary edema, the treatment will depend upon the cause for it. One of the causes for bat-wing pulmonary edema can be acute decompensated congestive heart failure, that is ADCHF, where D stands for decompensated, or it could be a cardiogenic shock. If it is volume overloading contributing to acute decompensation, then LMNOP are the molecules, because you need to give a diuretic, that is Lasix or furosemide. Morphine again to reduce the pulmonary edema and calm the patient. Nitroglycerin to reduce the preload and the afterload and reduce the stress on the heart. Oxygen obviously, because the SpO2 is lesser. And positioning of the patient is to be done in such a fashion that the feet of the patient should be lower as compared to the rest of the body. When it comes to cardiogenic shock, the molecules to be used, first line is norepinephrine. The second molecule to be used is after norepinephrine is dopamine. And another one that can be used is dobutamine. Though first line is obviously norepinephrine, I can quote Harrison here. He has categorically mentioned the fact that this has the least side effects and having the least incidence of arrhythmias and is superior. Even in septic shock, he has categorically mentioned vasopressors, the preferred one to be used is norepinephrine in the patient. However, for heart failure with preserved ejection fraction, that is PEF, if he says which are the major mortality reducing drugs, then it is ARNI and aldosterone antagonists in the patient. For ARNI, one would be angiotensin receptor blocker, which could be like valsartan, in combination with sacubitril, which is a nephrolysin inhibitor and ensures that the B-type natriuretic peptide is able to act more effectively, causing natriuresis. The aldosterone antagonist to be remembered would be like spironolactone or eplerenone. These are the only drugs which have reduced mortality. Cause of heart failure with preserved ejection fraction would be undiagnosed hypertension or restrictive cardiomyopathy, where there would be stiffness in the heart of the patient, due to which the filling pressures are elevated and therefore there is a resultant pulmonary edema developing in the patient. Then they have asked about the murmurs aspect. So especially I want to highlight the murmur of supravalvular aortic stenosis. If you look at the ejection from the left ventricle into the aorta, you will notice that the jet of blood that goes out into the aorta of the patient will be equally distributed into the right and the left blood vessels, that is in the brachiocephalic trunk in the right common carotid in the left subclavian. This is the left subclavian, this is the brachiocephalic trunk. So you can see equal distribution, but because of supravalvular aortic stenosis, what happens is that the blood pressure variation is seen, and that pulse disparity is technically called as Conda effect. The blood pressure in the right is relatively higher than that on the left hand side. That is because the jet is usually preferentially the jet is moving towards the right common carotid artery and the right subclavian artery. So the BP on the right hand side would be more than the BP of the left hand side. The murmur that is seen in this case would obviously be ejection systolic murmur, but will be associated with development of unequal blood pressure between the left and the right arms. Traditionally, when we read about ejection systolic murmur, what comes to our mind is valvular aortic stenosis or hypertrophic cardiomyopathy. But in both of these conditions, the blood pressure of left and right arm is equal. So now you need to remember a third cause of ejection systolic murmur, that would be supravalvular aortic stenosis, which can be differentiated from the previous conditions in a sense that this would be the only one out of the three where the blood pressure in the left arm and the right arm would be unequal, and the BP in the right arm will be relatively higher than that of the left arm due to preferential streaming of the blood into the right arm due to the presence of the obstruction in the part of the aorta just above the aortic valve of the patient. This is actually a physics word. No, Quanda effect is, if you Google the word Quanda, it will come as physics output. So preferential streaming of blood towards the right is the reason for it. Let's quickly also revise what are the conditions that can cause unequal blood pressure between the left arm and the right arm of the patient. So one of these conditions would be Takayasu's arteritis, where there is a ostial narrowing, and secondary to the ostial narrowing, you will notice that the BP in the left and the right arm would be affected. Even in Takayasu's arteritis, left subclavian artery is more inward, so BP in left would be lower than that on the right hand side. Then can be coarctation of aorta. The preductal variety of coarctation of aorta can result in unequal blood pressure, and the third one would be supravalvular aortic stenosis in a patient. These are three causes which are responsible for unequal blood pressure between the left and the right arm of the patient. Now, once you remember this information that I have highlighted before you, then we'll focus on the murmurs part. All murmurs will obviously become lesser in intensity with Valsalva standing, except HOCM that will become louder. Though I've talked about that MCQ earlier, but I still want you to remember that because this was last time's NEET question. You can differentiate between the two. AS will become relatively softer with Valsalva standing, and HOCM will become louder. Supravalvular aortic stenosis will again behave the same. It will become softer. As far as remembering the murmurs are concerned, one we have to remember regarding diastolic murmurs. So I'll just make you practice that. You see, the murmurs of diastole are classified as early diastolic and mid diastolic murmurs. The early diastolic murmur will be having a triangular configuration where the intensity of the murmur will decrease very soon. And the mid diastolic murmur will be having a bell-shaped configuration like this, with a murmur peaking in the middle of diastole and then coming down. Now, when it comes to early diastolic murmur, the mnemonic for that is GAP, where alphabet G would stand for Graham-Steele murmur. Graham-Steele murmur usually occurs in patients who are suffering from severe variety of pulmonary artery hypertension, and that results in a mild pulmonic regurgitation. A stands for aortic regurgitation of the mild variety, and P also stands for pulmonic regurgitation of the mild variety. In contrast, when it comes to mid-diastolic murmur, the mnemonic is CAM, that is Carey-Coombs murmur, Austin-Flint, and then a mitral stenosis. When I'm writing this, a lot of you guys would send up a query saying that Carey-Coombs murmur was a delayed diastolic murmur. I agree that traditionally speaking, Carey-Coombs is a delayed diastolic murmur, but lot of books are not, or lot of MCQs are not giving delayed diastolic in the choices. So I'm going MCQ wise today. If delayed diastolic murmur or late diastolic murmur word is not given, then Carey-Coombs should be classified as mid diastolic murmur. This is what I'm saying. Some books mention Carey-Coombs as delayed diastolic, that is the peak will be occurring a little towards the right, that is skewed. Now this will have inter-observer variation also, because it's only a few milliseconds that you need to use to decide whether it's mid or a delayed diastolic. Traditional experts who specialize in rheumatic heart disease per se mention that rheumatic heart disease patients Carey-Coombs have a delayed diastolic. If not given, then it is Carey-Coombs murmur obviously. Alphabet A would stand for Austin-Flint murmur. This is classical of severe aortic regurgitation. And then would be obviously mitral stenosis murmur that will have two peaks, including the one which will be just before the starting of S1. So in mitral stenosis patient, the murmur will come like this. The murmur will peak, and then we'll have a small secondary spike also. And this small secondary spike is the one that is technically called as pre-systolic accentuation in the patient. After the diastolic murmurs, you have to remember regarding continuous murmurs. The most important continuous murmur that you need to remember is peripheral pulmonic stenosis. This is a narrowing of the pulmonary artery of the patient, and remember, blood flows continuously in our pulmonary artery. Whether it is systole, whether it is diastole, the blood is always flowing in our pulmonary artery. So peripheral pulmonic stenosis is responsible for a continuous murmur. Then would be coarctation of aorta, and then would obviously be patent ductus arteriosus. If you want to rupture, remember, you can remember rupture of sinus of Valsalva. Sinus of Valsalva, if it ruptures, it will cause a communication to develop between the aorta and the right atrium. Now, aorta is a ultra high pressure area and right atria is a ultra low pressure area. So that would result in development of a continuous murmur to develop in a patient. Then can be mammary souffle, which is a physiological finding of pregnancy. Then could be venous hum, which could be due to dilated veins in the chest. Remember that 5 and 6 will not be questions for you. They would just be dummy choices in the MCQ. Otherwise, mainly the answers to be remembered are 1, 2, 3 for continuous murmur. Then is aspect relation related to systolic murmurs. In systolic murmurs, either the possibility can be that the murmur will increase and decrease with intensity, that is ejection systolic murmur, or the intensity of the murmur will remain constant all through the duration of systole, that would be a pan-systolic murmur. For ejection systolic murmur, the mnemonic is PAS, pulmonic stenosis, aortic stenosis. The add-ons to be remembered are, you could be having subpulmonic stenosis, that could be tetralogy fallet, that could be responsible for a ejection systolic murmur in the patient. For aortic stenosis, it could be subaortic stenosis, that would be a patient of coarctation of aorta. And then can be also supravalvular aortic stenosis having a Conda effect, where the blood pressure will be more on the right as compared to left. All these conditions are having ejection systolic murmur. In fact, for pulmonic stenosis in adults, one of the causes of pulmonic stenosis in adults is carcinoid syndrome. So instead of writing PS, he might write the word carcinoid syndrome, expecting you to remember that the patient would be having ejection systolic murmur. Pan-systolic murmur is relatively easy. Mitral regurgitation, tricuspid regurgitation, and then ventricular septal defect would be having a systolic murmur. So the slide is mainly regarding the murmurs part per se, and I would definitely like you to remember the classical name Graham Steele, Austin Flint, peripheral pulmonic stenosis. Then I wanted to remember carcinoid syndrome, supravalvular aortic stenosis. These are some like where he will straight away give you a condition and then say what is the type of murmur that is seen. Another possibility can be that in the question he can give you a scenario of Turner syndrome and say what is the murmur that is anticipated. Now in Turner syndrome, one of the common valvular lesion is bicuspid aortic valve. Also seen is coarctation of aorta, but the common one is bicuspid aortic valve. So because this is common and will behave like aortic stenosis, so the murmur that is anticipated in the patient more often is ejection systolic. And if there is coarctation of aorta, then it would be continuous murmur. Both bicuspid aortic valve as well as coarctation of aorta are seen with Turner syndrome, but bicuspid aortic valve is relatively more commonly seen. That is why I have highlighted this first, that bicuspid aortic valve in Turner syndrome will cause a ejection systolic murmur in the patient. Okay, the next slide that we will study here is called as broken heart syndrome. This is also called as Takotsubo cardiomyopathy. Though I talked about the cardiomyopathy parts earlier, I just want to bring to your notice the fact that all of those would be long-standing in presentation, but Takotsubo cardiomyopathy is an acute onset cardiomyopathy which occurs due to catecholamine excess. You can notice the dilated part of the left ventricle of the patient that is bulging out in the form of a jar, and this jar is actually used to trap octopus. So either you can call this head of octopus because the head of octopus will fit into this, and once it goes inside, it is not able to come outside. So this is a jar that's used in Japan to catch octopus, traditional data. And Takotsubo cardiomyopathy will present after extreme emotional stress, like husband died and after a few hours wife also died. Catecholamine excess. She was coming back from the funeral of her husband and she was so grieved that she had presentation similar to him. So like I'm describing a widow, she just lost her husband. They were coming back from the graveyard and then she started having this chest pain. And because the chest pain was very intense and she was having a lot of sweating also, her son decided to take her straight away from the funeral to the hospital. When you were the resident on duty, you checked her ST elevation in the ECG. You thought she's having extensive anterior MI. Even her biomarkers were positive, they were double. So you have decided to take up this lady in the cath lab, and you have decided to do a percutaneous coronary intervention in this patient within 90 minutes of arrival. But when you did coronary angiography of this lady, the angiography is perfectly normal, because this lady is not actually having a MI, but is rather having a catecholamine induced damage to the heart, which is causing the heart to go into cardiogenic shock, and cardiogenic shock will cause decrease in the coronary blood flow, and the reduction of the coronary blood flow will cause myocardial ischemia, which will be severe enough to result in a ST elevation. The coronary angiography of this condition is perfectly normal. This disease is diagnosed in the cath lab. It cannot be diagnosed in OPD or in emergency, because cath lab is obviously a specialized procedure. Now the doctor has decided to cancel the PCI procedure in this patient, and the treatment of choice for this condition would be intra-aortic balloon pump. Do not answer catecholamines for the cardiogenic shock here, because remember, she is already having a catecholamine excess. So intra-aortic balloon pump is used, very surprising, and recovery can also occur. So this is the only variety of cardiogenic shock, I would say, and rather I would say the only variety of cardiomyopathy where recovery is possible, because in traditional cardiomyopathies you either require an implantable cardioverter defibrillator, or for that matter of fact you require a cardiac transplantation. But this is one patient where emergency management is required and recovery is definitely possible in this case. So the name is TTCM, or Takotsubo cardiomyopathy. Like in AIMS exam, the question was two brothers had a fight, and the younger brother was so emotionally stressed out after the fight that he had chest pain, then he died. So that is definitely a possibility of cardiomyopathy, TTCM, to be considered. And there was no previous history present. If there is previous history of heart disease present, then we can think in terms of Brugada also. But in TTCM, there is no previous history. It's catecholamine excess that would straight away contribute to mortality in the patient. Coming to the next slide, I want you to remember aspects related to Kawasaki disease. If you read a question, the practice question to be remembered is ECG findings of MI in a 4-year-old child. ECG findings of MI in an adult is understandable, but a 4-year-old child will obviously be having a disease where there could be an aneurysm in the coronary artery of the patient. In fact, if you see the angiography report of this patient, there are multiple aneurysms in the coronary artery. So Kawasaki disease would be remembered by you as MCL, that is mucocutaneous lymph node syndrome. Let us remember the features that are seen in account of cases of Kawasaki disease. One, this child would be having fever for a duration more than 5 days. Mostly the presentation will be with unilateral cervical lymphadenopathy. The lymph nodes on one side of the neck are enlarged. So you thought that he's having a throat infection, you put in a tongue depressor. Now when you examined the tonsils were normal. But when you withdrew the tongue depressor, you saw that in the mouth, the tongue was relatively having a strawberry appearance. So strawberry tongue is one thing that should bring to your notice that the patient could be having Kawasaki. Then you will also notice that the child would be having peeling of the skin. You can notice the desquamation around the lips. In fact, this desquamation can be present on the fingertips. The desquamation could be present around the anus of the patient. The desquamation is present in the fingertips of the patient. So periungual, perianal and perioral desquamation would be present. Then you will also notice that this child will be having a rash which would be reddish in color, though mother may not notice it because it's on the trunk. So when you ask her mother to remove the clothes of the child, the rash would be noticed by you. The highlight of this child would be that if you look at the eyes of the child, there would be a bulbar congestion. The eyes would be bloodshot red. So now you have to put the data together. I'll just highlight the muco manifestations. Muco can be like bulbar congestion. Muco manifestation in this patient can be like strawberry tongue. So these are muco. The cutaneous manifestation of this child would be peeling and desquamation around these particular sites. There is also rash that is present in this area. And last but not the least, there is a lymphadenopathy also developing. So mucocutaneous lymph node syndrome is a term used to describe the manifestations of Kawasaki. This child will develop coronary artery aneurysm and will go on to develop a MI. The only way to treat the vasculitis of this patient is immunoglobulin and low dose aspirin. Otherwise, if we will develop MI, then God help this child, you will have to do thrombolysis. And doing thrombolysis in children is not a joke because they could be brain hemorrhage aspects also. So that's the sequence that I basically want you to remember for these patients. Okay guys, coming to the next one, there are two more miscellaneous aspects of the ECG that I want you to be clear about. One, you can notice that there is a definitive ST segment change in the ECG of this particular patient. So this particular ECG represents again a ST elevation, but as compared to myocardial infarction, this would be having a concavity in the upward direction. So you always have to remember the types of ST elevation that can be given to you. One is obviously the traditional one that you encounter in MI, that is Pardee sign. Another one to be remembered would be ST elevation, which would be concave upwards. The third pattern is the one which is seen in patients who are either having hyperkalemia or having Brugada syndrome, where you can see the co-pattern coming up. The first one is called as Pardee. The third one is the co-pattern. The second one in the middle does not have any specific name, but that is the one that is shown in this current ECG. And the diagnosis of this particular patient would be kept as acute pericarditis. If the question is asked as what is the leading cause of acute pericarditis, it is idiopathic, then is viral, and then is tuberculosis. So don't straight away jump the gun and think and straight away answer TB. I mean, I agree for TB, it looks, especially for India, it looks like a very encouraging fact to answer. But then it is idiopathic that is common, and I'll just describe pericarditis in a while. Let's just take care of the second ECG as well. In this ECG, if you count the heart rate of the patient, it is, I would say, very slow. You can count approximately 8 large squares between the R and the R waves, even in fact little more than that. So considering that the heart rate of this patient would be only in the range of, I would say, 30s only, something in the range of 30, I would say a little more than 30. 8 3s about 24. My mathematics is bad, so I'm just mentioning it like the proxy 38 per minute proxy. So patient is having a bradycardia and there is a broad complex QRS. Considering the fact that this is a broad complex QRS, we usually tend to think in terms of ventricular tachycardia. But in ventricular tachycardia, obviously, there should be a presence of heart rate more than 100, whereas here the heart rate is only 38 per minute. So this particular pattern is showing presence of a presence of broad QRS complexes, which are occurring primarily because of the intrinsic firing rate of the heart being relatively slow. In fact, the patient is having presence of premature ventricular contractions. Okay guys, coming to the next slide, we shall be talking about a miscellaneous aspect of again a change in the ECG, where you can see that there is a ST elevation. This kind of a ECG can be given to you with or without a history, but you will have to anyway pick up that this is ST elevation with a concavity in a upward direction, which indicates presence of acute pericarditis. There are multiple causes of ST elevation that you have to remember. This is actually one of them. The mnemonic that I have highlighted for ST elevation, and I will make you revise once again today. It goes by the name of elevation only, where alphabet E would stand for electrolytes. In fact, the complete mnemonic is elevation AB. That would complete the entire spectrum. A would stand for electrolyte imbalance, and usually the electrolyte imbalance that we're talking about is hyperkalemia, where ST elevation that is encountered would be in the following fashion. We can either call it a Brugada pattern or we can use the word co-pattern, like this ST elevation is also seen in Brugada syndrome. Therefore, this would also be called as Brugada pattern. So I highlight the fact that in topic of Brugada syndrome, I was using the word co-pattern, but because here the pattern of Brugada is being replicated in hyperkalemia, so Brugada pattern is a term used in Harrison to describe the ST elevation of this particular patient and also encountered in a channelopathy. Alphabet L would stand for left bundle branch block. Then would be early repolarization variant. The basic point to be understood is that Some of us might be having a physiological ST segment elevation without any causing threat to life, so that would be called as early repolarization variant. VA would stand for ventricular aneurysm. This is a structural damage that is encountered in the heart post myocardial infarction. Then would be T, that is trauma. By trauma, I don't mean any punch to the heart. By trauma, I mean something as simple as pericardiocentesis is being done. Like nowadays, we do pericardiocentesis echocardiography guided, but earlier when facilities were not there, they were used to do it ECG guided, and that if the needle will touch the heart, it will cause ST elevation. So, I mean, the guide to the progression of needle was ECG, and therefore pericardiocentesis was ECG guided in earlier times. So, this is a historical aspect, I would say. Ischemia, obviously, I mean, ischemic injury, myocardial infarction would classically cause the Pardee sign, with ST elevation should be at least of more than 2 millimeters in most of the leads, or at least it should be in contiguous leads to identify the patient is having a myocardial infarction. O would stand for Osborne wave, which is encountered in patients of hypothermia, where the core temperature would be less than 35. And then N would stand for non-occlusive vasospasm. Remember the fact that prinzmetal angina is one of the rare anginas where you get ST elevation. In fact, angina per se always has a ST depression. If you are having a ST elevation angina, that is only prinzmetal angina. So non-occlusive vasospasm is prinzmetal angina. Alphabet A would stand for acute pericarditis. This would be what I have just shown you in the ECG, and then B would stand for Brugada. So this is a mnemonic that you can remember for causes of ST elevation in patients who are having a threat to their life due to any of the following causes that I have highlighted before you, though some of them can be, initially a physiological variant also. Once we remember the causes of ST elevation, then the next thing to be remembered for this particular parameter or this particular slide would be causes of acute pericarditis, because most of the time what happens is that we all have a tendency to answer tuberculosis as the first line data. So avoid that impulse. One of the leading causes of acute pericarditis would be idiopathic. After idiopathic would be viral, and then would obviously cause tuberculosis. So that's the sequence to be remembered. Though pericarditis can be encountered even in rheumatic fever due to Ashcroft nodules, you could be having acute pericarditis seen with patients who are having uremic pericarditis, that is renal failure. The toxins would contribute to the irritation of the heart. Then malignancy is an important one, especially malignant pericardial effusion, malignant pericarditis. That would be lung cancer metastasizing to the heart, that is oat cell cancer. And the last one to be remembered is Dressler. The etiology of Dressler is asked, and it has to be remembered anyway. That would be autoimmune pericarditis in a patient. So these are the causes for acute pericarditis, and when you will examine the patient, you will be having a scratchy sound in the chest. Now, what is that scratchy sound chest called as? That is called as pericardial friction rub. How are you gonna distinguish the pericardial friction rub from the pleural rub? Is the fact that pericardial friction rub is best heard in the phase of breath holding. If a person is gonna hold his breath and you are still gonna hear the sound, then it is obviously coming from the heart of the patient. The ECG of this particular patient will obviously be showing you a ST elevation concave. The cardiac biomarkers in this particular patient would definitely be normal. And then you will have to obviously treat the patient. The treatment will be cause specific, like for viral, it is non-steroidal anti-inflammatory drugs. But for tuberculosis, it will be ATT, that is anti-tubercular treatment, to be administered to the patient for 6 months. For uremic pericarditis, hemodialysis has to be done to remove the toxins. In fact, one of the absolute indications for dialysis, remember my word, like the question says, absolute indication for dialysis, and you have to select between uremic pericarditis and uremic encephalopathy. Then do not select uremic encephalopathy, but rather the absolute indication for hemodialysis to be remembered. Absolute indication for hemodialysis is uremic pericarditis. Then oat cell cancer, obviously chemotherapy will have to be given. The chemotherapeutic drugs that we are using for malignant pericarditis would be like irinotecan, And another molecule that we use for chemotherapy here is cisplatin, highly toxic drugs, but then these are the only way forward for a cancer having micrometastasis. And for Dressler syndrome, it is autoimmune etiology. On reading the word autoimmunity, we can be biased towards steroids, but it is rather not steroids but aspirin that is recommended. Why? Because if you give steroids, then the healing process with respect to the heart will become relatively slow. So we give aspirin 650 milligram, will cause a bit of gastritis, so we can manage that. But then acute pericarditis is the one that I've highlighted before you. And if you do not manage these patients accordingly or properly, then these patients can deteriorate into development of a pericardial effusion, and then they can deteriorate even into cardiac tamponade. So complications of acute pericarditis to be remembered are pericardial effusion and cardiac tamponade. The difference between the two is mainly based on presence of pulsus paradoxus in cardiac tamponade. For pericardial effusion, he will mostly ask you a ECG finding. The characteristic ECG finding should be remembered as electrical alternance, which I've shown in the earlier part. The reason I'm making you practice this once again is because if they give you a question that talks about electrical alternance, and even in cardiac tamponade, they'll talk about electrical alternance. So there is a high possibility that you might be wondering what to answer. In those circumstances, coming to your rescue would be Beck's triad. And even if Beck's triad is not given, then pulsus paradoxus would definitely solve the aspect for you. Both conditions will be having a water bottle heart. Money bag appearance would be present in both of them. It is just that the money bag appearance in tamponade will be relatively much more significant. So you can be having similar wordings in a clinical based two-liner question, but then there are some words that obviously have to be picked up by you so that you can identify the difference. Pericardial effusion is unlikely to be seen with rheumatic heart disease, but is very common with malignancy, and it can upgrade to cardiac tamponade where hemodynamic compromise can be present in the patient. So blood pressure falling is a feature of cardiac tamponade. Muffled heart sounds is a feature of cardiac tamponade. The JVP in patients of cardiac tamponade will always be elevated, but it becomes non-pulsatile. And because it is non-pulsatile, therefore, we say the fact that in this person, Kussmaul sign cannot be appreciated. You see, traditionally speaking, Kussmaul sign is characterized by elevation of the JVP in inspiration, but here it is always elevated in all phases of respiration because it is non-pulsatile in nature. So remember, Kussmaul sign, which is always seen in patients of constrictive pericarditis, will be absent in patients of cardiac tamponade. These are the allied aspects which I want you to remember. Treatment is obviously pericardiocentesis, and for constrictive pericarditis, rather pulsus paradoxus, even if it is given, he will always mention the word low voltage ECG because there is a calcification outside the heart of the patient. Coming to the next revision part, we will study regarding metabolic syndrome. Metabolic syndrome is also referred as syndrome X. Point number one I want you to remember is that this should not be confused with a related terminology that is technically called as coronary syndrome X. Coronary syndrome X will be presenting like chronic stable angina. The clinical features will be identical to chronic stable angina, where the patient will say that on walking fast, like he went for a morning walk, he was walking fast, he had chest pain or heaviness. So chronic stable angina or hibernating myocardium is the presentation of this particular patient. But in coronary syndrome, because you are doing angiography of the patient, since you want to pick up the blockages in the artery, the angiography will be shockingly normal. The lesion in this condition is not in the main coronary artery, but it is the perforators in this particular condition which are involved. The perforators are the one which are actually having a nerving. So since in this particular condition there is a perforators that are involved, therefore this is a specific type of condition that is called as syndrome X, where though we are saying patient is having chest pain and walking fast, coronary arteries are normal in caliber. For treatment of this condition, we will have to give nitrates to the patient, mainly the long-acting ones. Beta blockers will also be given in this condition, but there is no point of PCI with stenting. Percutaneous coronary intervention with stenting is always done for blockages in the coronary artery, but here, because the main coronary artery is normal, there is no point of doing a PCI with stenting for the patient. So once you have remembered coronary syndrome X, now we will talk about what is called as syndrome X, or is called as metabolic syndrome. So pretty close names, I repeat once again. One is coronary syndrome X, which is characterized by involvement of the perforators, and the second one that we're discussing is metabolic syndrome, that is syndrome X. How to remember syndrome X? This is a typical Indian guy in whom the following things are more. One, the weight of this individual is significantly increasing and he is mainly developing centripetal obesity. It is mostly tummy fat, which is very dangerous and can increase the incidence of heart disease in this individual. The abdominal circumference more than 102 centimeter for males and more than 88 centimeter for females increases the risk of coronary artery disease. The Indian guidelines are for an Indian male, the abdominal circumference more than 90 centimeter, and for Indian female, abdominal circumference more than 80 centimeter indicates that person is having obesity. This particular patient who's also gaining weight is having a deranged lipid profile. Now, traditionally, when you read about lipid profile, you start thinking about increased cholesterol in a patient, increased LDL in a patient. But in this case, you have to remember that the major thing to be remembered is triglycerides and HDL. It is good cholesterol deficiency. That is, if the good cholesterol is less than 40 for men and less than 50 for females, and triglycerides more than 150, it contributes to heart disease. I want you to remember that not only hypercholesterolemia is dangerous and contributes to incidence of heart disease, but hypertriglyceridemia is also a risk factor. And this is the Indian person who loves to eat fried food for his breakfast every morning, like parathas or puris, for example. So basic point is, in Indian breakfast, the items which are basically taken by people in their households, they have an increased risk of causing heart disease, especially the tummy part is increasing in patient, triglycerides are increased, HDL is rather reduced in the patient. Now, because of the fact that there is more weight of the body, the peripheral resistance will be upgraded. The increase of peripheral resistance will explain why there is a elevated blood pressure of this patient. He is also hypertensive. Traditional patient, the hypertension cutoff that I have explained to you is 140/90. This is the one that is given in Harrison. Joint National Committee 8 guidelines are being followed, and hypertension cutoff is 140/90 only, not 130/80. That's according to the AHA 2017, and it has not been mentioned in Harrison. So let's not run after those updates which are given only in medical journals, because after all, in your exam, they'll follow the textbook data only. This patient's cutoff for hypertension, however, is not 140/90. The cutoff for hypertension of this individual would be 130/85 millimeter of mercury. And obviously, because the weight is more, there would also be an increased incidence of insulin resistance in the patient, and insulin resistance will cause impaired glucose tolerance in the patient. So let's quickly revise what are the features of syndrome X. The weight is more, the lipid profile is deranged, the sugar is more, and even the blood pressure is more. I'll just make you practice once again. I said the problem in the patient is weight is more, blood pressure is more, the blood sugar is more, and the lipids in the person are very offbeat. For the weight part, you will describe it as in the form of abdominal circumference or abdominal girth, that is centripetal obesity would be increased in the patient. The cutoff for hypertension is 130/85 rather than 140/90. They downgraded this cutoff because these are high risk patients. So we will say that these patients require antihypertensive medication even at a lower value. Blood sugar would be in the range of IGT, that is impaired glucose tolerance, and hyperlipidemia would be mainly hypertriglyceridemia with a downgrade of HDL. This all things, 4 things in a single chap. Imagine, weight is more, BP is more, blood sugar, lipids, all parameters are deranged. This basically highlights what is called as metabolic syndrome, or is called as syndrome X. And this is not to be confused with, or it is not to be mixed up with the information of coronary syndrome X, where perforators are narrowed, so we do not do a stenting in the patient. Now, once you remember the information for syndrome X, then is a step further, and you have to remember regarding syndrome Z. What is syndrome Z? It is a combo of syndrome X plus OSA, that is obstructive sleep apnea. This person is also having an increased neck circumference. You would have noticed that people who are having an increased neck circumference, they are also at risk for development of heart disease significantly. This guy cannot even put up a button in the shirt collar when the neck circumference is so big, and there's a prolapse of the airways when he's sleeping, especially in the supine position when he's sleeping. There's loud snoring, and then there would be apneic episodes that will cause hypoxia. Because of the apneic episodes and the hypoxia that is occurring in this patient, there will be a definitive sleep interruption in the patient. So one feature that is seen in these patients is they never wake up fresh, and he will say that I am always having this feeling as if my body is breaking. I don't feel comfortable in the morning hours. I think as if I'm running. I did some running. I'm very tired. I'm having cramps in my legs. So it is mainly due to disturbed sleep. But over and above the aspect of the disturbed sleep in this patient, what I am worried is that this particular individual, you will always notice that the hypoxia component will contribute to even a pulmonary artery hypertension developing in the patient, and these patients also become having systemic hypertension also simultaneously develop. So pulmonary and systemic artery hypertension developing, that's double whammy. I would say the insult to the injury. So the incidence of heart disease is relatively increased in these patients. So they have asked regarding syndrome Z, where the additional fact to be remembered is that of OSA, and obviously increased neck circumference is an important component for this. Then is a term by the name of Pickwinian syndrome. Pickwinian syndrome is mainly characterized by the fact that the PCO2 of these patients will be significantly elevated. In this individual, I can explain like this. In Pickwinian syndrome, if this is the representation of the alveoli, and these are the blood vessels which are surrounding it. So what's going to happen in this patient is that there is a fat which is present around the alveoli of the patient, and because of this, the diffusion of gas will obviously be a problem. I mean, oxygen will have to diffuse across an extra layer, and even carbon dioxide cannot be excreted out. So the values of PCO2 in the patient will begin to increase, which will make the person develop carbon dioxide narcosis. He will keep on sleeping for most part of the day. So in extreme obesity patients, we can also have a condition called as Pickwinian syndrome, where there would be a hypercapnia developing in the individual as well. So obviously, I mean, obesity is a epidemic in our country and needs to be handled on a bar footing. And associations with heart disease is what I've tried to explain to you here, especially the aspect of syndrome X, coronary syndrome X, and then Pickwinian syndrome, which is characterized by morbid obesity and hypercapnia in an individual. The next thing that we will revise after this would be aspects related to rheumatic fever. This, that is, I'm going to make you practice, is the 2015 update for rheumatic fever. One of the special highlights of the 215 update for rheumatic fever is that echocardiography has been included in the criteria for diagnosis of carditis. Why? Because you see, traditionally when we study carditis, we are always thinking about clinical carditis, which would be valvular lesions like mitral stenosis, mitral regurgitation. Nowadays, he says that you don't need to wait for the carditis component to actually manifest in the patient. You can pick up the inflammation of the valves. Even on echocardiography, the subclinical carditis can be picked up in the form of valvulitis, and therefore subclinical carditis has been included in the diagnosis. You can understand it in the following fashion. Like suppose this is the representation of the mitral valve leaflets. Then Ashkoff nodules would be contributing to inflammation of the heart valve cusps. So Ashkoff nodules will obviously cause damage, but Ashkoff nodules are present in this area, that is the commissural end. And because of the commissural end involvement in rheumatic etiology, there would obviously be a development of valvulitis, due to which in this patient there's a possibility that the blood can leak between the valve leaflets. That is, there is a possibility of Caricom's murmur developing in the patient, or there could be a development of McCullum's patch. So echocardiography has been included. Then you will notice the fact that earlier we used to think only about the arthritis component, and that too we used to study about migratory polyarthritis, where we used to say that it is involvement of the ankle joint, then of the knee joint, then of the let me say the elbow joint. Like this child is having history of recurrent sore throats, and then the child woke up in the morning with inability to walk. He is having a limping. That limping is because of the swelling of the ankle. Then after a few days, the swelling of the ankle will disappear and the contralateral side knee joint will get inward. Then the knee joint swelling will disappear and maybe the elbow joint swelling will come. So what he has done now is he has basically divided this into, I would say, a low endemicity and a high endemicity population. What you mean by the word low risk population would be, for example, I would say America, where the endemicity of the disease is very less. So if a person is having multiple joint involvement, only then I will say that yes, he is having rheumatic. But in a country like India, where the incidence of sore throat is also more, and I would say that the case load is also more, so he says that why do you want to wait for multiple joints to get involved? Only monoarthritis is sufficient for diagnosis of the patient. So another thing that he has done is he has divided the discussion into two, that is a low risk and a high risk population. For America, it is that even multiple joint involvement is a must for diagnosis of the patient. But when it comes to country like India, monoarthritis is also to be considered. So echo has been added, and initial point is monoarthritis word has also been added. Otherwise, the traditional word was migratory polyarthritis. Now even monoarthritis, if written in MCQ, yes, is a major criteria for diagnosis of rheumatic fever. No aspects with chorea and erythema marginatum, that would be standard data. Even subcutaneous nodules, that would be standard data in the patient. So it's only 2 points to be remembered in the major ones. The presence of subclinical carditis. He might write subclinical carditis, or he might say echo showing valvulitis. For the minor criteria, again, you will notice that earlier we used to say arthralgia. Now he's obviously divided that into polyarthralgia and monoarthralgia. Well, how to remember that? Very simple. For American population, even if it is like one joint involvement, we can't be sure. But India, it is so common. So single joint involvement is also common for Indian population. And therefore, monoarthralgia, even if written, is included in the diagnostic criteria. So monoarthritis is there. Monoarthralgia is also present. Remember that polyarthralgia, one word which I want to tell you is, that's just, for reference sake, polyarthralgia as a word is included in the major criteria for Indian population. But for American population, polyarthralgia is included in the minor criteria. So here I just want to say the fact that because in India disease is more common, polyarthralgia is to be considered joint pain, right? Not inflammation of the joint. But in America, disease is reduced, so polyarthralgia is a minor diagnostic criteria. Then fever cutoffs have been mentioned, a little less higher for American population as compared to Indian. Then ESR cutoffs is also mentioned, 60 and 30. Earlier, there were no such cutoffs given. No, there was no such parameters like ESR of more than this much is diagnostic. So I'll just make you remember this also. This is what I've said. Even monoarthralgia is a diagnostic criteria. But this monoarthralgia is a minor diagnostic criteria, not a major one. Polyarthralgia is a major criteria for Indian population and is a minor criteria for American population. Then the cutoffs of ESR are to be remembered, especially for American population, it would be 60. He says for India, why do you want to wait for 60? Even if it is 30, it is sufficient for diagnosis, and or that is for the Indian population, he says, and or that you can add C reactive protein to it, that is capsular polysaccharide pneumococcus reactive protein with value specified as more than 3 units is sufficient. The fourth feature is obviously a prolonged PR interval. Why prolonged PR interval? Because there would be a Ashcroft nodules between the SA node and the AV node, so they will slow down the conduction basically. So these are some aspects which I have highlighted, and earlier you will notice that the term used was essential criteria. What he is now doing is that instead of using the word essential criteria, which can be obviously asked to you, he can, instead of writing, he says must do investigations. So this that I have highlighted before you are must do investigations for the patient, that you have to have evidence of streptococcal infection in the previous 45 days. He must have had an infection. How do you do that? You can go in for ASO titer, you can go in for a rapid streptococcal antigen test in a patient, or you can go in for a throat swab. But this is a additional information which would tell you that yes, there is an infection with rheumatic etiology in a patient. Once you remember the update, that is, I'll highlight it once again, the echo showing presence of subclinical carditis, that is valvulitis, presence of monoarthritis in Indian population or polyarthralgia in Indian population is sufficient. Then monoarthralgia is also a minor diagnostic criteria, and then ESR cutoffs of 60 and 30 with positive C-reactive protein. I want you to remember that TLC has been removed from the discussion. TLC is not included anymore in the diagnostic feature for rheumatic fever. Once you remember this, then we'll also talk about the valvular lesions which are commonly seen. especially because they ask about the endocarditis in this patient. So, three aspects of endocarditis should be quickly revised. One is if he says what is the common valve involved in this condition or not involved in this condition. So, mitral valve is obviously involved, aortic valve is also involved. The incidence of aortic valve involvement will obviously be lesser as compared to the mitral valve, but pulmonic valve is least likely or unlikely to be involved in rheumatic etiology. After the valve involvement in the patient, the next thing to be taken care of in the patient would be the lesion. So whether it will be mitral stenosis or mitral regurgitation, one, you have to remember that if it is a child, usually the lesion seen is mitral regurgitation, and if it is an adult, then the lesion seen is obviously mitral stenosis, and you can have a combination also. In some MCQs, instead of writing child versus adult, he might say that patient is having active carditis, then the answer would be mitral regurgitation. If he says the word plain carditis, then plain carditis is mitral stenosis. Please remember, active would mean a pediatric presentation in a patient only. So both of these are two different ways of asking the same question. Last but not the least, the surface of the heart involved, that is commissural end, which I've shown in the previous diagram only, is the endocarditis component in the patient. Now, once he has asked you about the endocarditis component, he can obviously ask you about the chorea component also, because chorea is a late feature, and this is due to damage to the caudate nucleus in the patient, that there would be a chorea manifestation in the patient. Once we have remembered the features, then I'll talk about the treatment part. For the treatment of these patients, for the arthritis component, aspirin is fine. For the pericarditis component of the heart, we give steroids, but do not answer steroids for endocarditis, because for valvular lesion, specific treatment is required. Like if it is mitral stenosis, then we will have to go in for a percutaneous mitral balloon valvotomy. We'll have to dilate the valve. If it is mitral regurgitation in a patient, we will have to repair the valve, that is valvuloplasty in the patient. So these are two procedures which are done for valve repair and are not to be answered for the endocarditis component if present. I mean, don't answer steroids for endocarditis. It is specific answers for the valvular lesion that would be manifesting in the patient. However, if he specifies what is the treatment for chorea, the first line treatment for chorea is obviously self-limiting. It should stop on its own. If it does not respond to, or it does not stop by itself, I mean, you notice that a couple of months have passed by, the chorea is incapacitating in the patient, then in those circumstances, you could be giving valproate to the patient. You can also use haloperidol in the patient. But the disadvantage of haloperidol will be it can cause drug-induced Parkinsonism. If in spite of using valproate and even low doses of haloperidol, the disease is persisting, you will give steroids in the patient. This usually is sufficient and controls the chorea component. If you tried everything that I have said, he says the word medically refractory chorea as you would encountered in questions, then for medically refractory chorea, it is intravenous immunoglobulins which are to be used for the patient. So if all else fails, then for the medically refractory chorea component in the patient, the last resort that you shall be using for management of the patient would be IVIG, that is intravenous immunoglobulins for the patient. So for these patients, specific treatments are to be given. Then he can ask you about the antibiotic usage in these patients, that is use of benzathine penicillin. There have been two questions on benzathine penicillin. One, they have asked about management of cardiovascular syphilis, which I'll discuss in the subsequent slide. But here I'm simply saying that I'm going to be using the standard 1.2 million dose. It would be given intramuscularly every 3 weeks. And obviously, I will be doing a AST, antibiotic sensitivity test in the patient before I give this medication to the patient. When it comes to benzathine penicillin, why are you giving this medication? Because you want to prevent the recurrent sore throats in the patient, and the duration of prophylaxis will obviously vary. I know that the standard answer is 21 years. I just want to point to the fact that if he specially mentions rheumatic endocarditis present in a patient and he gives active valvular lesion like MR and he says what is the duration of prophylaxis, then the answer is 40 years. However, if there is no mention of any valvular lesion in the MCQ and he simply says for how long will you give prophylaxis, then it is okay, 21 years. And it is not a guarantee that always heart is involved. Sometimes it could be only arthritis and chorea. So if it is rheumatic fever in a patient, then the duration of prophylaxis is again 21 years. The backup is 10 years and 5 years. whichever is longer. What I mean by whichever is longer is obviously we should give the longer duration of prophylaxis. But you see, though I've said lifelong in the routine lecture, that is not practical, and even a mother would say that. So remember that lifelong is an ideal approach that you have to say to protect yourself from medical legal perspective. But in the exam, when he gives you, you have to answer from what we actually do. That is these guidelines which I've highlighted in the routine lectures also. That is 40, 21, and 21. And if there is allergy documented on a test dose, or penicillin allergy is documented in the case, then in those circumstances the antibiotic obviously has to be changed, and the antibiotic that is to be given in these circumstances would be macrolide, and one of the common macrolides that would be used would be azithromycin in the patient. The duration would obviously remain the same for this particular case. Coming to the next slide, I have talked about benzathine penicillin to be given in case of rheumatic fever, but this time we will be talking about giving benzathine penicillin in a patient where there is a presence of cardiovascular syphilis. The dose which is to be given here is 2.5 million units, and it is to be given intramuscularly for a total of 3 weeks in a patient. Remember the standard questions that they were asking earlier was for neurosyphilis. For neurosyphilis, we are supposed to use penicillin G. Penicillin G would also be called as crystalline penicillin, or would be called as aqueous crystalline penicillin. So the basic point is that if we are giving intravenous penicillin to the patient for a duration of 2 weeks, that would be answer for neurosyphilis. But currently they have started asking not regarding primary and neurosyphilis, because that's very straightforward. Now, we in the table we usually focus on the first two parameters, that is management of primary syphilis, which is a single dose penicillin of 2.4 million units, or for that matter of fact neurosyphilis, which is intravenous penicillin. They had asked about especially latent syphilis from the late perspective, or for that matter of fact cardiovascular syphilis, then it is IM 3 weeks for the patient. The concepts to be remembered are benzathine penicillin is to be answered for 3 scenarios. 1, it is given as a single dose in post-streptococcal glomerulonephritis. That's a single dose that is given because most of the time the nephritogenic strains contribute to pyoderma, and that is where we will use BP, benzathine penicillin, in the patient. Then the second aspect is rheumatic heart disease, where the dose would be given 3 weekly to the patient, and this would be depending on the involvement of the heart, 40 years or 21 years respectively, as discussed in the previous slide. And right now I have discussed that if a person is having cardiovascular syphilis or a latent syphilis, then benzathine penicillin is given. That is total of 3 dosages given at a gap of 1 week, and the dose is 2.4 million units. So that's the basic point that I wanted to remember for BP and its usages in different scenarios. Coming to the next slide, they have asked regarding the axis aspect. So let's just quickly practice the axis aspects before you. How to look at the axis in the exam. You have to have a quick look at lead number 1 and AVF, and you need to first put it the positive negative like you do in a mathematics class, that is on the x-axis and the y-axis. When it comes to the y-axis, I want you to remember that the positive is inferior instead of being superior, and the normal cardiac axis would be falling in the range of -30 to 110, though some books say -32 plus 110. This is definitely the normal axis of the heart. Now what we will do is we'll look at the 2 ECGs. The first one you will notice is having lead 1, and the difference of the vectors of R minus S is positive, because you can see R is much taller than the S wave. But when you look at lead number AVF, you will notice that AVF, the S is deeper, the vector of R minus S is negative. So we are now going to plot this positive and negative on this recording. When I plot it, first positive for lead 1 and negative for lead number AVF, and if I join the two, then the axis will point superior to the normal quadrant. This would be called as left axis deviation. Usually conditions that are having enlargement of the left side of the heart will contribute to left axis deviation in a patient, like hypertension patients or aortic stenosis patients, hypertrophic cardiomyopathy. They all would cause a left axis deviation to occur in a patient. From pediatrics, it could be ostium primum variety that can be associated with left axis deviation. Let's do this activity once again. This time I'll be using a different color to highlight for the findings in the patient. Like you can see that the lead 1, the S wave is deeper than the R wave's height, so R minus S vector is negative. Now you will move on to lead number AVF, and you can see that in AVF the vector is relatively taller, R minus S is positive. So all I'm going to do in the patient is plot this data of lead 1 being negative and lead number AVF being positive. So if I join this, you will notice that the axis will be pointing exactly opposite to where I drew initially. That was in red color, left axis deviation. This would be called as right axis deviation. This would be encountered in COPD patients, pulmonary artery hypertension patients, ostium secundum variety of ASD from pediatrics perspective. Conditions causing enlargement of the right side of the heart will cause a right axis deviation. Axis deviation is mainly calculated to identify whether a patient is having enlargement of any particular chamber. The chamber criteria are different, and echo is more sensitive than ECG for the same, but this is still, historically discussed, so you should be aware. And in the exam, he simply mentioned that AVF, if you plot it like this, you will notice that lead 1 was what I had drawn initially, and this is lead number AVF. So he simply said in the paper that lead AVF vector is 90 degrees. Lead AVF vector is 90 degrees. That is a normal axis in the patient. Lead 1 axis is 0. And if lead AVF is 90 degrees, all I'm doing is that I'm putting this degree values here before you. You just need to remember it from the degree perspective. This would be 0, 90 obviously. This would be 180, and superiorly would be minus 90. Why? Because sometimes instead of asking you left axis or right axis deviation, he can just give you values in degrees. Like you can say lead 1 vector is 0 degrees, AVF is 90. What is the normal axis? The residual axis is obviously normal in the patient. So axis deviation, I think, is very straightforward, and you can easily identify that. Ventricular tachycardia will always be having an extreme axis deviation. If both vectors are negative, then if the quadrant falls in this direction, then the term used is EAD, extreme axis deviation. There was one question that was asked as extreme axis deviation can be seen in. The answer would be a ventricular tachycardia. Though, lot of conditions can cause extreme axis deviation. One of the important causes is VT, that will cause all the vectors to turn negative in the patient. Moving to the next part of the discussion, we will talk about presence of one, as you can see, these erythematous macules in the sole of the foot of the patient. That would be Janeway lesions. Rod spots cannot be actually commented on this particular diagram because they are obviously to be felt. Coming to the next slide, you have to remember the next topic for revision, that is infective endocarditis. This would be characterized by vegetations on the heart valves that can definitely cause mayhem, and they would be both embolic and immunological manifestations. One of the embolic manifestations that can be occurring in the patient is Janeway lesions, which would be reddish macules that would be seen on the palms and the soles of the patient. And second one would be a immunological manifestation that would be called as rod spots, which can be evaluated on a fundus examination of the patient. Do not be under impression that rod spots are seen only in infective endocarditis. They are also encountered in blood cancer, that is leukemias. They are encountered in patients with lymphomas. Even something as simple as anemia you could be having is presence of rod spots. So alone rod spots can never be a major criteria. It's always a minor criteria for diagnosis. For the topic of infective endocarditis, you should be remembering the organisms first. For acute bacterial endocarditis, if it is community acquired, specially mentioned in the question, then obviously the answer should not be given as Staph aureus. For community acquired, it would obviously be Streptococcus in the patient. Otherwise, the standard hospital acquired would be obviously Staph aureus. Now, if they ask you about the sub-A variety, that is subacute bacterial endocarditis, the organism would be viridans. If they ask you about an IV drug user who has damaged his right-sided heart valves, then the leading organism for IV drug abuser having right-sided endocarditis would again be Staph aureus. Remember the fact that for IV drug users, it is not epidermis, it is Staph aureus which causes right-sided endocarditis. Then is prostatic valve endocarditis and left-sided endocarditis. Left-sided endocarditis would be possible only if a person is having a congenital heart disease by the name of patent fossa ovalis, so that the infection in the right side of the heart can go to the left side and then can damage the mitral valve of the patient. The organism responsible for left-sided endocarditis will also be Staph aureus, because IV drug users are the ones which are mainly gonna be having left-sided endocarditis. If it is not given in the option Staph aureus, then the answer would be given as Enterococcus. As far as prostatic valve endocarditis is concerned in a patient, it would either be early onset or it would be late onset. In early onset, for the first within 2 months of undergoing a surgery, versus late onset, the organism will automatically change. For early onset, one of the leading organisms is cons, that is coagulase negative staphylococcus, and for late onset, it would be streptococcus viridans only, which is the one which is responsible for causing subacute bacterial endocarditis. Once you remember the organism aspect, then you have to remember the diagnostic criteria, that is Duke's criteria. I got a lot of messages, people saying that, sir, in Duke's criteria, you did not mention splinter hemorrhages. Doctor, splinter hemorrhages are not given in Duke's criteria in the current edition of Harrison. One reason for that can be splinter hemorrhages can be due to trauma. Splinter hemorrhages can be even in parasitic infestations. So something as simple as parasitic infestation, if it can cause a splinter hemorrhage, it would not be included in the Duke's criteria, the modified Duke's criteria. I'm talking about the ones which are given in the current edition of Harrison. So the point that I'm trying to make before you is the fact that we have to go by the standard data that is given in the textbook. And for the modified Duke's criteria, the major ones are mainly related to blood culture and echocardiography. When I say blood culture is obviously integral for diagnosis of infective endocarditis topic. We obviously need to take multiple samples and a couple of them should turn positive. But they have asked that in which situation would you be taking a scenario where only if one culture report is positive and still you will consider it to be a diagnostic criteria. Coming to the diagnostic criteria of this condition, the major ones, we have to remember aspects related to blood culture and echocardiography. For the blood culture component, I want you to remember that ideally we should be taking at least 3 sets of 2 bottles each, and ideally 2 sets to turn positive out of 3. But the only one where only one culture is taken to be sufficient for diagnosis of infective endocarditis is with respect to Coxiella. This is what I said, 3 sets of 2 bottles each taken at a gap of at least 1 to 2 hours, at least minimum 2 hours gap. Why the gap is there is because you want to demonstrate that the heart is pumping bacteria into the systemic circulation of the patient. Ideally, 2 sets out of 3 should be positive, and both sets should be positive with the same organism. That is, if first set is Staph aureus, then second should be aureus also, otherwise it could be contamination. 1 out of 3 positivity was asked in the last time's NEET exam, that is only valid for Coxiella burnetii. Where did Coxiella burnetii come from? So it is a zoonotic infection. It came from animals. Like this patient of rheumatic heart disease, he stays in village, and in village like in India, they keep cattle in the house. So from the cattle, he could have got this infection. So 1 out of 3 positive is Coxiella burnetii. And then you have to do echocardiography in the patient. Echocardiography in patients of infective endocarditis would be revealing the following features. One of them could be that the patient could be having vegetations visualized, but the size of vegetation should obviously be big. Only if the vegetation is more than 2 millimeter, it can be seen on echo, otherwise the echo would be blind to it. Then there could be a perforation in the valve leaflet. The blood will leak from the perforation into the chamber of the heart. Then it could be possibly a valve abscess or ring abscess. So these words, if written in a question, are to be taken as a major diagnostic criteria. Because of the perforation, there will also be leakage of blood, so there would be a presence of a new onset murmur in a patient of pre-existing heart disease. These are 3 major diagnostic criteria. You will notice that terms like rod spots, Janeway lesions, they're all included in the minor criteria for this one. So after the major ones, we'll talk about the ones which are minor ones. One, you obviously need to demonstrate the predisposition in the patient. The predisposition would mean that there should be a presence of, let me say, IV drug usage history in the patient, or he can mention dilated cardiomyopathy, rheumatic heart disease. There has to be demonstration of fever on at least 2 occasions. The fever should be more than 101.3 degree Fahrenheit, and it should be at least 2 times with help of a digital thermometer, that we should be able to demonstrate that it's a febrile state in the patient. Then would be immunological features. The immunological ones which are to be remembered are Roth spots, ossular nodes, and glomerulonephritis. Alphabet R stands for Roth spots, and alphabet R also stands for positive RA factor. So you will notice the fact that he has written a biologically false positive RA factor in the literature of endocarditis. O would stand for ossular nodes, which would be feeling as P-shaped nodules. These P-shaped nodules are felt in the pulp of the fingers of a person of endocarditis. G would stand for post-streptococcal glomerulonephritis, that could result in hematuria in the patient. Then obviously you could be having embolic manifestations in the patient. One of the embolic manifestations, and very classical, is what I showed you in the previous slide on the sole of the foot of the patient. These are reddish macules which are called as Janeway lesions. Another one from the embolic manifestation to be remembered would be a development of mycotic aneurysm. Mycotic aneurysm would imply that there is a, I would say, dissemination of infection from the heart to the brain. So there's an aneurysm in the brain, and if it ruptures, it can contribute to even a intracerebral or even a subrecurrent hemorrhage in a patient. So the main point is that there is dissemination of infection out of the heart of the patient, but splenomegaly is not included in the diagnostic criteria, and neither is clubbing. So in embolic manifestation, do not answer spindle hemorrhages, do not answer splenomegaly, do not answer clubbing. Then would be blood culture not meeting the major criteria. Like, let me say you took 6 samples in the patient and only 1 bottle is positive. Now, if 1 bottle is positive, it could be Vadan, 1 could be contamination, or it could be a possibility that, you did not take the sample properly, so therefore the processing problems were there. So, blood culture not meeting the major criteria can be taken as a minor one, and then antibiotic treatment can definitely be initiated in the patient. Usually, the antibiotic treatment will have to be given for at least 3 weeks. You have to give appropriate antibiotics to the patient, because culture sensitivity report will come from the microbiology department after about 3 weeks. The management of this condition would be IV antibiotics. You will have to give intravenous antibiotics to these patients for at least 3 weeks. These should obviously be appropriate antibiotics. And how do you know these are appropriate antibiotics? You will have to wait for the culture sensitivity report from the micro department, which will usually take about 72 hours to appear. And if you give appropriate antibiotics, then patient will become afebrile, ideally within 7 days, which means that the patient's treatment is right on track. Infective endocarditis, unfortunately, if even after giving appropriate antibiotics, you are noticing the fact that the patient is not becoming afebrile, it indicates that he could be having a valve abscess. Now, this is a nightmare situation for any doctor, because if there is a valve abscess, even if you give the best antibiotic to the patient, the antibiotic will not penetrate into the area where there's an abscess, because obviously antibiotic goes into those areas which are very having a good blood supply, and abscess is all walled off. So in those circumstances, you might say what antibiotic can be added, and that could be rifampicin, that could be added for valve abscess. And if the valve abscess does not respond, in a sense that you have given it rifampicin, you've given all the antibiotics, appropriate ones, and still the patient is febrile after 7 days, then you might have to consider surgery, because the valve tissue is septic in the patient, so you will have to excise that septic tissue. So it's going to be very dangerous surgery, because there could be embolism of the septic foci into the brain. And even without surgery, he's anyway going to have any kind of a cerebral event, so we will have to anyway excise the septic tissue in the patient. Most of the time we will be having a good prognosis in this patient, though they can sometimes ask you regarding culture negative endocarditis. However, if he asks you regarding culture negative endocarditis, then the organisms to be remembered are HISA group of organisms. The treatment of choice for these patients would obviously be cefotaxime, or we can use ceftriaxone. Normally, traditionally, ceftriaxone is for cerebral infections or for meningitis, but cephalosporins are being used here. Alphabet H would stand for Haemophilus. Aprophilus, this is a tongue twisting name, so that's why it's not Haemophilus influenzae, it is Aprophilus. A would stand for Aggregatibacter. I mean, he will usually not use the word Acinetobacter, but he will use the word Aggregatibacter species. C would stand for Cardiobacterium hominis. Slightly a tongue twisting name, but that is what he wants, that these tongue twisting names would upset your rhythm. Then would be Echinella corrodens. And last but not the least would be Kingella. These are the organisms which are to be remembered for HASEK group of organisms, HACEK, and cefotaxime would be useful for these patients. Then he can also quiz you about sterile endocarditis. The sterile endocarditis to be revised are Libben-Sachs endocarditis. Libben-Sachs endocarditis can involve any surface, but if inferior surface is involved, then there would be valvular regurgitation. The usual valvular regurgitation can be MR in the patient, for which the repair has to be done. So for Libben-Sachs endocarditis, do not answer steroids, but answer valvuloplasty. Another one to be remembered is non-bacterial thrombotic endocarditis. In this particular case, the vegetations occur on the lines of closure. And in these particular patients of non-bacterial thrombotic endocarditis, the usual cause is malignancy, which would be blood cancer like acute promyelocytic leukemia, or could be like ovarian cancer or a pancreatic cancer. So we have to treat the cause. And last but not the least, in sterile endocarditis, you will have to remember regarding rheumatic endocarditis, which will be having Ashkoff nodules. The location of the Ashkoff nodules would, however, be on the commissural ends. These three are examples of sterile endocarditis. Whereas the previous discussion was a quick revision of patients who are having an infective endocarditis process. Also remember the fact that when it comes to the topic of sterile endocarditis, it would be, I would say, comparison wise more frequently asked as compared to infective endocarditis, because he would like to ask you regarding the pathological correlates here as well, which would be, I would think that's straightforward to answer. Revising the next aspect, we'll talk about congenital heart disease. One that is obviously of interest to us here is a cyanotic heart disease by the name of tetralogy of Fallot. Now, this is one of the most important cyanotic heart disease that is usually asked, and you can notice that the patient or the child is exhibiting squatting episodes. Squatting episodes will reduce the cyanotic spell in the patient. Like usually these children have cyanotic spells. So squatting episodes are like the child when he squats like this will result in compression of the femoral artery. And by compression of the femoral artery, the severity of the TET spell in this particular condition will reduce. TET spell is also called as hypercyanotic spells in the patient. For management of TET spell in a patient, if he says what is the first line management, it is a knee chest position or a squatting that can be done. Then the second thing that should be done for management TET spell is use of morphine. The third thing to be done in this particular case would be to give soda bicarbonate to the patient because there is severe metabolic acidosis in the patient. And then we can give a drug which can cause a slight increase in blood pressure of the patient. This increase of blood pressure will result in reduce in the shunting in the heart, because if you increase the blood pressure slightly, then the left ventricle will have to apply more force to overcome the resistance, and if left ventricle pressure will increase, then the shunting from right to left will also reduce. So for management of a TET spell, we use the following drugs, and not used was asked, that is calcium chloride. Obviously calcium chloride is used in hyperkalemia, and there is no role of calcium chloride in management of a TET spell. Also, the murmur during the TET spell of the patient will become relatively softer. In fact, for that, I can just represent a diagram before you, though I have told you the answer to the question that was asked. And in revision program, we mainly try to focus on the hardcore facts only. But this, I'll just invest a few seconds to explain to you why the intensity of the murmur will reduce. You see, all patients of tetralogy Fallot will be having a VSD with a concentric right ventricular hypertrophy. So what I have once shown is that in this person, the problem is not in the orifice of the pulmonic valve, it's a subpulmonic stenosis, as you know. The most important determinant of cyanosis in a child of cyanotic heart disease, that is tetralogy of Fallot, the most important determinant of cyanosis is subpulmonic stenosis, which will limit the amount of blood that can go from the right ventricle into the lungs of the patient, and this will also result in a murmur that would be a ejection systolic murmur, because I am showing the blood is going into the pulmonary artery, so it has to be ejection systolic murmur. You can see that in patients of tetralogy of Fallot, deoxygenated blood can go from the right ventricle to the left ventricle, which explains the fact that why in these patients central cyanosis is present. Now, what happens in a TET spell is that the amount of blood going into from the RV to LV will increase further. You can see that there is more shunting happening now into the left side. So the cyanosis of this patient will increase so dramatically that the lips of the patient will turn blue and might even look black. Like in this child, you can see that the lips of the patient are turning blue to the level that their lips are looking black. You can see the visible distress on the face of the child. Now let us see what happens when there is a TET spell happening. If you focus on the diagram, you see there is limited blood in the right ventricle. If blood of the right will go to left, then the amount of blood that would go into the lungs will further be reduced. I have slightly modified the diagram now to show to you that during the episode of TET spell, more blood will be going from the right ventricle to the left ventricle, so the blood going to lungs will be lesser. If less blood will go in the lungs of the patient, the murmur will also become relatively softer. So the question was that with respect to a TET spell, what happens to the intensity of ejection systolic murmur? Then there is a significant reduction in the intensity of a high-pitched ejection systolic murmur during episode of a TET spell, and the lips of the child will turn blue. What you will do to decrease the TET spell is you should increase the pressure in the aorta. If you increase the pressure in aorta, left ventricle pressure will also increase. You can see that if this pressure of the left ventricle is increased by you, it will obstruct or it will try to reduce the shunting of blood, and that is what the child is automatically doing by compressing his femoral artery. So you can see that the child is here exhibiting a squatting episode, and this would usually result in a self-termination. If not, obviously, you will have to use the maneuvers that I have explained to you. If the question is asked as what is the drug of choice for management of tetralogy of Fallot, then we will be giving alprostadil to the patient. This is obviously to be given in the first week of life only, immediately after birth, to keep the ductus open. So ductal patency has to be maintained in this condition. Failure to maintain ductal patency will result in occlusion of the ductus, and subsequently the tetralogy of Fallot manifestations will usually occur in the patient. Tetralogy of Fallot never presents on day 0 of life, right? It always presents after day 7 of life. Why that is so is because of this quick diagram that I can make before you. I am once again showing before you the defects in tetralogy of Fallot. One of them is obviously a VSD, but the major determinant of cyanosis is not VSD, it is a subpulmonic stenosis. If you look at this representation, you will realize the fact that in these patients, the amount of blood that goes into the lungs of the patient is very limited. Majority of blood that going across into the pulmonary artery of the patient is across this gradient, which is offered by the hypertrophied ventricle of the patient. Now, this is the pulmonary artery bifurcation. There is an anatomical structure that I am highlighting before you, which is called as ductus arteriosus, and that begins to close after birth. So let's have the ductus arteriosus now in picture. This ductus arteriosus is connecting the descending aorta to the bifurcation of the pulmonary artery. What I am saying is that all the blood that will go down into the aorta will obviously be contributing to cyanosis, but due to the pressure difference here, this blood, which I am showing in blue color, will be moving across like this into the lung circulation of the patient. Once this blood will go into the lungs of the patient, then this blood will get oxygenated, and therefore I can say in this diagram that oxygen-rich blood will now be entering into the left side of the heart. So because there is a oxygen-rich blood that I have shown here, at least being able to come across on the left hand side, the cyanosis in this patient may not be visible on day 0. I will now put a cross to say that the day the ductus will close, then all the blood going to lungs like this will be stopped, and that is when the availability of oxygen on this side will also reduce, and that is when cyanosis will come. The functional closure of ductus arteriosus usually occurs by day 7. Because the functional closure of ductus arteriosus usually occurs by day 7, since there is now no flow of blood occurring across this anatomical structure, therefore the availability of oxygen-rich blood to the left side will also reduce, and therefore cyanosis will become visible in this particular child. So tetralogy of Fowler does not present with cyanosis right on day 0 of life. It is cyanosis after on day 7 of life. If the question begins by saying there is cyanosis in a baby on day 0, then the answer should be thought of as TGA, that is transposition of great arteries, where the presence of cyanosis will be very severe right on day 0, and the possibility of mortalities will also be very high. So TGA per se is also going to be managed with the alprostadil only, but that's the only way we can make these children survive. Otherwise, the severity of cyanosis is such that these children usually tend to die. The shunt diagram of TGA can also be quickly revised. Coming to the next slide, we will talk about TGA, that is transposition of great arteries, which will present with cyanosis on day 0 of life. Let us see a quick why there is a cyanosis on day 0 in this particular patient. That will make you more comfortable to answer the exam. You can see that in this case, the aorta will be originating from the right ventricle of the patient. And in this particular case, the pulmonary artery is originating from the left ventricle of the patient. Now that is grossly abnormal. That's why we call it transposition. What's going to happen in this condition is that all the deoxygenated blood will enter into the right side, go to the right ventricle, but now unfortunately it will not go to lungs, but via the aorta will go back to the body and will again come back to the right side of the heart of the patient, whereas the oxygenated blood that will be present in the lungs of the patient will come to the left side, but unfortunately will not go in the body, will again go back to the lungs. So there are two parallel circulations here. The two parallel circulations, one is contributing to blood to go into the aorta and second is in the lungs, but obviously deoxygenated on one or oxygenated on the other. Now let us see where the mixing occurs in this case. So I'm now going to create an anatomical structure that would be connecting the two. This anatomical structure that is connecting the two is ductus arteriosus. This is the saving grace. This is where the mixing can occur in this patient, that in this particular case, the blood of the lungs can get access into the aorta of the patient. So I'm now showing oxygenated blood traveling like this. This oxygenated blood is being powered by the left ventricle. So it will be going into the aorta of the patient and therefore will ensure survival in this particular case. But the moment it closes, again the patient will die. So ductal dependency is definitely a feature even of this condition. The ductal dependency of this patient will ensure that why are you giving alprostadil to this patient to keep the patient's ductus arteriosus patent, and therefore at least some shunting will occur. A lot of these children might be born with a VSD, a lot of them might be having a ASD. Now obviously if there is a VSD or ASD, that will improve the mixing in the heart of the patient, and therefore the chances of mortality would significantly be reduced in the patient. The chest X-ray finding of transposition of great arteries should be remembered by you as egg on side appearance. A related MCQ is egg in a cup appearance. Egg in a cup appearance is encountered by you in a patient having constrictive pericarditis, and egg on side is a feature that is seen on transposition of great arteries in a patient. These patients' X-ray can be compared with that of boot-shaped heart. Boot-shaped heart is an X-ray that is very classical and is encountered in patients of tetralogy of Fowler. In fact, we can just look at a couple of the X-ray findings which are to be remembered for the paper for congenital heart disease. Chest X-ray finding of box-shaped heart has been asked, which all of you know is Epstein anomaly, which would be a teratogenic effect that would be seen in those circumstances where the mother is taking lithium, a teratogenic molecule. The problem in Epstein anomaly would be inferior displacement of the tricuspid valve, and that would be associated with tricuspid stenosis as well as regurgitation in the patient. Then is figure of 8 appearance. That is a feature of TAPVC, that is total anomalous pulmonary venous connection. And then would be boot-shaped heart, which is due to right ventricular hypertrophy of the concentric variety that is encountered in patients of tetralogy of Fallot. After the egg-on side appearance of transposition of great arteries, you should also be able to pick up the boot-shaped heart, which is present in tetralogy of Fallot. In this particular case, you can definitely see that the apex of the heart is slightly lifted upwards, especially due to right ventricular hypertrophy, because right ventricle is actually not on the right. It is positioned in such a fashion that it will lift the apex upwards. This represents boot-shaped heart in contrast to egg-on side appearance of TGA. Then you should also be remembering regarding the radiological finding of a box-shaped heart, which is a characteristic feature encountered in Epstein anomaly. In fact, we can just make a quick practice here of the remaining names that is to be remembered. With the chest X-ray finding of a figure of 8 appearance, which is very classical only for supracardiac variety of TAPVC. The cardiac and the infracardiac varieties do not have a figure of 8 appearance. Box-shaped heart would be encountered in Epstein anomaly. That would be a teratogenic event that would be seen if the mother happens to be taking lithium. Like this is a case of maniac depressive psychosis, accidental pregnancy. She was taking lithium, so the baby ends up with the Epstein anomaly. These are some radiological findings that you should be aware of, and let's now just quickly practice regarding the features of L2R shunts versus right to left shunts. The L2R shunts will always present with congestive heart failure, and there would be recurrent pneumonia episodes developing in the patient. This is due to the pulmonary plethora, that there is excessive blood supply. Whereas when it comes to the right to the left-sided shunts occurring in a patient, then in these circumstances there would obviously be cyanosis and a possible TET spells in the patient. There would be failure to thrive as well. This is secondary to the fact that there is hypoxia present in the patient. Now when it comes to the left to right sided shunt, the possibilities can be a VSD, it could be a PDA, it could be ASD. For right to left, it could be tetralogy of Fallot, it could be tricuspid atresia, or it could be Epstein anomaly given in the question. For VSD, the usual age of presentation is 6 weeks. PDA in a preterm baby will be right at birth. In term baby would be 6 weeks, and ASD can present as late as 5 years of age. Tetralogy of Fallot usually be present by the 7th day of life. Tricuspid atresia can present right at birth. Epstein anomaly, the presentation of the patient can be variable. It could be at birth or even later as well. The highlight of patients having a VSD would be abnormality in the second heart sound. VSD will always be having a wide variable split second heart sound. PDA will be having a narrow split second heart sound, that is because of the left ventricular failure. And ASD will be having a wide fixed split second heart sound. When it comes to tetralogy Fallot, the finding of tetralogy Fallot will be single S2. In this particular case, why I'm saying single S2 is because P2 will not be heard because there is a subpulmonic stenosis. So one, I've shown P2 to be very small in alphabet size. Why? Because the intensity says so less that you're not able to appreciate it. In tricuspid atresia, what will happen is that all the blood of the right will go to the left side. So rather you will be having a presence of a single S1 in the patient. The reason for single S1 is explained by the fact that in this case, there would be no T1 happening, only M1 would be happening. M1 would be louder in the patient. So it is a single loud S1. And along with this, obviously, there would be a single S2 also because there is no blood going into the lungs by the root of the pulmonic valve. So single S2 is a feature of tetralogy Fallot, but single S1 and single S2 both given, that is feature of tricuspid atresia. I repeat again, in tricuspid atresia, no T1 is heard. And when it comes to obviously the blood supply in the lungs, the pulmonic valve is also not having sufficient flow across to represent a P2 in the patient. For Epstein anomaly per se, I can say that there would be a presence of a tricuspid regurgitation in the patient, so that can result in a soft S1 to develop in the patient. Once I have mentioned aspects related to heart sounds for these patients with S1 mainly coming for the right to left sided shunt, we will quickly revise regarding the murmurs that can be anticipated in these patients. In VSD, it would be a pansystolic murmur. Patent ductus arteriosus would be a continuous murmur. ASD, when it comes to shunt murmur, the shunt murmur is silent. There is no shunt murmur in atrial septal defect in the patient. Why? Because the pressure difference between the left atria and the right atria is very less. The murmur or tetralogy of Fallot would be ejection systolic murmur. For tricuspid atresia, it would be a flow murmur. It will be a mid-diastolic murmur which is heard across the mitral valve of the patient. And in Epstein anomaly, if there is a tricuspid regurgitation, there could be a pansystolic murmur that could be appreciated in the patient. The investigation choice for all of them would be echocardiography. For ventricular septal defect, the specific treatment would be to use Dacron patch that would close the defect between the left and the right ventricle. For patent ductus arteriosus, for preterm babies, it is ibuprofen or indomethacin. For term, it is surgical ligation. For AST, the treatment of choice is occlusion device that will help you in closure of the defect. For tetralogy of Fallot, initially it is alprostadil, and then there's a surgery that is done that is called as Blalock-Taussig shunt. Blalock-Taussig shunt is a palliative procedure that would also be helping in patients who are having tricuspid atresia. When it comes to repairing these defects, especially tricuspid atresia and Epstein, it is a very complex procedures that are to be followed. So the mortality rates in the patient would be higher. And you will notice that in this table, I have not included TGA and TAPVC. Why? Because they are mixed defects. What I mean by mixed defects is that in a single patient, you would be having features of left to right also, as well as features of right to left also. So combination of features would be seen. Left to right will always contribute to development of heart failure findings in a patient. Right to left would result in cyanosis in a patient. So if you get a question where both heart failure and cyanosis is given together, then you have to think in terms of TAPVC and transposition of great arteries in a patient, where X-ray findings if given would definitely help you. Or for that matter of fact, small itsy-bitsy aspects like ASD is associated with total anomalous pulmonary venous connection. So he might mention the word wide fixed split second heart sound, which is valid for patients having a total anomalous pulmonary venous connection, but not for transposition of great arteries in the patient. So these would be some shunt defects or congenital aspects that have to be revised by you. You can quickly look at the X-ray of the figure of 8 appearance in a patient, also called as a snowman heart. This is for the supracardiac variety. That's the commonest variety and also has a relatively better prognosis as compared to the other ones which are having a relatively, I would say, a bad prognosis. And last but not the least, a quick revision at the aspects of the heart sounds also. When it comes to the second heart sounds in a patient, usually they will ask you regarding wide split versus narrow split second heart sound. So wide split is the one which is anyway to be catered. We are going to subdivide this into the variable split and fixed split in a patient. For fixed split, remember, it is always going to be AST or it could be a massive pulmonary embolism. There's a huge clot in the middle of the pulmonary arteries that is obstructing the pulmonary artery of the patient. So in those circumstances, the amount of blood going in the lungs will be equal in inspiration expiration because the clot will limit how much blood will go in the lungs of the patient. For variable, it would be ventricular septal defect or mitral regurgitation in a patient. Then ASD in the question can be written as Down syndrome or Luton-Baker syndrome, which is a combination of ASD with mitral stenosis. Or it could be written as Holt-Oram syndrome, that is ASD with skeletal defects in the patient. Then we'll incorporate the words bundle branch block also. Variable split would be a right bundle branch block. Why? Because the delayed impulses on the right hand side would cause a delayed P2 and then respiration effect would anyway come in. When it comes to narrow split second heart sound, narrow split second heart sound is one encountered in valvular aortic stenosis and subvalvular aortic stenosis. Any cause of left ventricular failure would result in development of delay in A2, which will result in lesser gap present between the A2 and the P2 of the patient. Then is left bundle branch block, which would be responsible for this manifestation in the patient. Max to max, what he can ask you is, though I've drawn this diagram earlier, I just want you to pay attention to the current sketch. This is SA node, AV node. Then the information goes into the bundle of phase, the two fascicles, left and right. Then goes to Purkinje, like this we have studied. And then you can see that I've shown once again before you WPW syndrome. In patients with WPW syndrome, you can see that I have shown a fascicle which is connecting to the left side of the heart. So I'm going to call it WPW type A. And if the fascicle was on the current contralateral side, then I will call it WPW type B. Now the concept is that WPW type A will be causing first activation of the left ventricle, and then the current will travel by the myocytes, and there would be activation then of the right ventricle of the patient. So I can say that this will behave like a right bundle branch block. Why it will behave like a right bundle branch block? Because the impulse will go to the left side normally, but then the right side impulse will be delayed. So because it will behave like right bundle branch block, I will have to incorporate the word WPW type A, which would also be having a wide variable split. That would be with respect to patients of WPW with a left-sided fascicle. If patient is having WPW type B, then you can see that the fascicle would be right-sided. Then I'm going to call it WPW type B, and now the impulse will first go to the right ventricle and then impulse will go to left ventricle. Normally both ventricles get the impulses simultaneously. Here first impulse will go to the right ventricle and then to the left. So WPW type B will behave like left bundle branch block, and therefore this will be having a narrow split second heart sound. So the information that I've added would be WPW type B here. WPW type A is more common as compared to type B. All you need to remember is that the type A variety behaves like a right bundle branch block. Why? Because the impulse first goes to left, then goes to right. So there's a delayed impulse provided to the right hand side. This is a table for second heart sound that you're familiar with. We can now work out the information for first heart sound also. For the first heart sound, usually the question will be asked to you with respect to narrow split first heart sound. The classical example of that would be mitral stenosis. Why there would be a narrow split in mitral stenosis is simply based on the fact that mitral valve will close relatively later. In fact, it could also result in single S1 in the patient, and it could also result in reverse split in a patient, that is T1M1 in the patient. So especially for mitral stenosis, you have to remember the following facts. Mitral stenosis not only has a loud S1 and a soft S1, soft to denote the calcified mitral stenosis component, but you have to remember the remaining aspects of narrow versus single versus reverse split that would be present in S1 in the patient. Then single S1 is also read in pediatrics literature. That would be a patient of tricuspid atresia because there is no tricuspid valve. So therefore patient will be having all the blood going across the mitral valve only. So mitral valve component will be accentuated and the T1 component will not be heard. Like normally we call it M1 T1. Now I'm saying M1 part is louder and the T1 part is not heard at all. So that would be tricuspid atresia causing a single S1 to be occurring in the patient. Then the aspects of loud S1 in physiology etc. is not important. In the perspective, that's very simple. Third heart sound is mainly to be remembered for conditions where there's a dilatation of the heart like dilated cardiomyopathy, heart failure, cor pulmonale. Any condition contributing to failure of the heart of the patient, whether he writes the word pulmonary embolism of the massive variety or he writes cor pulmonale plain, is dilated heart, that would be third heart sound in a patient. Fourth heart sound would be found in conditions where there would be a presence of a left atrial hypertrophy. Conditions of left hypertrophy are aortic stenosis, HOCM and hypertension. Conditions of hypertrophy of the right hand side would be pulmonic stenosis, pulmonary artery hypertension and tetralogy of Fallot in a patient, or I can just put the gross word subpulmonic stenosis due to any etiology can contribute to fourth heart sound to develop in the patient. And then I'll add a word pericardial shudder. Pericardial shudder occurs at the same time as S3. This is an auscultatory finding of constrictive pericarditis. So whenever you read S3, you will always read pericardial shudder present there in the literature of third heart sound only because it occurs at the same time. Tumor plug sound is a feature of atrial myxoma, which I can mention in the end. Tumor plug sound is an auscultatory finding of a benign tumor of the heart, atrial myxoma, which is associated with development of leukemia. So these are some aspects which I've tried to make you remember. And once you have done that, obviously you have revised the basic data, then you can go ahead with the questions also. And don't bother if you find a rare aspect in a question. You see, most of the time the point is that there will always be some standard information in the question, at least for two choices, and the remaining two would be a little atypical, one offbeat. You just need to practice continuously, and then your eyes will start automatically going to the right answer. Okay guys, next we shall be revising regarding aspects related to rheumatology. As you can see a very oft repeated image where you can notice a rash on the face of this lady, having a very characteristic butterfly distribution. In fact, if I mark it, you can see that the cheeks of this patient are very characteristically inward. Then is the bridge of the nose of this person, and then the contralateral cheek of the patient as well. So this is going to give it a characteristic butterfly rash distribution. Most of the time in patients of SLE, even the earlobes can be involved. Sun exposed parts are the ones which are usually having the presence of a rash, and if you compare this image with the one that is given inferiorly, you will notice that the classical butterfly distribution is not being respected. You will notice that there is definitely skin lesions present on the bridge of the nose of the patient, especially the tip of the nose, I would say, going on to the sides of the nostrils and the contralateral cheek also. But in this lady, you are definitely not having that classical butterfly distribution. The question also mentioned that this lady has presented with breathlessness. So the disease that you have to consider in this particular case would be different, that is sarcoidosis. Even if the question did not mention that the chest x-ray of this lady is showing a bilateral hilar lymphadenopathy and the hilar lymph nodes are then pressing on the airways of the patient, we still have to consider this manifestation that I have highlighted before you as that of lupus pernio. Lupus pernio is a skin manifestation of sarcoidosis, which can be worked out on the basis of the clinical history provided. And even if history is not provided, this is definitely not to be answered as a presentation of butterfly rash of SLE. Butterfly rash of SLE is the one which is represented superiorly. So let us quickly revise the clinical findings that are encountered in patients of SLE. So let us revise the features of SLE here, which are remembered by a mnemonic by the name of MDSOSP BRIN. Since they have recently asked about the lung manifestation of SLE, so I'll just state it right away. That is, pleuritis is the most common lung manifestation in SLE. Obviously, the patient would be having a butterfly rash or a malar rash, as I've said. But when you attempt questions, you have to be careful with the fact that he's not using the word malar flush, because malar flush is a feature that you would be encountering in patients of mitral stenosis, and malar rash is obviously a feature of mitral SLE. Then would be discoid rash, and there could be associated alopecia. This would be the non-scarring variety. Then is serositis present in the patient. The serositis that would develop in a patient of SLE could be involving the lungs of the patient as well as the heart of the patient, and therefore the lung manifestation and the heart manifestations of pleuritis and pericarditis. Both would contribute to chest pain, but you can differentiate because the pain of pericarditis will radiate to the left shoulder, pleuritis won't. And at the same time, I would say that the lung manifestation of the patient would be pleuritis and the heart manifestation of the patient would be pericarditis, and both will contribute to development of chest pain, and they can be easily differentiated on the basis of ECG that will be showing ST elevation only in case of pericarditis. If pleuritis will worsen, it can cause a pleural effusion also, and it can also contribute to development of pericardial effusion. A related MCQ to be remembered is serous cavity effusions. When I say serous cavity effusion, obviously I'm talking about pleural effusion and pericardial effusion in SLE, but an endocrine disorder where you have serous cavity effusions and should be remembered is hypothyroidism, where myxedema is the main culprit which is responsible for this serous cavity effusions to develop in an individual. After the serositis component, the next thing to be taken care of is oral ulcers in patients of SLE. Now, abscess ulcers in a normal individual are horribly painful, but in SLE, the abscess ulcers are painless. So that's again an important diagnostic feature, and they could be involving, in fact, they would not be one, they would occur in crops, one after the other. but genitals are not going to be involved here. So remember the fact that if a question begins by saying that there are aphthous ulcers which are present on the oral cavity, obviously, and are involving the vulva also, then in those circumstances, the answer would definitely not be SLE and should be remembered as Behçet's disease. I'll be describing Behçet's in the later part of the slides today, but I want you to remember that aphthous ulcers, painless, specially described, is a feature of SLE. The next thing to be considered in these patients would be development of synovitis. In the current edition of the book, he has removed the word arthritis and has replaced it by the word synovitis, which is mainly to highlight the fact that this would be non-erosive arthritis. In fact, joint problems or joint pain is the most common symptom when it is regarding SLE. He says, which is the most common symptom or symptoms encountered by the patient? It is mostly joint pain and difficulty in mobilization, and large joints can be involved. Small joints of the hands can also be, but knee joint is the one that's usually involved. Then is photosensitivity, which is very characteristic. It's not photosensitivity which is the most common one. It is synovitis and joint pain which is the most common one. Rather, for photosensitivity, he will say which antibody will be causing photosensitivity. So that would be anti-Rho antibody. Then you could be having CNS manifestations in patients of SLE. The number one CNS manifestation is obviously cognition defect, due to which patient could be having forgetfulness. But if he specifies the word lupus cerebritis, then the patient could be having autoantibodies by the name of anti-neuronal antibody. This antibody can easily cross the blood-brain barrier and could cause swelling of the brain, for which dexamethasone would be used in the patient. For lupus cerebritis, it is dexamethasone that is to be used, but we have to be careful that patient may not be having or simultaneously should not be having psychosis, because psychosis will worsen with steroids. If he says, well, how do you manage psychosis? Then it is obviously antipsychotic drugs. We don't give steroids for a psychosis. The antibody which is responsible for development of psychosis would be anti-ribosomal P antibody, a very peculiar name. Anti-ribosomal P antibody is responsible for psychosis in patients of SLE. Then can be renal involvement in the patient, which is one of the important causes of death. I want to make it very clear to you the fact that the cause of death in SLE cannot be generalized overall. It is depending on the presentation. Like in the first 10 years of diagnosis, most of the time the cause of death happens to be infection. In fact, because this happens to be a controversy, I'm just going to show you a snapshot from current medical diagnosis and treatment, which I think I mentioned page number also, is one of the highly, I would say, accurate resources to look for it. Now let's see what it shows, what it says. He says mortality in SLE shows a bimodal pattern. In the early years after diagnosis, it is usually infections which are the leading cause of death in the patient. And if he specifies the word active SLE, because in SLE per se, guys, we give treatment to the patient. We don't let the patient suffer. If patient is not taking treatment, like because you're giving steroids, some doctors, some family doctor of the person said, oh, don't take steroids, there's Cushing syndrome, there are so many side effects. As you know, normally it happens in families, when they discuss about medication, steroids, I mean, you Google the word steroid first, such a result is Cushing syndrome. So people are going to stop taking medication, and then if the active flares will continue, that's when the kidney of this patient will definitely suffer, and there would be a kidney involvement or a CNS manifestation which would contribute to death in the patient. Then in the later years, that's the next point to be remembered, in the later years, that especially after 45, it is atherosclerosis which becomes the major cause of death. So I want to highlight the fact that early years of diagnosis, especially in the first decade of diagnosis, it is infection. If the patient is not taking treatment, he says, followed by active SLE, which is person not taking treatment, then obviously organ failure will occur, no man. Then it is going to be kidney failure in the patient, and later part it is atherosclerosis. So infection and atherosclerosis are two leading causes of mortality, and obviously if a patient is non-compliant, not under your care, then even kidney involvement can contribute to death. Why I'm saying kidney involvement will contribute to death is because patients will require transplantation, they will not have money for it. Hemodialysis itself increases accelerated atherosclerosis. So somebody with a kidney disease will anyway have a bad prognosis. Going back to my original slide, The renal involvement in this patient will be having a lupus nephritis, which will present as hematuria. From the histopathological perspective, one, you need to remember wire loop lesions, which would be beyond the scope of this particular discussion. So please look at the slide from patho by yourself, wire loop lesions. And second is an immunofluorescence study, which shows a full house effect. What do you mean by full house effect? I'll show you a slide in the subsequent part of this discussion. So keep watch for the same. I'll talk about that. What I mean by full house is all antibodies would be positive, and like in the pack of cards, multiple cards turning positive if you play bridge or if you play cards. So let me explain that in the later part of this discussion, the full house effect. But just remember the name IEF study showing full house effect is a feature of lupus nephritis. How would the patient present to you? The patient will be having standard features of hematuria and development of high blood pressure, hypertension, because the glomerular filtration rate of the patient will be significantly reduced. Later on, as the kidney failure will progress, uremic manifestations will start developing in the patient. The uremic symptoms could be in the form of GI symptoms, something as simple as nausea, vomiting, hiccups, because urea will be irritating the diaphragm and the stomach mucosa, and would contribute to GI symptoms. And if it irrigates the pericardium, it will contribute to chest pain in the patient. So initially uremia does not present as oliguria and urea, but presents as GI symptoms and chest pain in the patient, and there's a progressive downhill course because the GFR of this person will progressively reduce, so antihypertensive drugs have to be used. If these patients are not going to take treatment, the GFR will reduce and they might develop even ESRD. End-stage renal disease is defined as glomerular filtration rate less than 15. When uremia will develop when GFR will be less than 15 ml per minute. Once you remembered the renal manifestations of this patient, we move on to the next point of the discussion of this one. That would be that the patient can be having a autoimmune hemolytic anemia. Patients of SLE could be having a Coombs positive hemolytic anemia. There is a AIHA, due to which if you run a peripheral smear of this person, it will be showing spherocytes. Remember my words, in pediatrics, if you read spherocytes, it means hereditary spherocytosis. But in an internal medicine MCQ, if you read spherocytes, it's gonna be always a autoimmune hemolytic anemia. How would spherocytes look like? Suppose these are the RBCs. You will notice some RBCs which are smaller and they lack a central pallor. So when you read this report that shows spherocytes present which are minus the central pallor, normally RBCs are pink but they always are having a central pallor. Here central pallor is not present, so that's AIHA, which can also be written as Coombs positive hemolytic anemia in the patient. Please appreciate guys that this is a revision program, so I will have to talk a little faster as compared to the traditional data. In this condition, the autoantibodies will also damage the lymphocytes. So there will be a lymphopenia, and the antibodies will be damaging the platelets also. So there would be an autoimmune thrombocytopenia developing in the patient as well. And then obviously the immunological features will predominate. For the immunological features of this particular condition, I will use a different slide. The immunological criteria of this patient are the ones which are the most important part of this particular discussion. So let's now try to remember the immunological features of this particular disease. The immunological features to be remembered are, obviously the standard data would be like C3 and C4 in the patient can be less. I mean, that's very standard, but let's revise the antibodies which are associated with the disease. One of the antibodies very specific is anti-Smith antibody. This happens to be the most specific antibody which is responsible for pathogenesis of SLE. But when it comes to the status of double-stranded DNA, why do you do a dsDNA or a double-stranded DNA in the patient is to monitor the course of the disease. You want to basically see whether the patient is improving or worsening. Like for example, I would say like this, that during pregnancy the disease will worsen, postpartum it will improve. So to monitor the flare-up of the disease and to then see that the patient is going into a remission, a double-stranded DNA will be used by you. Anti-nuclear antibody is obviously for diagnosis. SLE diagnosis is not possible without an anti-nuclear antibody, no doubt about it. The antibody, the next one to be remembered is anti-Rho antibody. This is responsible for two aspects. One of the aspects to be remembered for anti-Rho antibody would be that it is responsible for photosensitivity. Second, this antibody belongs to immunoglobulin G class, and therefore this antibody can cross over from the body of the mother to the baby, and the newborn baby of this lady will be having neonatal lupus. This baby will be born with butterfly rash, and along with the butterfly rash, you will also notice that the child would be having a heart block. The ECG of this child will now be done because the child is having bradycardia. When you do the ECG, you are noticing there are P waves coming. Then there is a prolonged PR interval with really a broad QRS complex followed by a T, again a P followed by a P. Maybe a third P might come, may not come, but there will always be a prolonged PR interval with a broad QRS complex coming in the patient. What you have to understand is that there is no correlation between the P and the R waves in this case, and the RR interval of the patient is much more as compared to the PP interval of the patient, because normally the PP interval and the RR interval will always match, but here the PP and the RR interval will never match. Plus there will always be a broad QRS complex which will not be encountered in Mobitz 2 heart block in a patient, because lots of you, what are you gonna do is you're gonna just look at the PR interval at this particular point of time and just compare and say that doctor, because PR interval is constant and there is a P wave, but I have here highlighted the fact that there is no missed beat per se coming up. Why I'm not saying a missed beat? Because some of the P waves never went down. This ECG is not of a Mobitz 2 heart block. This ECG is of a patient of a complete heart block. Features of complete heart block is PP not matching with R with a broad complex QRS, whereas when it comes to presence of a Mobitz 2 heart block, the QRS will always be normal duration. So one hint is, if you're stuck between Mobitz 2 and complete heart block, remember guys, especially 2:1 block, because I got a lot of queries for 2:1 block, go to the bradycardia segment where I've talked about it. And if you have issues, ping me. But remember my words, that if you are confused between 2:1 block and a third degree heart block, if it's a broad QRS, you should think in terms of a complete heart block in a patient. And in this case, a newborn baby is born with complete heart block. Why? Because the baby is having antibodies transmitted from the mother, for which a pacemaker would be required, and facilities like that may not be available in our country, so this child might actually die. The word is complete heart block, or will be written as third degree heart block in a patient. Suggested read is bradycardia. Symptomatic bradycardia is where I've talked about it, or you can listen to the ECG section also, but symptomatic bradycardia is where I want you to listen to this again if you have any issues. The next thing to be remembered for the antibody perspective is anti-ribosomal P antibody. This antibody is responsible for causing psychosis. Very surprising statement, but true, that there are neurological features in SLE, there is psychotic features in SLE. Thus, the antibody causing cerebral edema is anti-neuronal antibody that crosses blood-brain barrier and explains the headache and possibility of seizures in patients of SLE. So don't be surprised if you read cerebral edema, seizures, headache in a discussion of systemic lupus erythematosus. Then anti-erythrocyte antibodies are responsible for autoimmune hemolytic anemia in a patient. That's easy, I think. So autoimmune hemolytic anemia will be written as Coombs positive hemolytic anemia. Last but not the least, guys, obviously the antibody that is involved is anti-cardiolipin, lupus anticoagulant, and anti-beta 2 glycoprotein antibody. These antibodies are responsible for one, a false positive VDRL, and apart from a false positive VDRL, they are also responsible for development of recurrent abortions in patients of SLE. Anti-cardiolipin antibody or lupus anticoagulant. Lupus anticoagulant is actually a misnomer, no? Because when you read the word anticoagulant, it should cause bleeding, but it is causing recurrent abortions. So these antibodies are responsible for one, recurrent abortions. They are also responsible for false positive VDRL in the patient, especially lupus anticoagulant or anti-cardiolipin antibody. But if he specifies the word that which antibody is most specific to explain the recurrent abortions of this particular patient, if you have to select from all the names given here, then I'm just going to put symbolically anti-beta 2 glycoprotein. The name should be given as a priority over the previous antibody names. Because recurrent abortions are going to be occurring in patients of SLE, the word used would be secondary APLAS, that is anti-phospholipid antibody syndrome. See guys, anti-phospholipid antibody syndrome can occur even without SLE, but here I'm saying with SLE, so this name has to be remembered. Secondary anti-phospholipid antibody syndrome is related to anti-beta 2 glycoprotein antibody, and this explains the bad obstetric history in this patient. Once we come to the management part of patients of SLE, we will obviously be using steroids, but obviously in exacerbations, and we need to taper the dose ASAP as early as possible. Because nowadays we use high potency steroids, methylprednisolone for example, for a quick resolution. Because patients want quick response, we give highly efficacious drugs. Opportunistic infections come in. That explains the infection part that I was highlighting in the earlier part of the discussion. If he says pregnancy, and he says that the lady is having a SLE exacerbation, then in pregnancy we don't give steroids. It's not that steroids are teratogenic. Don't be under that impression that steroids are teratogenic. It is simply the fact that when it comes to a patient who is having SLE, she's pregnant, she's having exacerbation, the molecule that we can use in this particular case would be by the name of hydroxychloroquine. At least that is what Harrison says. And why is he not recommending steroid is because he says that placental enzymes can deactivate the steroids that you're giving. So the actual steroid that is available to her to neutralize her flare is lesser, and therefore the results may not be obtained as expected. The placental enzymes are neutralizing the steroid that you're giving. So it's hydroxychloroquine which is to be used for this particular case. For pregnancy and SLE, I wanna highlight the fact that there are two aspects to be remembered. One, mother's health will worsen. When you say that the mother health, she is definitely having a flare up of the disease, because autoimmune diseases can worsen in pregnancy. I am worried about the fetus also because of two aspects. One, the fetus might never be born, that is there's an abortion, or would be having a complete heart block, and the antibodies to be answered for both of them are different. If the question specifies the fact that which antibody is responsible for abortion, your answer should be given as anti-beta 2 glycoprotein antibody, not given anti-cardiolipin. And for complete heart block, the name of the antibody to be given is anti-Rho antibody, which is immunoglobulin G class. It can cross the placenta and it can result in this manifestation for the patient. Let's look at the laboratory findings in these patients and remember which is the most common laboratory finding. Then obviously anti-nuclear antibody obviously has to be positive for diagnosis of SLE, but in case that is not given and he says what is the commonest laboratory derangement of this particular patient, the answer is anemia. So I'll explain like this. Symptom wise, it is joint pains, which are one of the reasons why patients of SLE would come to you. It is not photosensitivity, which is the main reason that may or may not be described by the patient. Malar rash, yes, patient will notice. Cosmetic complaints are well noticed by patients, but photosensitivity part is like my skin burns on sunlight exposure. In India, it's so hot. No, everybody will think that okay, it's so hot, so that's why my skin is burning. They're not realizing it's a first degree burn. So you have to, then sensitize them to the photosensitivity component. They start using sunscreen lotions. It doesn't work. That's when they come to you. So joint pains, photosensitivity, malar rash are some of the common reasons why these patients would come to you. And then she will tell you, doctor, I don't know what's going on, but I'm becoming pale. I'm taking iron supplements, but my anemia is worsening. Why? Because it's not iron deficiency anemia. It is an autoimmune hemolytic anemia in the patient. With time, you will realize on a follow-up consultation, because she might even be having low-grade fever, which is, she's taking paracetamol off and on, and you did workup for TB, you did workup for infections, the fever is persisting. That's when you wrote ESR, it was elevated, and you wrote an anti-nuclear antibody, and surprisingly, it was positive. Lots of time we don't anticipate it is SLE in early part. I'm talking about once a case is full blown, it's a easy diagnosis, but in the early part, if you're encountering anti-nuclear antibody positive, that's definitely a diagnosis in the patient. So what I'm saying is, if you document presence of synovitis, You document presence of photosensitivity, malar rash, anemia, ANA. Out of 11 points that I've said, at least 4 should be positive in a patient for diagnosis of SLE. He says in these 4 positive, at least 1 clinical feature should be positive, and at least 1 laboratory feature should be positive for you to say that yes, this is a diagnosis of SLE in the patient. This is a quick revision for the aspects that I have highlighted before you for this particular topic, including the mortality aspects, which in early years are infection, later is atherosclerosis. Active SLE given, just the word active SLE given, then okay, kidney, because patient did not take treatment. No, let's be frank guys, I mean a lot of patients in India, when you say steroids and they just back off. I mean, when you say steroid in a consultation, no, most educated people will just say, doctor, are you serious? You're giving me steroids? I don't want to take it. And the price that they pay is the kidney damage, right? So that's one of the reasons why these patients would be having a mortality. So this is aspects for SLE that I want you to remember. Coming to the next slide, you can see two very diametrically opposite issues. One is showing a strawberry tongue and the second one is a strawberry gingiva. As I told you, strawberry gingiva would be a presentation of Wegener's granulomatosis, WG, which is nowadays called as granulomatosis with gingitis. From the histopathological perspective, this condition will be having a necrotizing vasculitis with granulomas. So remember, Wegener's granulomatosis, as the name itself suggests, no, granulomas are present. It is necrotizing vasculitis with granulomas. I mean, normally you don't read this word, no. Necrotizing vasculitis is what you read, but granuloma with the necrotizing vasculitis is one of the characteristic features of granulomatosis with gingitis. The highlight of this disease would be involvement of the upper respiratory tract, lower respiratory tract and the kidneys in the patient, as I've highlighted earlier also. So he will describe to you epistaxis, or he may not give you epistaxis, but because there is a necrotizing vasculitis involving the upper respiratory tract, the necrosis that occurs could result in recurrent sinusitis developing in the patient. The second manifestation that will occur in this patient will be that of hemoptysis, which might be on a recurrent basis, and sometimes instead of describing hemoptysis, he might develop multiple lung cavitation. Traditionally, you read about lung cavitation with TB, but in this case, it could be multiple lung cavitation because there is a vasculitis, so the blood supply of the lungs is affected. The third one will obviously be damage to the blood vessels of the kidney, contributing to hematuria. And this image shows obviously presence of strawberry gingiva. You know that strawberry nose is a feature that is seen with rhinosporiodosis, and strawberry gallbladder is seen with cholesterolosis, but strawberry gingiva is a feature that is encountered with Wegener's granulomatosis. To confirm the diagnosis of this condition, the test to be done is C-ANCA, that is anti-nuclear cytoplasmic antibody, and C here stands for direction against a cytoplasmic antigen. The name of the cytoplasmic antigen is anti-proteinase 3. Thus, like a related MCQ by the name of P-ANCA, where he has asked that against which perinuclear antigen the P-ANCA is acting. So the antigen is myeloperoxidase for P-ANCA, which is seen with microscopic polyangiitis or for ulcerative colitis. But in C-ANCA, it is anti-proteinase 3 that I'm talking about. For treatment of Wegener's granulomatosis, the drug of choice is cyclophosphamide, which is a notorious drug for causing hemorrhagic cystitis. While I'm writing it, question for you guys: which drug causes hemorrhagic pancreatitis? The question is drug causing hemorrhagic cystitis. As I said, is obviously cyclophosphamide treated by Mesna. Question was hemorrhagic pancreatitis is seen with, and the hint is it's an antidiabetic drug. Hemorrhagic pancreatitis is associated with exenatide. This is a incretin which would be acting by increasing the values of GLP-1. Though the advantage of this drug is that it needs to be given only once a week, but the disadvantage of this is hemorrhagic pancreatitis. The second image obviously shows a strawberry tongue in a patient, which is a feature of Kawasaki. And Kawasaki we have talked about in the earlier part of the discussion only. So there is no point of talking about it again, but I would just like to remind you the word coronary artery vasculitis is a special feature of this Kawasaki disease, which will cause ECG findings of MI in a child. If you get a question that begins by saying, what is responsible for ECG findings of myocardial infarction in a newborn baby? then obviously the answer is not Kawasaki disease. Then the answer should be given as L kappa. L kappa would stand for anomalous origin of the left coronary artery from the pulmonary artery. If you read the name carefully, you can see that the left coronary artery is originating from the pulmonary artery, so it is containing deoxygenated blood. But if the question is rephrased as ECG findings of MI in a child, then one disease that you have to consider is Kawasaki. And especially if the child is an Afro-American child and he is not giving you any features of Kawasaki disease, then the word to be remembered or the condition to be remembered is sickle cell anemia, in which there could be sickling crisis which could cause ischemic damage to the heart with elevated biomarkers, and the child could end up with MI or a subendocardial infarction sometimes, which might later on present as a ischemic cardiomyopathy. The shortcut to be remembered for Kawasaki disease is mucocutaneous lymph node syndrome, where muco would be like presence of strawberry tongue, cutaneous would be like a rash and periungual peeling of the skin, and lymph nodes would mostly be unilateral cervical lymphadenopathy in a patient. Whereas for sickle cell anemia, it is sickling episodes where the sticky RBCs will contribute to microinfarctions, and therefore there could be a possibility of a myocardial infarction developing in a child. In fact, the term that they will use to describe this MI, if it develops in the child, or chest pain that develops in the child, would be called as acute chest syndrome. You know the fact that acute coronary syndrome is a term that we use for atherosclerosis, but acute chest syndrome is a term that we shall be using for sickling crisis in an individual. Acute coronary syndrome is a term that is used to describe the following profiles. That is going to be unstable angina, non-ST elevation MI, and ST elevation MI. These are three terms which are included in acute coronary syndrome. Prinzmetal angina will also have similar presentation, but acute coronary syndrome per se incorporates classically definition-wise the following terms. And acute chest syndrome is a feature of sickle cell anemia. Coming to the next slide, guys, we will revise Behçet's disease, where one of the important diagnostic criteria is obviously recurrent aphthous oral ulcerations developing in a patient, and the definition of recurrent aphthous ulceration or CROPS for aphthous ulceration would be at least 3 episodes in a 12-month period is the one that we basically need to remember. Then would be the aspect of the accessory features in these patients, which would be most of the time along with aphthous ulceration, genital ulcers in a patient. Like in a female patient, it will mostly be vulval ulcers. But in a male patient, it would not be an ulcer on the penile area. That is like if they give you an image of a person who's having an ulcer on the genital area, it's mainly a STD, right? In a male patient with Behçet's disease, it would be scrotal skin that would be involved. So patient would be having a scrotal ulcer. The ocular manifestation of this patient would be anterior uveitis, which could be written as hypopaeon, that is pus on the anterior chamber of the eye. So you can remember this disease as oro oculo. That's a shortcut for you. Like I was teaching in Kawasaki mucocutaneous lymph node, here I'm teaching you oro oculo genital syndrome. Oral is a must, and the remaining two, if present, the diagnosis of the patient is made. Dermatological manifestation could be like pseudofolliculitis or erythema nodosum with target lesions present in a patient, and then is pathology test. Very peculiar. What are you going to do in the pathology test? You are going to use a hypodermic needle and you will gently prick the patient in the forearm area. In a normal person, if you prick with the forearm area, max it will cause, pain, discomfort, and after 48 hours, you can't even see the prick area because it will heal. Gentle prick with a hypodermic needle. In this case, what's going to happen is that after 48 hours of wherever you gave the prick and you had marked the area with an indelible ink marker, there will be a formation of a sterile pustule at the site of the prick that you had given, and therefore in this condition, the sterile pustule that I'm talking about, this is what is technically referred as pathology phenomenon or a pathology test. Pathology phenomenon is an example of a type 4 hypersensitivity reaction. It's a delayed kind of a hypersensitivity reaction that is encountered in patients. For management of this condition, we will have to use especially topical steroids, especially for oral manifestations and genital ulceration. But if it is an ocular manifestation occurring in a patient, then for ocular, obviously it would not be good idea to use steroids because you could be having a silent perforation. So especially if ocular manifestations are described in a patient, then the drug that we use is an immunomodulatory drug by the name of azathioprine. And Behçet's disease also causes pulmonary artery vasculitis. A rare manifestation of Behçet's disease is that the pulmonary artery of this patient can rupture and a life-threatening hemoptysis can occur, though that's obviously a rare feature. But Behçet's is also described in the textbook as a cause of large vessel vasculitis. So when I describe this, a lot of guys send a message that you said vasculitis, but which blood vessel is involved? So pulmonary artery can be involved in Behçet's disease, large vessel, and the rupture of the large vessel can occur, contributing to a life-threatening hemoptysis in patients of Behçet's disease. Moving on, I have next shown you a slide where Shermer's test is being performed. The disease that we are going to discuss now, where there are dry eyes and dry mouth, is called as Sjogren syndrome, which is also called as Sika syndrome. The highlight of this particular disease would be that the antibodies would be causing damage to the lacrimal glands of the patient and salivary glands of the patient. This disease is unmistakable. Dry eyes and dry mouth is an unmistakable presentation. A salivary gland biopsy can be done in this case to diagnose the disease, but our objective is to diagnose it without invasive tests. Even Bartholin gland involvement can occur in the patient. So the glands involved are salivary gland, lacrimal gland, and Bartholin gland, contributing to dry vagina developing in the patient. The antibody which is responsible for this one is called as anti-Rho antibody, and the second one is anti-La, lupus anticoagulant antibody. Anti-Rho is called as SSA and anti-La is called as SSB antibody. So these would definitely help you in diagnosis, but even if not given, clinical features are sufficient. We can also do a salivary gland biopsy for diagnosis of this patient. Even if a patient does not allow a biopsy, we still have made the diagnosis anyway. For dry eye, the test that he might actually mention is the one which I've tried to show before you, that is called as Shermer's test. In Shermer's test, he is also asked which cranial nerve is being tested. So we are testing for the secretomotor function of the lacrimal glands, that is 7th nerve. So it is not testing the 3rd nerve or the 5th nerve, as some people casually have answered in various MCQs that I was seeing. It is the 7th nerve that is being tested in Shermer's. If dry eye of the patient is not treated, then the manifestation that can occur in the patient can be in the form of exposure keratitis. And last but not the least, that can result in development of a corneal ulceration causing extreme photophobia in the patient. To identify the corneal ulcer in the patient, you will have to put in a dye that is called as fluorescein dye. And to identify the exposure keratitis component of the patient, you would be using what is called as rose Bengal dye. So a lot of these questions will actually talk about these ophthalmological terms like Shermer's test, rose Bengal dye or fluorescein dye for evaluation. For management of these patients, obviously frequent mouth washes are recommended. We obviously have to maintain oral hygiene in the patient, but one drug which is an oral cholinergic drug which is to be given for the patient is cevilimine. What I mean by cevilimine is that this drug will basically help in stimulating the salivary flow, because this is a cholinergic drug. It stimulates the salivary flow in the patient and will help in improvement of the I would say the oral hygiene of the patient. Otherwise, these patients will end up with development of extensive dental caries. You see, saliva plays an important role in bactericidal properties, and if the saliva flow is less, then there would be growth of a bacteria which is by the name of Streptococcus mutans, which you are familiar is responsible for extensive dental caries. So poor hygiene would also be described in these patients. For dry vagina, obviously KY jelly can be used, but as such symptomatic management for these patients is done. Now when you will attempt MCQs, you will also notice that in Sjogren syndrome, he might simultaneously even mention rheumatoid arthritis features. That is, he might say the fact that patient is having PIP, MCP, wrist joint involvement, pain in the smaller joints of the hand with tenderness. If you are having rheumatoid arthritis features present with Sjogren syndrome, then the term that we are going to use to describe the patient is called as secondary Sjogren syndrome. The incidence of lymphoma in patients with secondary Sjogren syndrome is relatively increased. That's just an associated finding to be remembered. But rheumatoid arthritis, guys, is a disease that can coexist with any other autoimmune disorder. So if it coexists, then we call it secondary Sjogren syndrome. Just to explain this coexistence fact, I can explain one more fact to you, which would be that if you read, like for example, you are reading a question in which SLE features are given, then even scleroderma features are given. SLE features would be like butterfly rash and joint pain in a patient. Scleroderma features would be like Raynaud's phenomenon in a patient. It's not that Raynaud's phenomenon cannot be seen in SLE, but is not a diagnostic feature. So I'm saying the question begins by describing a lady who's having this classical cosmetic complaint of malar rash with joint pain. Her knee joint hurts and she takes a painkiller for it daily. She's also having low-grade fever. The question is also mentioning that this lady is having Raynaud's phenomenon. Then also says that she has difficulty in climbing stairs because the hip joint muscles of this lady are relatively weak, polymyositis. That is a proximal myopathy. And then also says that the patient is having PIP swelling, MCP swelling, wrist joint swelling bilaterally. So when you get a question like this where rheumatoid arthritis is coexisting with multiple other disorders, the diagnosis of yours would be given as MCTD. MCTD would stand for mixed connective tissue disorder. Mixed connective tissue disorder is characterized by a combination of the features of the following disease. To crack this question, one option is that you should read the clinical features of all these autoimmune diseases together, or the shortcut is to remember the antibody. Read the name of the antibody very carefully, because this is the best bet that you have in the paper to crack this one. This would be called as ribonucleoprotein antibody. Earlier I was teaching you regarding anti-ribosomal P antibody. That is the usual source of confusion that I find with most people. They tend to remember anti-ribosomal P and anti-ribonucleoprotein, but they mess up between the two. The anti-ribosomal P antibody is responsible for development of neuropsychiatric manifestations. It is responsible for causing psychosis to develop in a patient of systemic lupus erythematosus. But on the other hand, the anti-ribonucleoprotein antibody is the one that is useful for diagnosis of MCTD, that is mixed connective tissue disorder. So rheumatoid arthritis can coexist with multiple other neurological disorders is the basic learning that I've tried to give you. Moving to the next slide. Very classical Z-line deformity. This was given in this January 2019 NEET. A Z-line deformity in the hands of the patient with a possible subluxation of the first MCP. And along with this, you can also notice the deformities in the hands of the patient with presence of rheumatoid nodules. Rheumatoid nodules are the most common extra-articular. Rheumatoid nodules are the most common extra-articular manifestation of patients of rheumatoid arthritis. So considering the manifestations given in the two images, the diagnosis for this condition is fairly very straightforward. The highlight of this disease would be involvement of the small joints of the hand, that is the PIP, MCP and the wrist joint bilaterally, and this would be obviously bilaterally symmetrical involvement. And in one consultation you obviously cannot comment on whether how many joints are involved, so it is obviously over 6 weeks that you need to monitor the patient and then obviously evaluate. But my point is that if you're reading about small joint involvement, large can also be involved, remember, in this particular condition, but small joint involvement along with large joint gives more credibility to the diagnosis. One of the tests that is useful for diagnosis of this condition is RA factor. RA factor is IgM class of antibody, so it can be biologically false positive. I've written BFP, biologically false positive in 5% of normal population. Because this test can be biologically false positive, therefore in ordinary population it can't be used as a diagnostic feature. So the main test that you have to write for identification of the disease is anti-CCP. That would stand for cyclic citrulline peptide antibody. Anti-cyclic citrulline peptide antibody or CCP antibody is the main test for identification of this condition.
And if you do not identify the disease, then obviously in these patients the deterioration will occur, and the deterioration would be in the form of development of joint deformities, because this disease is characterized by erosive deformity developing in the patient. Therefore, for monitoring of these patients, we have to use both RA factor for rather follow-up of the patient, but in main test for diagnosis is anti-CCP. X-ray of these patients can be showing presence of periarticular osteoporosis, but all those findings are those of erosive aspect. Then I want you to remember that in rheumatoid arthritis, multi-system involvement can be present. Like he can ask you ophthalmological involvement of this patient. The ophthalmological involvement in these patients could be that of dry eye, that could be keratoconjunctivitis sicca. I want you to remember the fact that juvenile rheumatoid arthritis can be associated with uveitis, but when it comes to adult patients, it is mainly a dry eye in the patient. So extra articular manifestation of eye would be keratoconjunctivitis sicca. Then as you come up from the eyes, the neck part of these patients is very vulnerable. These patients will always be told not to put undue pressure on the neck, like doing yoga exercise, etc. is not recommended for these patients, or headstand is not recommended because cervical spine is very vulnerable. In these patients, it is a possibility that if the person is trying to do a yoga exercise, a headstand for example, the patient will end up with quadriplegia and will be wheelchair bound for whole of the life. Why? Because this disease is having predisposition to atlantoaxial dislocation, for which a MRI spine would be required and urgent surgical management is required for the patient. And some cases, the results of spine surgery are very disastrous. You may not get a good result. After cervical myelopathy, if you go down, the heart of this person can be involved. The involvement in the heart can be that these patients could be having first degree heart block. Why? Because there would be rheumatoid nodules which would be developing between the SA node and the AV node, causing a first degree heart block. One of the leading causes of death of patients with rheumatoid arthritis is accelerated atherosclerosis. I would like to remind you that in SLE patients in old age, the cause of death is accelerated atherosclerosis, especially after 45. And even in rheumatoid arthritis, one of the leading causes of death would be accelerated atherosclerosis. The involvement of the lung of the patient can contribute to development of rheumatoid nodules, and when these inflammatory nodules will break down, it will result in exudative pleural effusion, which will result in development of Light's criteria being mentioned in the MCQ. In Light's criteria, he will mention regarding pleural fluid protein, pleural fluid LDH, protein being more than 0.5 and LDH more than 0.6 of the serum protein and serum LDH values. There might even be presence of cholesterol crystals that would be present in the pleural effusions of this particular individual. You can see that because this disease is having multiple involvements, he can even ask you the hematological profile of the patient, which is normocytic normochromic anemia. This normocytic normochromic anemia is because this is a chronic disease. I agree that in anemia chronic disease, microcytic hyperchromic anemia also occurs, but traditionally speaking, books mention that first answer for anemia chronic disease should be normocytic normochromic anemia. As you can see, multiple body systems are getting involved in the patient. When it comes to neurological involvement, this disease does not cause a central nervous system involvement. It mainly causes a peripheral nerve involvement, that is mononeuritis multiplex, where multiple mononeuropathies can occur in a patient. So mostly it is PNS. It is peripheral nervous system that is involved in this patient, in a sense that spinal cord can be involved. Why? Because there is a atlantoaxial dislocation, and peripheral nerves can be involved in the patient because there is mononeuritis multiplex, but CNS involvement is not seen in the patient. If they ask you to select one and say which of these is the most common extra-articular manifestation of rheumatoid arthritis, then I've already told you it would be rheumatoid nodules. They are non-tender, they are found in extensor distribution. Most of the time they would be noticed by you on the olecranon process, or instead of olecranon process, they could be on the extensor aspect of the elbow, shin of the patient, occiput, back of the spine of the patient is where you will be able to evaluate. They're non-tender, and the distribution of these is same as that of rheumatic. But rheumatic is seen with sore throat, and that would be a child. Here we're talking about adult, and in rheumatic you will not be having the remaining manifestations that I have said. For treatment of patients with rheumatoid arthritis, one of the best drugs that is to be used is methotrexate. The current edition of Harrison says that there is no role of non-steroidal anti-inflammatory drugs in management of patients with rheumatoid arthritis because they do not prevent the progression of the disease. So we should be giving methotrexate, and if methotrexate alone is not working, then we should go for triple therapy. This I would highlight as the most important point for this particular topic because this is what was asked in the NEET exam, that is January 2019 winter. They had asked about that methotrexate has already been given but patient is not improving. So what is the next step in the management? So he says that you have to be aggressive right from day one. Like earlier we used to worry a lot about the side effects, and the price the patient paid was the deformities in the hands. And I mean, deformities of hands is something where quality of life suffers, basic tasks are compromised. So we have to give to the patient methotrexate, hydroxychloroquine and sulfasalazine. We can also use biologicals for the patient, but you can understand the biologicals are little expensive, like infliximab for example. One shot of infliximab depending on the brand can go up to 10,000 rupees, which is obviously expensive. So triple therapy normally was being discussed for H. pylori, but now we're talking about triple therapy even in management of patients with rheumatoid arthritis. And where this aggressive treatment is not given, you can see the deformity. You can see the development of a swan neck deformity in the patient, which is that in this particular patient, if this is the PIP, and if this aggressive treatment is not done, then you can notice the deformity developing in the finger of the patient, which is by the name of swan neck deformity. If I just zoom it in, you will notice the fact that there is a definitive deformity in this particular individual. One, you are having a deformity at the proximal interphalangeal joint, that is an extension. And at the DIP of the patient, that is distal interphalangeal joint, there is a flexion. So because you are noticing a deformity at the joints of the patient, a swan neck deformity has been described here. If you compare this with the image-based question, which was, I think, written diagnosis is already there. This would be like what Dhoni could be having or any cricketer could be having when you're catching a ball fast, right? When you're catching a ball, deceleration, footballer or a cricketer, you know, catching a ball like this or catching a ball like this, that could result in avulsion of the extensor tendon and could contribute to a mallet finger deformity in the patient. When this image was given, a lot of guys answered it as swan neck, but you can notice for swan neck to be present, you need to have a classical defect, which I've highlighted, and therefore it would be the first image. This one is mallet finger, obviously. That would be seen in, for example, athletes, cricketers, footballers, and especially goalies, for example, and wicket keepers. And swan neck deformity is the one that I've highlighted here for this particular patient. Boot tennis deformity can be present, and then can be obviously a presence of Z-line deformity, which was given in the paper. So these are the deformities for the erosive arthritis that I've highlighted. Coming to the next slide, guys, you can notice very characteristic violaceous or violet colored lesions which are present on the nose of this lady, on the cheeks of this lady. The in-between skin area also looks normal. This particular skin area looks normal. So I'm not going to call it a classical butterfly rash, which would be reddish in color. These are violaceous lesions. Also present in this patient are skin lesions that would be called as erythema nodosum or erythema nodosum like lesions, I would say. Not a very classical target sign, but still these lesions would be called as erythema nodosum. And in the chest x-ray of the patient, you can see very significant bilateral hilar lymphadenopathy. So the disease that we are talking about in this particular slide is sarcoidosis, which is characterized by non-caseating granulomas, which would be resulting in various important manifestations for the patient. At the outset, I would like to mention an important endocrine manifestation of this condition, which is that the non-caseating granulomas in this condition would be synthesizing vitamin D3. You know the fact that these granulomas would be having an enzyme by the name of 1-alpha hydroxylase, which is traditionally present in our kidney and is responsible for synthesis of vitamin D3. So most of the time, endocrine manifestation of this condition, hypercalcemia, would be asked. Because hypercalcemia in this condition will respond to steroids also, because the best drug for treatment of sarcoidosis is steroids. So therefore, I can also call this condition as steroid responsive hypercalcemia. Traditionally, for hypercalcemia, we have to give bisphosphonates, normal saline, furosemide drip. But in this case, obviously, since I can treat the main disease, so it would be called a steroid responsive hypercalcemia. The next point to be remembered for this would be a skin involvement of this disease that is called as lupus pernio. The color of this would be violet. It will involve the face of the patient, but will not be having a classical butterfly distribution. The remaining manifestations can be remembered like this. If this is a line diagram for these patients, you could be having a brain involvement in these patients or a pituitary involvement in the patient. So the brain involvement or the CNS involvement of these patients could be lymphocytic meningitis. Then because the pituitary can be damaged in the patient, especially the posterior pituitary, so nephrogenic diabetes insipidus could be described in the patient, especially polyuria, polydipsia for the patient. Then the eyes of the patient are involved. The ocular involvement in this patient, could be in the form of either a uveitis or a retinitis or pars planitis. So both the I would say the anterior chamber of the eye and the posterior chamber of the eye, both are involved in this condition, and even optic nerve can be involved. Due to the optic neuritis component of this disease, there's a possibility that a misdiagnosis with multiple sclerosis can occur. So neurosarcoidosis causes optic nerve involvement, but if he says what is the most common cranial nerve involvement in the patient, then it is seventh nerve. Why? Because if there is a parotid gland involvement, then in this patient bilateral seventh nerve palsy can be a manifestation. So most of the time when they ask you regarding the topic of sarcoidosis, is not going to only talk about the lungs, but he could talk about the CNS manifestations of the patient. So let's revise again. The brain is lymphocytic meningitis, posterior pituitary damage, nephrogenic diabetes insipidus. The eye involvement is uveitis and pars planitis with optic neuritis given for blindness and seventh nerve palsy. As we go down in this patient, the next manifestation that occurs would be with respect to the hilar lymph nodes of the patient. So if this is the representation of trachea, bronchus, lungs of the patient, the lymph nodes will definitely enlarge and they would be visible on an X-ray, and that is what I showed you in the image for this condition also. As you can see, the hilar lymph nodes are very significantly enlarged in the patient, and that is what I've tried to highlight for this patient. These hilar lymph nodes will obviously contribute to cough and breathlessness in this patient, and subsequently in this condition even the upper lobe of the lung would be involved. So upper lobe fibrosis can be seen in patients with sarcoidosis, but parenchymal involvement, guys, is late. That is why HRCT has diagnostic utility for this condition lesser as compared to a plain X-ray, because X-ray will pick up enlarged lymph node shadow early. So normally for interstitial lung diseases, we go in for a high resolution CT scan, but parenchymal involvement is a late feature of the disease, and for early diagnosis even chest X-ray is sufficient. So here it is chest X-ray and a CT guided biopsy which is best, or a bronchoscopic guided biopsy which is best. In fact, if the question says what is the investigational choice for this condition, it is a bronchoscopic guided biopsy, because you can access these enlarged lymph nodes fairly easily. Then heart can also be involved in these patients. The cardiac involvement of this condition could be either in the form of development of bradyarrhythmias. They could be heart blocks obviously, but what I'm worried about is that the granulomas could cause damage to the muscle and cause restrictive cardiomyopathy. In fact, this is itself a question, because you know the fact that one of the important causes of restrictive cardiomyopathy is amyloidosis, but after amyloidosis the next thing written is sarcoidosis. So the granulomas damage the muscle, cause restrictive cardiomyopathy, which could result in stiff heart. The stiff heart could result in pulmonary edema. When left side is involved, it will cause pedal edema. When the right side of the heart would be involved, because the venous return into the heart will be difficult, no, because it's a stiff ventricle. So pedal edema and pulmonary edema or square root wave sign could be described for this patient. For these patients, because the cardiac myocytes are being involved, even tendency for arrhythmias will occur, which explains the fact that via ICD is required for the patient or a pacer is required for the patient. ICD is implantable cardioverter defibrillator, which is required for recurrent episodes of tachyarrhythmias developing in this patient. So cardiac involvements are definitely important cause of mortality. Then if I take pulmonary artery to be a part of the heart only, the pulmonary artery hypertension will occur in this patient. This is one of the leading causes of problems for these patients, and pulmonary artery hypertension will be given as loud B2, or it might be given in the X-ray as a prominent PA segment. Normally there is a concavity, and I've shown you X-ray already where a prominent pulmonary artery segment was highlighted, which was described in comparison with 3 sign for coarctation of aorta. And instead of pulmonary artery hypertension, he might write the word DLCO, diffusion capacity of the lung for carbon monoxide is lesser. That's because in pulmonary artery hypertension there is fibrosis in the wall of the pulmonary artery, so diffusion of gases would definitely be affected. I'm talking about the smaller branches now. So DLCO lesser, these are 3 expressions by which pulmonary artery hypertension can be described for this particular individual. Liver and spleen are obviously enlarged in this condition, so hepatosplenomegaly can occur in the patient. The bone marrow involvement of this patient would be in the form of lymphopenia. So it's a good idea to actually compare this, because the bone marrow involvement or hematological manifestation of rheumatoid arthritis was normocytic normochromic anemia, but here the predominant one is lymphopenia in the patient. So this is a basic root diagram to explain the findings of this patient. Now let us see how do we do a workup of this guy. For the workup of this individual, we will be doing a chest x-ray, and that is the first investigation to be done, not a CT scan, and it would be showing you evidence of bilateral hilar lymphadenopathy, a very significant one, which is the main point for diagnosis. The IOC for this condition is a bronchoscopy guided biopsy that will narrow down the diagnosis for you. If we do a HRCT for the patient, and there would be a presence of what is called as galaxy sign, which I have highlighted here. A distant constellation galaxy implies in astrophysics regarding the stars. And while I'm shooting this, just wanna relate to you the fact that India is few hours away from, in fact, at this time I would say India is just 2 hours away from going to the moon. So I feel happy shooting for this for you 2 hours before actually the India goes to moon. And well, we are one of the most progressive nations. You are one of the highly intelligent chaps who are listening to what I'm saying. So I feel proud while discussing this with you. Just came to my mind because I said astrophysics word galaxy sign, so it's a pleasure talking to you guys at this particular opportunity. Coming back to the focus, guys, in this disease, the traditional old MCQs will talk about gallium scan, and the gallium scan of the patient will be having that classical panda sign and lambda sign. However, nowadays, because we are having such advanced techniques available, so it doesn't make too much of sense to actually talk about this. One more outdated test that is not used anymore for this condition is Queen's test, because of the risk of variant Creutzfeldt-Jakob disease that could be developing in the patients. And then one bronchoalveolar lavage finding, yes, worth remembering for this condition would be, in fact, 2 of them. One is lymphocytosis as a bronchoalveolar lavage finding of this guy, and the second one that I would like you to remember after lymphocytosis would be CD4 CD8 ratio more than 3.5:1. Normally we talk about CD4 CD8 ratio in AIDS, but CD4 CD8 ratio in bronchoalveolar lavage with value more than 3.5 is suggestive of diagnosis of sarcoidosis. The diagnosis is obviously with help of a biopsy, a bronchoscopy guided lymph node biopsy. For treatment of sarcoidosis, obviously we shall be using steroids in the patient, though in pregnancy we will be using hydroxychloroquine. Most of the time, good prognosis would be seen. I have myself treated a family member of mine who had sarcoidosis, and she never had recurrence once we treated her, because most of the time we find that the disease has obviously like any autoimmune disease will have a waxing and a waning course, but usually we find once we treat aggressively that the disease does not come back, and the disabilities that I'm talking about, they significantly tend to reduce in our patients. The HRCT chest that I showed you for galaxy sign has to be now compared with, you can see in the peripheral part of the lung, the honeycomb appearance. Honeycomb appearance is a feature that is found in patients who are having interstitial lung disease. So both of these appearances have to be remembered. In fact, if I mention regarding the HRCT aspects that I have discussed with you today, the HRCT lung aspect that I have taught you one today is tram track appearance. Then after tram track appearance, the second one that I am teaching you is presence of signet ring appearance. That's again bronchiectasis. Then is galaxy sign. Then is a honeycomb appearance. And each of them are having specific answers. So let's quickly revise them. The first two, the answer is bronchiectasis. For galaxy sign, this would be sarcoidosis. And for honeycomb appearance, it would be ILD, that is interstitial lung disease in a patient. So these are some common aspects to be remembered. Additional MCQs, tram track appearance in pathology for kidney biopsy is a feature for MPGN, that is membranoproliferative glomerulonephritis, and tram track appearance with respect to a CT head. This is for neurocutaneous disorder that has been discussed in this part of the discussion only with respect to Sturge-Weber syndrome. Coming to the next slide, you can see this is a male patient who's having a presence of low backache. Whenever you read about an old man with backache, it is obviously to be thought of in multiple myeloma and prostate cancer. Young guy with a backache and especially presence of sacroiliitis. And secondly, you can notice the characteristic bamboo spine in the patient. So the disease that I'm talking about here is ankylosing spondylitis. Though I'm very sure you have read this disease in orthopedics also, I'll try to do my part here. The highlight of this disease would be a young male who is coming to you with low backache, which is due to the following aspects that I mentioned. You will be taking daily painkillers also, and even morning stiffness as a word can be described even in this condition. Usually on physical mobility, the disability of the patient will reduce. In the morning hours, these patients might even be having ankle pain. He might tell you that when I get up in the morning, when I put my foot on the ground, it hurts, but when I walk, the pain tends to ease off. Enthesopathy and tendon involvement can also be encountered in these patients. The main reason why we're discussing this disease in internal medicine is because of the fact that this condition could one have a cardiovascular association, that is valvular aortic regurgitation. The lung involvement of this condition would be extra parenchymal because the chest wall stiffness will occur, so costochondral joints will become stiff. So extra parenchymal lung disease can occur in the patient, that is extra parenchymal restrictive lung disease will develop in the patient. Why? Because there would be stiffness of the chest wall of the patient. Because of the stiffness of the chest wall, when you ask this patient to exhale, he cannot exhale like normal. So amount of air going out of the lungs will be lesser, and you know that if the amount of air going out of the lungs is lesser, residual volume will be increased. Traditionally speaking, residual volume reduces in restrictive lung disease, but in extra parenchymal restrictive lung disease, the residual volume of this particular individual would be significantly increased. Due to involvement of the back of this person, you will notice that patient might be having findings of Schober's sign. The mobility of the spine would be reduced, and you would check for the mobility of the spine of the individual, which would be affected. Only thing I want to say is that there's another disease in which the mobility of the spine can be affected, and that is alkaptonuria. They had given a situation where an individual was having urine turning black on air exposure, and then Schober's sign was given in the patient, that is stiffness of the back. Now obviously that would not be ankylosing spondylitis. As I said, urine turning black on air exposure plus Schober's sign, that's because of osteoarthritis of the spine. Black vertebra is a feature in alkaptonuria, which is homogentisic acid oxidase deficiency. For ankylosing spondylitis, for diagnostic purposes, obviously HLA-B27 positivity is required, but the point is that HLA-B27 positivity can be seen in other conditions also. Juvenile rheumatoid arthritis, ulcerative colitis, Rr syndrome, or Rr की जगह पे he might write the word reactive arthritis. So the point I'm trying to make is that HLA-B27 positivity alone is not sufficient for diagnosis of this condition. So if he says what is the preferred imaging modality, that is the main question that I want to highlight. If he says what is the main imaging modality for diagnosis of ankylosing spondylitis, your answer is MRI. We will be doing an MRI of the axial skeleton, and an MRI of the spine of the patient, MRI of the pelvis of the patient will reveal an early finding for this patient, and the early finding for this patient is presence of bone marrow edema. Very surprising. but that's the word. The early finding in this patient might be evidence of bone marrow edema. So MRI spine is able to pick up the disease earlier. In fact, one of the most important criteria for diagnosis of this condition is MRI spine showing a bone marrow edema. HLA-B27 positivity, as I explained to you, is not sufficient for diagnosis because it is encountered in other medical conditions as well. For management of this patient, physiotherapy is important, rehabilitation of the patient is important, but one of the drugs that is used in medical management and should be remembered is infliximab. Though we use infliximab in ulcerative colitis and Crohn's disease also, and even in rheumatoid arthritis, but infusions of ankylosing spondylitis, and especially degenerative spine disease, which causes loss of even height of the individual and maybe a abnormality in the appearance of the patient might be bent forward like that, kyphosis might be prominent. For that, you will have to use infliximab for the patient. These are details for costochondritis and low backache. Also, I want to highlight the fact that if you read a question that talks about low backache, especially in a young individual, then the first differential that you have to consider is obviously PIVD, prolapsed intervertebral disc. Another one is obviously ankylosing spondylitis. In old people, low backache, which will require a painkiller daily, prostate cancer. For a female, obviously breast cancer, and then multiple myeloma are some of the important differentials which have to be kept in the mind from the exam perspective. And if they give you a X-ray finding or a MRI finding, then obviously we are able to identify, and ideally in all these age groups, MRI spine would be giving you clinching evidence right away, because MRI spine will show you secondaries. It will show you lytic lesions or multiple myeloma. It will show you radiculopathy, the disc compressing on the nerve roots or disc compressing on the spinal cord tissue of the patient, or bone marrow edema of ankylosing spondylitis. So MRI spine would help you identify the lesions in the patient. Okay, coming to the next slide, guys. An important part from rheumatoid is cryoglobulinemia. Always or indirectly there's a question on it. One, they ask you always the cause of cryoglobulinemia, the most important cause, and that is to be remembered is hepatitis C, where cold antibodies can be triggered. And what will these cold antibodies cause? They can be causing development of Raynaud's phenomenon, where if a person will put his hands in cold water, the fingertips of the fingertips of the patient will change color from white, blue, and red. So just remember, though otherwise, it can be associated with HIV, it can be seen with hepatitis B, Sjogren syndrome. So the list is pretty endless, and you don't need to, in fact, go into the specifics of it. But 2 points I want you to remember is cryoglobulinemia is related to hepatitis C, Raynaud's phenomenon. Worst come worst scenario, the cryoglobulins could trigger development of stroke in a patient. The antibodies could cause thrombosis and triggering of the clotting system, and therefore stroke manifestations could be seen in the patient. And cryoglobulins will also contribute to hyperviscosity. Antibodies are being formed, no? So the gamma globulin component is increased, and hyperviscosity itself is a trigger for development of stroke, because if there is a hyperviscosity in an individual, then the brain circulation will become sluggish, and the sluggish brain circulation can contribute to development of stroke in an individual. Coming to the next slide, guys, we'll quickly have a look at the joint fluid aspects. Like the normal fluid volume is about 3.5 ml in the knee joint. Cells are less than 200. There is obviously no bacteria present. Neutrophils may be present. Clarity is obviously transparent. The fluid is for lubrication purposes. But look at septic arthritis. In septic arthritis, obviously the volume of fluid will be increased. It will be opaque on aspiration, and you will notice that on culture, obviously you will grow organisms like Staph aureus, and more than 1 lakh cells might be present. But when it comes to gout, when it comes to acute gout, the fluid might appear again translucent to opaque, but the number of cells will be usually between 2000 to 75,000 cells, and most of them would be neutrophils in a patient. So most of the time I want you to remember that if the counts of cells are in excess of 1 lakh, then it is usually in favor of septic arthritis. Whereas if the fluid is I would say translucent to opaque, and there is like up to 2000 to 75,000 cells, no culture positive obviously, then you have to think in terms of diseases like gout, acute gout, rheumatoid arthritis. Those are obviously inflammatory situations that I'm talking about. In acute gout, the investigation of joints is joint aspiration. And the main drug that is used for management of the patient is indomethacin. Allopurinol is contraindicated in patients of acute gout. For management of these patients, aspirin should not be used. In fact, the question is which painkiller or NSAID is contraindicated in these patients. So it is aspirin that is contraindicated because that increases the uric acid concentration in the joint space. If indomethacin allergy is there, if person is having NSAID allergy, that even steroids can be used to reduce the inflammation in the joint of the patient. But we are not supposed to give aspirin and allopurinol to the patient. Then can be the aspect of chronic gout. In chronic gout, you obviously need to check for the levels of serum uric acid, which will be increased, but then you will be checking for 24-hour urinary uric acid in the patient. When you check for the 24-hour urinary uric acid, there could be two possibilities. Either it could be elevated, that means he is an overproducer of uric acid, so you would tell him no non-veg for you. I mean, meats etc. should not be allowed in these patients. But if he's an under excreter, you know that uric acid is excreted via the tubules of the kidney, then the treatment part will change. If he is an overproducer, the main drug to be used is allopurinol. The only disadvantage is that if the kidney function is deranged, you might have to use alternative drugs, but otherwise allopurinol is the main drug that we are using for our patients. For under excreters in a patient, you have to remember that the drug that would be recommended for the patient is probenecid. So for chronic gout, obviously, because even kidney stones can develop in the patient, they can ask you about the therapeutic treatment. And for acute gout, I think that's very simple. Don't bother about it. And septic arthritis findings would be very gross and translucent to opaque fluid would be seen, mostly opaque, and the cell counts will also be very high. The next question that I want you to remember is that if he says which is the most frequently detected antibody in scleroderma, then the most frequently detected antibody in patients of scleroderma is not to be answered as anti-topoisomerase antibody. The most frequently detected antibody in the patient should be answered as anti-nuclear antibody. As you can see that the incidence of anti-SCL70, that would be, if you just look at the mathematical values, 95% for anti-nuclear antibody, and anti-SCL70, that is anti-topoisomerase antibody, the percentage is only 33%. So this is the table that is given in current medical diagnosis and treatment, which I basically want you guys to understand that for SLE, obviously nobody has any issues. No, anti-nuclear antibody is the main diagnostic antibody, but look at the surprising figures for Sjogren syndrome, scleroderma, and Crest syndrome. For all of these three disorders, the commonest antibody detected is not anti-CCP, not anti-topoisomerase, not anti-centromere antibody. It is anti-nuclear antibody. The learning is like this. If the question simply says, what test is done to identify patients or diffuse scleroderma or the most differentiating antibody for this condition, then for diffuse scleroderma, the main antibody to be done is obviously anti-topoisomerase antibody. However, if he gives you localized disease, however, in the MCQ, if he gives you a situation of a limited scleroderma, diffuse scleroderma will be having 11 clinical findings. Limited scleroderma is going to be like Crest syndrome, where you have calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Then in a limited scleroderma in a patient, the antibody that we used is called as anti-centromere antibody. These are specific antibodies for diagnosis of this condition. For rheumatoid arthritis, the main antibody is anti-cyclic citrulline peptide antibody. The language of the question will be most frequently found antibody. In patients of Crest syndrome or scleroderma is And as I've taught you, the answer would be given as anti-nuclear antibody. That's the main focus why I've shown you the table. Why is this so? And I'll just zoom in the table so that you can just look at the ANA values for each one of them. Even in polymyositis, no, you can see up to 80%, but values in excess of 95% is what we consider. 95% is taught even in PSM for the p-value confidence interval. So I can say the fact that the most detectable antibody, commonly detectable antibody for S-Jogger and diffuse scleroderma and CRUS syndrome should be answered as anti-nuclear, and obviously the remaining antibodies will help you in diagnosis. In fact, REMAT is all about antibodies, man. If you get the antibody name right, half the MCQ can be solved even with the name of the antibody itself. Coming to the next slide, you will notice that this lady is having a very characteristic rash around her eyelids that is called as a heliotrope rash. This would be a reddish to violet rash that would be seen on the skin of the upper eyelid of the patient. Then you will notice that on the knuckles of the particular patient, there is a presence of hyperkeratosis. This would be called as Gottron papules, which is again a term which is very characteristic and helps you in narrowing down the diagnosis of this condition, that is dermatomyositis. You can also notice that in this person there is a neutrophilic infiltrate which is present around the muscles. The myofibrils are infiltrated by neutrophils. There is a perifascicular neutrophilic infiltration, and then you can also notice in this patient, if I just zoom in, you will notice the cracking in the hands of this particular individual, like a car mechanic's hands. I would like to highlight the fact, like in a car mechanics, in a case of a car mechanic, because they will come in contact with engine oil and grease and lubricants, etc. So those are obviously abrasive material. So there could be cracks in the hand of an individual. The same manifestation is what I've highlighted here. Mechanics' hands are seen in patients with dermatomyositis. So the entire presentation that is given here are clinical features which are to be remembered for dermatomyositis. The bad news for a lady of dermatomyositis is that there is increased risk of cancer, of malignancy in these patients, especially ovarian cancer or genitourinary cancer is increased in this patient, unlike polymyositis, where you will not be having any of these skin manifestations, only muscle involvement will be present. So if you are gonna have skin profile which I have just shown you, heliotrope rash, Gottron papules, mechanics hands, and presence of a proximal myopathy in a patient, then you have to think in terms of dermatomyositis, where the risk of cancer is increased in this order. The skin profile is, I repeat again, mechanics hands, heliotrope rash and Gottron's papules. Then is proximal myopathy, difficulty in climbing stairs or difficulty in combing of hair is a term that could be usually described in the multiple choice question for this particular patient. In the workup of patients of dermatomyositis, CPK-MM will be elevated because muscles are involved. Anti-nuclear antibody will be positive in even patients with dermatomyositis in 80% cases. One of the antibody that would help you in identifying the disease is anti-Jo antibody, and people having anti-Jo antibody also have concomitant interstitial lung disease. So lung involvement in patients with dermatomyositis could be interstitial lung disease. Anti-Jo1 antibody increases the predisposition. If they say what is the best test for diagnosis of this condition, it would obviously be a muscle biopsy, and ideally this muscle biopsy should be CT or MRI guided, because wherever the muscles are exhibiting a wasting and the muscle mass is reduced, if you take a biopsy, because if you take a biopsy just like that from any muscle, you might miss the area of the myositis. So especially proximal muscles would be scanned if you're noticing wasting of muscles, and then you take a sample from that, you would be getting this image that would be presence of infiltration, I would say fascicular or periskeletal muscle fibers. There would be neutrophilic infiltrate present, which normally is obviously not there. For medical management of this patient, it is symptomatic management. Steroids can be given for lung involvement. Obviously aggressive management in the form of azathioprine would be required, but the main concept is that if you remove everything here and if you are having only muscle involvement in a patient, that too proximal myopathy, then it should be thought of as a possibility of polymyositis in a patient. Then how would you differentiate this from inclusion body myositis? Inclusion body myositis myositis will not, obviously you need a biopsy for inclusion body myositis, but clinically speaking there will be a asymmetrical muscle weakness or asymmetrical muscle involvement, unlike polymyositis which is symmetrical and proximal. Asymmetrical muscle involvement is a feature that is seen with inclusion body myositis, where obviously the diagnosis would be confirmed by doing a biopsy, which would again be MRI guided. Asymmetrical would mean like the hand muscles would be weak, shoulder of the right side would be involved, and ankle joint of the left is involved. So a patient feels unstable in the left ankle, and therefore while walking, like it's a female, she has difficulty in walking while with high heel sandals. So she says, I feel as if my ankle will twist, and there's a lot of times she says only my left ankle twists. That's big, maybe because she's having weakness of the muscles of her left ankle joint, which could be a presentation of inclusion body myositis.